Dear colleagues, we are opening this Congress. It is the 34th International Congress on Diagnostics and Therapy of Gynecological Disease with an endoscopy course. Now, from 8 to 10 a.m., we shall hold an international course on endoscopic surgery. This course will be hosted by Professor Arnaud Vattiers, head of the gynecology department at a clinic in Dubai, Professor Philip Connings, honorary professor of G&O of Leuven University, Oxford University, UK, and Catholic University of Rome, Italy, Professor Mario Malzoni, director of the Center of Expertise in Pelvic Surgery and Endometriosis, Dr. Armando Romeo, head of the Project of Research and Educational Center of Turin, University of Torino, as well as members of the Department of the Center for Gynecology and Obstetrics, Doctors Irina Felixovna Kazachenko, Alex Iranovich Arakilyan, Andrei Vladimirovich Kazachenko, and Bykov Anatoly Gennadievich. And the head of this course is myself, your humble servant, Leila Vladimirovna Adamyan. The Congress will be officially inaugurated at 10 a.m. sharp Moscow time. Could we please have a video film that we made? Could we have it up, please? No, could I have a video film that was just on? Could you please put it up? In charge of this course is academician of Russian Academy of Sciences, academician Leila Vladimirovna Adamyan. Music, background music. Laparoscopic and hysteroscopic in operative gynecologist. Dear colleagues, We are right now about to start our course on endoscopy. Endoscopy course will be held dedicated sessions for robot surgery, intrauterine surgery, use of surgery energies, and suture materials. As already mentioned, this course will be addressed by Professor Konings, who is now staying online. He can see and hear us. I hope Professor Malzoni, Professor Arnaud Vattiers, Professor Romeo, and other distinguished speakers. May I first, without further ado, if Professor Konings is now online, may I suggest he should start his presentation now. Could we please ask Philip Konings? Philip Konings, do you read us? Professor Konings, can you please start? Can you unmute your mic? Professor, your mic is muted. Your mic is muted. Philip, do you read us?
Good morning, Professor Adamian. I am opening my presentation. Hello. Should I start?
Please do, dear Professor, please do. You are about to start this session. Further speakers and professors as experts will be introduced. Please, you have the honor to begin this session. Thank you, Professor.
Okay, please. I have 20 minutes to be sure.
Yes, quite so. Please begin.
That's it. Good morning, everybody. I am happy to see Professor Adamian in good health, energetic like always, and it's a pity it's not in Moscow. I hope it is the last time it should be online, unless in between. Use of energy, I think energy is one of the essential parts of endoscopic surgery. This we can, first strategy, you have to know how the material works, and the strategy is for Professor Vattiers. This is how to do the surgery. The tactics, how to use the weapons. The whole story of energy is a story of temperature. And this temperature can be because of electricity, because of mechanical, because of laser, whatever. Temperature is energy over time and volume. And these are the classic things. 1 calorie is 1 millimeter, 1 degree, 1 watt, 1 joule. But this is not the most important aspect of temperature here. 60 degrees tissue damage, 80% coagulation, more than 100 degrees, it's boiling. Is it slow? You have desiccation. Is it fast? You get carbonization because you're going to destroy the proteins. The electrosurgery equipment has only watts and effect. And effect is voltage. I'm going to explain this. Electrosurgery, you know, is an alternative high frequency current. And there is a peak voltage, which is essentially important. I'm going to try to explain this. Simple electrosurgery is like water. The intensity is right proportional to the voltage. The higher the water falls, the more energy, and is inversely proportional to the resistance. If there is a resistance, there's less water. It's very logic. But it may, and then you have watts. The two only formulas you have to know is voltage times energy is the energy you have. You can have the same energy with a high voltage and low intensity, or with a low voltage and a high intensity. It's just a product. That's what they call the isowatt curve. Same thing, voltage, watts, intensity. And this is the surgeon's choice. Your device only has voltage and watts. And if you have voltage, you have resistance. This is because it's a wet tissue. There is no resistance, which means that the resistance is the area of contact. So if you have a point, you have a small area of contact, which means low intensity. If you have a large area, you have a high flow. And this can have exactly the same energy. This is the most important slide. You preset your voltage and you preset your watts. If you have this with a very small area of contact, you use a little bit of the preset watts, but the voltage remains the same. And then a little bit more, you use more. And then you see from a certain point, when you have more area of contact, you have the same energy, the same watts which I use, because this is preset, it's limited, and therefore the voltage decrease. I think this is very important. Small contact area, low intensity, which means that 30 and 300 watt setting has exactly the same effects. In high energy area, in here, that is important to the watt setting, which in fact becomes a safety it's a safety area. Okay, so you can have this kind of alternative current. The second point you have to remember and know, below 200 volts you have no sparks. Above 200 volts you always have sparks, and the higher the voltage, the higher the sparks. Electric bistoury has two edges, the flat and the sharp edge, which means that it's a compromise. If you have this kind of electric bistoury, you have a series of sparks which works continuously. In correlation mode, at that moment you have a small bite and superficial. And if you have, let's say, 250 volts, like we normally use, at that moment you are going to have small sparks and some cutting. And if you have a big bite, at that moment you are going to have no more sparks and you have a coagulation. What is a spark? A spark, heat is the air, and we are going to come to this a second later. It heats the air to 2000 degrees, which means you have an explosion of the superficial cells. When your intensity goes up, you have still after the spark, the cutting spark, you have some energy left, which means that you also have coagulation. So high, this is the mode. Before they use this, this is cutting current and this is coagulating current, but it means you have a higher voltage. You can have the same energy over time by having intermediate pulses. Soft coagulation, it means that since the energy is stopped by the vapor, it means that with soft coagulation, if you want to coagulate deeper, you have to have slower coagulation. Slower is deeper, lower intensity, higher contact area. Same thing for bipolar. So the tissue effects varies with the voltage. High intensity, fast cutting, and it's the choice of the surgeon how to use cutting and coagulation. And after all, I try to explain that something like 30-35 watts at a voltage of 250 to 300 volts is an ideal setting. The lower watts is only a safety measure. If you make a mistake, at that moment, you are not going to cut too much. Capacitive coupling, this is used in a lot of bathrooms, transmission of energy without direct contact. This is when you have an alternative current here and some kind of isolation in the wall. That moment you have capacitive coupling. You have, these are the special things of bipolar irrigation, bipolar cutting with sparks. I try to explain this. So you have the intelligent electrosurgical devices is the PK system and the ligature. If you control the pressure, you can control exactly the temperature to 80 degrees, and then you get sealing. Modulation of electric wave, I am not sure it works. Ultracision devices, there you have mainly a mechanical and a friction and energy, and the nice thing is you have much less lateral spread. For the rest, it's a perfect device. 2 words about CO2 lasers. CO2 laser is light amplification by stimulate emission of radiation. There's nothing specific about laser light, it's just light. The molecules here make the wavelength, and the laser beam is going back and forward between 2 mirrors. And if then you open a little bit the mirror, you let the laser escape. Remember, laser is an electromagnetic wavelength. This is non-visible in a large area, and only this part is the visible light. But when you go to audio waves, TV waves, when you go to cosmic X-rays and so on, it's always an electromagnetic wave where we only have this kind of wavelengths. And you see already argon is in the green area. You have the red helium nail layer, which is red by definition. And then you see the CO2 and neodymium, they are 1084 and 10,000, which is near infrared. It's already it's beyond the infrared, and it's non-visible light. But the quality of a laser depends mainly on the wavelength. Wavelength is light, so you're not surprised there is reflection, like on a glass, and you can have transmission. And when you have transmission, when it starts to penetrate, you can have absorption. That's all that is about laser effect. You see, if you absorb everything superficially, you have a high temperature. If you have less absorption, then you have a deeper penetration. This depends on the wavelength. And the most important thing there is that CO2 has virtually no absorption, which means it only has a superficial effect. Same thing like the excimer lasers. The argon is intermediate, is no longer used at this moment, and I'll explain in a second. And then the KTP and the neodymium yak, they have less absorption. This is the reason they are much more hemostatic, but all cutting you can do with it is preceded by a cone of heating and tissue destruction. The hocus pocus of a laser, you can have this in continuous mode. You see, if you're ironing, you leave it on the table, you're going to heat everything underneath it progressively. You can have the same energy, let's say what they call chopped wave, intermittently. And then you can have super pulse, high peaks in a short time, but over time, it's exactly the same. Difference is this can cool in between, and if it can cool in between, you have less penetration and you have less destruction. So since there is a lens before it, you have this kind of focus. So if you are in focus, you have a spot diameter of less than 1 square millimeter, which means you have a very high local heat. If you go in defocus, at that moment, the spot diameter is much bigger and you have a much lower power density. Penetration, I said already, this is volume, and this determines the characteristics of a laser. You can have a large area by using a high power laser, an 80-watt laser. If you only have a 50-watt laser, at that moment you have to have a machine in order to move the spot diameter around. Last thing you have to know about a CO2 laser is that we have insufflating with CO2, which means that CO2 gas is the resonance frequency of a CO2 laser, because it's made with CO2 gas, which means that if you have in the tube no circulation, you are heating the CO2 and you have a blooming of an opening of the wave. Last thing you have to know, and this is for the argon laser, if you have a wall with red and green tiles, that's what they call complementary colors. This is red because it reflects the red light. If you're going to shine on it with a red lamp, then all this red light is going to be absorbed and just reflected by the others. You only see the odor of tiles. The difference between electrosurgery and a laser is that if electrosurgery is energy is a contact area and stop is no contact, which means that if you go over it, you can cut to the same depth. If you go over it with a laser, you're going to have the same destruction over the same area. If you stop electrosurgery at that moment, stop moving, at that moment nothing happens, but there's no more contact. If you stop moving a CO2 laser, at that moment you're going deeper and deeper and deeper. This is the reason why it's a totally different way of training for CO2 than for electrosurgery. Laser surgery needs specific training of the surgeon, of the assistant, because since the surgeon has two hands, one the laser and one most of the time an irrigation probe, at that moment the assistant have to do the coagulation. The advantage is you can do it with less puncture. You need smoke evacuation, and which means high flow insufflation, which means you need a setup in order to use a laser correctly. You can do it with two. We did hysterectomy long years before with only two secondary puncture. If that's important, I just let you decide how important this is. Conclusions: electrosurgery is the most versatile. CO2 laser has specific advantage for superficial ablation while being fast, has a disadvantage of having little coagulation property, and ultrasonic scalpel has theoretical advantages, but is less versatile. Conclusions: surgery is tactics and strategy. The tactic is the choice of the instruments to exercise and understanding them. Electrosurgery is a history of voltage, history of Watt's testing, and this is mainly a precaution, a safety. That's why you can use them both to coagulate and to cut. You're going to see this during live surgery. The surgeon uses the contact area to modulate intensity and voltage. This is the flat and the sharp of the electrical bistoury, and the steam stops the current. And today we have intelligent devices which are needed because fat or is not electricity is not going through fat. That's why it's less useful for the epiploon, and that's why we need these kind of sealing devices, especially for bowel surgery and epiploon. Thank you for your attention.
Leila. Leila.
Dear Professor Connings, thank you so much. Please stay online because there will be presentations of our experts, and then we'll have a chance for discussion Before I introduce Professor Arnaud Batiez, please put on a brief video reflecting our joint work. Thank you so much. Dear friends, well, we decided to put on this video showing what has been done in the field of endoscopy, the Department of Operative Gynecology courses on laparoscopy, together with our foreign experts and colleagues. Starting from 1991, we have been conducting these wonderful summer congresses. We've had 33 of them. Today is the 34th, and we've also had 15 winter congresses. This team has always been with us. Before I give the floor to Arnaud Batiez, who is waiting for us, well, it's a pleasure to see all of you. And I'd like to say that at the Kulikov National Center of Obstetrics and Gynecology, we organize courses on laparoscopy, hysteroscopy. We organize lectures, seminars. We broadcast operations, and please sign up for our courses in the Simulation Center. That's in your curriculum. Now it's a great honor for me to give the floor to the co-chairman on our endoscopy course, Professor Arnaud Batiez. Arnaud Batiez has been with us since the first congresses. He's a great surgeon and endoscopist. He's a philosopher in operative gynecology. He's the key person in Strasbourg, and right now he is in the Middle East. Arnaud Batiez, please, the floor is yours. Say a few welcoming words concerning this Congress, this course, and the theme of the presentation is key points of laparoscopic surgery, ergonomics, energy choice, complications. Arnaud Batiez is the head of the Gynecologic Department, Latifi Hospital, Dubai. Arnaud, the floor is yours.
Thank you, Leila. I hope you hear me well. Sorry for the connection problem at the start. And as you said, I think that education and courses are very important for people. And usually when we do courses, I always do this kind of lecture. So it's always almost the same message, but as we say, we are going to discuss about strategy, etc. So before I jump on my talk, and I will try to do it quite fast because time is limited, but give you some flavor at least. I would like to thank you, Leila, for the kind invitation. Obviously, I regret not to be in Moscow. You know that this June meeting is a landmark, is a key, is a milestone in our life since, as you say, more than 30 years. And the beauty of this Congress, beside all the friendship between us, is that we teach people as much that we learn from others. And I'm sure that our different career would not be same without these meetings. So thank you for your energy and thank you for your commitment. And thank you for the opportunity of doing this lecture. I'm very glad that finally, you know, that I talk after Philippe. And I'm very glad that he put the last slide he did about the strategy and the tactic, because I really are in phase with what he said, and I think you will understand why. So this is what I call the surgical rule, and I always start by this slide that I have presented. I have presented. You have my slide, by the way, because I see my face but not my slide. So if someone can tell me if you see my slide.
Yes, I can see the first slide called the surgery in the middle, and we can see the slides.
Okay, so thank you. No, just because I don't see it myself. Okay, it's fine. So I put this slide since very long, and I put a lot. The aim of that slide was to show that to be a surgeon, you have to get a lot of, let's say, qualities, among which ability is only one. And then you know that normally when you are a surgeon, you are supposed to be habile. But what I want to see is probably the least important quality of a surgeon compared to courage, curiosity, imagination, etc. So this is the first message of this: to be a laparoscopist, a minimal invasive surgeon, no need at all to be habile. And so my second message is that what we do in surgery is very basic. And that we say we coagulate, we cut, we stretch, we push, we pull. And at the end of the day, all those movements are very basic. But this is the way when you are going to coordinate them, associate them, in which order that will constitute the art of surgery. And this is where the slide of Philippe is totally correct. And this is the cumulation between strategy and tactics. And it's very important to look at the etymology of these two words, because they are very different and should be associated. I cannot resist to show you this this painting that because I took this picture in Moscow in the Tretiakov Galleria. And I was fascinated by the look of this young lady on the painting, and I was telling myself, how does this painter to give me this impression? So I come very close, and as you know, because I have presented this slide in Moscow last year, I think, and I just realized that when you look the eye from very close, those are very simple things. So the deepness of the sight is just given by this white line. And so I think this is amazing. And this is, I say, this is what we do in surgery. We do very basic things, but at the end, the result of what we do may be considered like an art. And so it comes to laparoscopy, which is very specific. And it took us years to understand that everything was turning around anatomy. And why is this like this? Is because the way we see the anatomy by laparoscopy is not only precise, it's very particular. It's really something you cannot see by laparotomy, you cannot see vaginally. And so then start a problem, because you see much more. And I will come to this, but if you see much more, you should know much more. And this is our problem. So to conclude this first step, remember that surgery is mainly in your head. Is an intellectual act, it's not a manual one. And so we have to be ready for it. And we have to be ready and we have to use our brain. So it means that we have to feel correctly or to make correctly the brain of the young people to help them to think. And so it starts like this by laparoscopy, that laparoscopy don't give you cosmetic advantages, don't give you pain advantages, don't give you social advantages. Laparoscopy gives you a vision which is very different and is not, you don't look, you see. So it means that you have an intellectual act beside the optical fact. And so that allows you to shape what you look at, what I call shaping the information. And that makes that your work, the quality of the work is enhanced and homogenized all around the place you work. And so those are the advantage of laparoscopy, and that leads that the main advantage of laparoscopy is we do better for our patient. And that's why we do it. But in order to get those advantages, we have lots of inconvenience. And this is what we talk. We have a lot of problem of ergonomy. We have a problem of productivity, fatigue. We should learn suturing. We should learn energy, as Philippe beautifully did before. And so again, we have to be prepared, and we need strategy and we need tactics. And so to come to what Philippe said, that it's very important to always update your knowledge, because the skills from the past are contaminating the environment of the present. And so if just to give you some very simple fact, when we started to coagulate the uterine artery for doing a TLH, people was criticizing us because at the time it was using clamps and suture. And now it's okay. So for years, the fact that normally you do not coagulate the uterine artery was, slowing the process of the adoption of laparoscopy. So the first thing that you should have when you do laparoscopy, you have to get an open mind. So it means you should think outside the box, and you have to remember this strategical place of laparoscopy where all the understanding is important. So when you start laparoscopy, the first thing you should do, you should look and not touch. And this is very important because you should look, you can manipulate, you can expose, you can look right, left, and it is very important to see if your findings that are confronted to what you know from the patient correspond to the discussion you had with your patient, the consent you obtained from the patient, and the information you have given. And then comes the strategy. Once you have understand, comes the strategy. And when you have the strategy, you may have a tactic to apply it. And so this is where we come back to surgery. And these slides, surgery is a recombination of these three things. I recognize the structure by dissection. I control the structure mainly doing hemostasis, and then I act on the structure mainly by doing section or by doing suturing. But I mean that recognition, control, and action are the key words in surgery. And I will do all my talk about this, about dissection. Dissection, comes from Greek and means that to cut off. So it means that is linked to anatomy, that anatomy means the same. So anatomy and dissection are linked, and this is obvious because if you want to recognize structure, you have to separate them. And so it becomes the most important step in surgery because it decreases the amount of uncertainty before you apply a definitive act. So before you coagulate what is in your bipolar, you want to know what is inside the bipolar, and you want to know where is the ureter, for example. And so this is, if you have dissected before, the uncertainty to get a burn of the ureter is reduced. And so that gives you a lot of advantages. You make better decisions, you reduce the margin of error, you use the energy precisely and limitedly, you increase the global safety of the patient, and you increase the predictability of the results. And so dissection means that you separate structure that by definition you should recognize. So it means that you know them up front, and your capacity of dissection makes you what I call a predictable surgeon. And I always tell that if I have to get surgery on me, I want to have it done by a predictable surgeon. And so what it means, predictability means that the expectation happened. And so we want to be a predictable surgeon. So what are the rules? And so this is always the same. One day they say, what are the rules of dissection in laparoscopy? I thought about it and I say, well, look, the first rule is to know the anatomy. And so everyone understands. And then I say, look, if you know the anatomy, then use it. So second rule, use the anatomy. And last rule would be, okay, if you know the anatomy and use it, why you should lose it? So don't lose it. And so looking at the strategy and the tactic and the technique that way, we have the opportunity to apply and to understand the rationale behind what we do. So let's see, know the anatomy. So you know anatomy is leading everything, and you learn the anatomy in the book, and laparoscopy is probably the best tool to observe it. And if you do surgery, you have to dissect it. And so you have to know what is important. So just as an example, when you look at the ureter, which is our classical friends or enemy, I mean, the ureter, you should know what? You should know its microscopic structure for knowing where is the distribution of the vascularization inside the ureter. You should see the position at the ureter when it goes into the pelvis, and you should see the way of the vascularization to learn to dissect it. So ureter should be identified always during surgery, and especially in the pelvis. And so you have to know all those things. So it's not, I will not go in the anatomy, but remember that you just recognize what you know. And so the story is the same. I have cut a lot of right hypogastric nerve because I didn't know what it is or what it was. And since I learned what it is, I don't cut it. And so this knowledge of the anatomy is very important. And we can, so I call that the science of the landmark, the science of the anatomical landmarks. And so we organize a course with Miss Academy on that. And so when you know these landmarks, you have to use it. And then we come to the dissection part. And what means using it is, for example, I always take this example of the bladder. If the bladder is a mobile organ, so if you pull on the peritoneum, you will let the bladder down. So you have to pull on the bladder itself. And this is a general rule. So here you have the video. So the surgeon shows the bladder is entity to the assistant. The assistant lifted the bladder, and look what happened. You see the famous bubble. I will come back to this. And you dissect in the plane. And this is true for the rectovaginal space. It is true for the parietal space. It is true for the paravesical space. You have to separate the limits, the landmarks, to develop a space. And so as we have a limitation with laparoscopy, we have to overcome our limitation. And how we do that? We do that by exposure. And this is very important. Exposure is not only Trendelenburg. And then we have to use small things that I described, I think, already when I do the course in Moscow. Just to go very fast on that. Exposure, what it brings to you. You free the assistant that become helpful to you. You free your hand as a surgeon and improve the working area and vision. And again, better information, more precision, better use of energy, improve surgery, saving the time with a better performance. And so this is what we want. And so if you work with one hand, this is what you do. You know, you can push and look if the ureter works. This is only what you do. Then if you use some system to help you, so you fix the ovary to the wall, for example, using T-lift of suture, this is now what you can do. You know, the hand of the assistant is free. Your two hands are free. The assistant can help you moving from right to left. And you can make deep dissection. And here, for example, recognize the first sacral root. So this is very important. This is what you can do. You can dissect the parietal space with your two hands, which give you safety. So you have two hands to dissect, simple movement, because the two hands are free. And so we use all this. And then we use divergent forces, white line and bubbles. White line are those tiny lines that you see. They are the condensation of two planes of tissue. Here, the sigmoid, you see the white line. The white line is the fusion between parietal and visceral peritoneum. If you stay down the line, you stay into the cavity. If you stay over the line, you go in the retroperitoneal space. So we use that. We use the fat. The fat is your friend. And so you should know to what the fat belongs. Here, this is the rectovaginal pouch, the Douglas pouch. And you know that the fat that you see belongs to the bowel. So the plan is lateral to the fat. So if you want to see and you see the bubbles, you are lateral to the fat. In difficult condition, here you have the rectum attached to the uterus, and you know that the fat belongs to the rectum, so the dissection plane should be not where the bipolar is, but more lateral. Here is the bowel. So you have to go lateral to it like the scissors go and medialize the fat. And so then you have the bubbles. And the bubbles is just the result of the CO2 gas push in the negative pressure of the retroperitoneal space. And it just goes in anatomical plan. So like here, we are in the paravesical space, and you see that the bubbles shows you the way. And just by stretching, and sometimes you meet some perforating vessel, just come with the bipolar. And this is important that your hands are free. You can use monopolar energy as Philippe shows. You can do bipolar. And this is a combination of vision and tactile perception. And in most difficult situation like this one, endometriosis, you find lateral to the rectum some bubbles, so you are in the anatomical plane. You find this vessel, and this is the unique one, which is here is the rectum, and you can know where is the inferior hypogastric plexus lateral to it. So we work like this. So I mean that we do simple things which are driven by very sophisticated knowledge. And then what we apply is very simple. We apply traction, counter traction. Look at this. So we are on the side, you pull and you follow with your vision. You see? You follow the breaking of the plane. If this is anatomic, like here is fine, and then you come to non-anatomical plane and you have to. And you can know the first thing you meet medial to the IP ligament is the ureter. So it's easy to find. But you don't do what you don't do, you do very systematic approach. So the breaking line is 90 degrees from the lateral forces. So you should apply the forces correctly to obtain the result that you want. And look here, penetrate the parietal space, look with a slow motion, look the direction of the breaking, look the direction of the breaking. So the breaking is always perpendicular to the force you apply. You should be slow and control your movement. And then when you know the anatomy, you can use it correctly. And when you use it, you should not lose it. And how you lose it mainly when you get bleeding. When you get bleeding, you wash. When you wash, you aspirate, and then you lose the light, the space, etc. So you lose the anatomy, and this is what we call the vicious circle. You get bleeding, you wash, you lose the anatomy. The first thing is to avoid to get bleeding. And how we do that, we implement technique if we make mistakes to avoid this, like in this case, lateral size of an hysterectomy, good coagulation on the good place of the uterine pedicle, uterine vein, good coagulation. When we think that everything is okay, we cut, and what happened? Bleeding. Look immediately what happened. The bipolar catch back the proximal part, and the scissors compress the distal part. Doing so, we have a full open uterine artery and vein on the side, no bleeding at all. So we understand that we are going to make mistakes, but we have to get in our hand the technical capacity to solve the problem without losing the time of aspiration and all subsequent problem we may have during laparoscopy. So we keep the anatomical plane, we keep the efficiency of electricity, we keep the pressure and the space, and we keep the light. And this is what we want to do. So as you understand on my talk, everything is a question of details. It's not, we speak about very simple things, but they should be applied at all the time. So it was my talk. I hope I stay on the time. Doing this very small thing, we really talk about everything. And so I think that this is exactly what was the purpose. And so I hope you get my message. And if you have any question, I'm ready to answer to that. Thank you again for the opportunity.
Dear Arnaud Vatiers, thank you very much. You are not just a brilliant surgeon as your speaker, but as a philosopher. At the same time, I have a request. When there is an endoscopy course, please do not go away. And now I'd like to give the floor to Mario Malsoni, then Romero, and then at the end of our course, we'll say a few words each. Thank you very much, Dr. Vatiers. Please put on the next video.
Dear colleagues, I'm just put up this video on purpose because my staff have just drafted it, because this has all the team, both the Russian team and our distinguished colleagues, amongst whom we have Arnaud Vatiers, Philip Konings, Mario Malzoni, Bromero, who is now with us and who will deliver the presentation every day. We are here online as of 8 o'clock in the morning, Moscow time. We are about to start this course. It is like our hallmark. It is my great happiness and joy to give the floor to Professor Mario Malzoni, who is in charge of the Center Expert Pelvic Surgery and Endometriosis, Avellino, Italy. For many years, Professor Mario Malzoni has been traveling to attend. We also went to see his clinic. We met at different congresses. We had live videos of operations, both a brilliant surgeon, and the name of the presentation is at this endoscopy course, Novel Surgical Energies, Instruments, and how to design a surgical intervention. Now we live in an era of artificial intelligence, AI, for the better or for the worse. It is being widely adopted. So both Mario Malzoni and Arnaud Vatiers are today's figures of authority who look well into the future. Mario, the floor is yours. Good morning, dear Mario.
Hi, Leila. Good morning. Good morning, everybody. And thanks for your invitation. It's a great honor for me to be part of your meeting. As always, as all years, I started my experience in your center more than 15 years ago. For me, it's an honor to be part of your family in Russia and of your meetings. So I start to share my presentation. And I start talking about the new surgical energy instruments and how to tailor our surgery with these instruments. So the relationship between surgery and technology represents the present and the future of our profession. And in the past, several new technology was proposed to surgeons. At the beginning, probably in the 80s, some surgeon was reluctant to new technology, laparoscopy, and probably underestimated the potential of the technology. Shifting after some years, and the either sharing and knowledge have changed the idea of surgery. So more technology probably represent better surgery, but it's better to consider that advanced technology and tailoring this for appropriate procedure means better surgery. That means probably better results in terms of quality of life for the patients. So in this presentation, I want to propose you some news in the instruments and technology in the last years. So the new electrosurgical units for advanced bipolar forceps, the use of the new advanced ultrasonic technologies, the use of argon plasma coagulation, the new diode laser system, and the use of indocyanine green, and the new scope like Rubina camera in oncology and in the surgery for deep endometriosis are, in my opinion, very important. So, starting from the new unit for electrosurgical and advanced bipolar, the new system of Herbevio 3 with high frequency surgery with the 4 outputs for different instruments has an automatic regulation of the power, can recognition of the instruments with an automatic correction system. So we can use at the same time the monopolar scissor, the bipolar forceps, and the biclamp. The use of biclamp, in my experience, is very important. I started the use of bipolar many years ago with biclamp, and the new advanced bipolar electrosurgery provide more consistent hemostasis with less thermal lateral spread of energy and can treat vessels up to 7 millimeters in diameter. Have an integrated adaptive control. So when the impedance of the tissue increase, the flow of energy will decrease. This is very important for this energy. And this is just an example of the use in the right hand of bipolar and advanced biclamp bipolar. In the left hand, we can use monopolar. We use the precise mode of the new Vio monopolar system. It's very fast and with very few smoke. For ultrasonic use, the system uses ceramic disc sandwich under high pressure, which produce mechanical vibration, no electricity through the patients. And we started the use of ultrasonic system technology just from 80 years. But now the new system of ultrasonic have an incorporated titanium blade, so the cutting and coagulation process occurs at lower tissue temperatures with ultrasonic energy that with electrosurgery, if we compare with electrosurgery. So when we use this system, we use, in my experience, this system in all the conditions when we want to treat the fat tissue. So in the preparation of the colorectal surgery, bowel surgery, when we have to remove all the fat tissue around the serosa of the rectum, the sigma, the use of ultrasound, in my opinion, is mandatory because you are faster, you are safer, and you can clean all the fat tissue around the serosa of the rectum for a good exposition of the serosa before to treat with shaving technique, with discoid technique, or like in this video with segmental bowel resection. So in the surgery for colorectal surgery for endometriosis is very important, and we use this system of ultrasound for lumbar aortic, para-aortic lymphadenectomy to have more possibility of movement when the action of dissection is less important. We use this system. At the same for omentectomy in ovarian cancer, in high-risk endometrial cancer, and in all the conditions when we need to remove momentum, we use this system too. So in this video, you see that it's very important, the traction, the contratraction. So to push with the rectal probe inside the rectum, and the traction of the assistant to improve the action of this system. And another important technology is the argon plasma coagulation that you can use with no contact or contact electrocoagulation technology. And ionized gas is very highly conductive, and it's important to consider that the dip of thermic effect of the argon plasma is less than 0.3 millimeter, and the lateral thermic spread is less than 0.5 millimeter, and the applicator is always cold, and there is no direct use of electricity on the patients. So in this video, the use of argon plasma in the preparation for hysterectomy, you see that the tension of the tissue is very important for the use, for the correct use of argon plasma. And we are preparing posteriorly the peritoneum for vision of the vessel, and then we use anteriorly in the vesicouterine plane in order to free the bladder anteriorly. And this is important, like Arnaud said before, to pull correctly on the bladder in order to see the bubble, to see the right plane, and to go with argon in the right plane. This is very fast and safe if the tension are correct, and if your knowledge of anatomy is correct, you can use and tailor your surgery using this system to be faster, safer, and reduce the risk of bleeding during this part of the surgery. The same you can work with the argon on the porcelain part of the manipulator. We are using the Clermont-Ferrand manipulator to finish our surgery of hysterectomy. So You see that the smoke is very few, and aspiration system of the smoke is important to reduce the smoke during this surgery with use of argon plasma, and you can finish our surgery in this system. So the diode laser system we use in the last years has a different system, contact or non-contact mode. You can use the new fibers of diode laser to cut, to do coagulation on to vaporize. It's very important for laparoscopy. You can use in treatment of ovarian endometriomas, for peritoneal endometriosis, for adhesolysis. It's important to consider that the tip of laser penetration is less than 0.2 millimeter. You can use in hysteroscopy for histmocele, uterine septum, or polyps, sometimes for myoma inoculation, but you can use for low genital tract like condylomatosis treatment, cervical dysplasia, or conization. And this is an example of the use of diode laser for treatment of small endometrioma on the right ovary, so without enucleation, in order to reduce the risk of compromission of ovarian tissue. So we decided to treat with the laser only vaporization of the capsula of endometrioma, and you can use the 5 millimeter fibers or through the middle trocar, or to the right or the left trocar. Is very versatile, and you can use in this system very fast to treat the superficial spot of endometriosis and endometrioma 2. And again, the use of indocyanine green and the new Rubina system camera is very important. It's a coloring agent that increases the fluorescent substance and works at near infrared radiation, so minimal energy in the visible spectrum. And we consider that the camera, the new Rubina camera system, it's a full HD 3D 4K camera. It's very important because it uses 3 different systems. We can have a monochromatic possibility to show the indocyanine green, the intensity map, and the overlay in 2 colors, in the green and in blue. It's important, the use of indocyanine green applied to Rubina system camera stores for surgical staging of apparent uterine confined endometrial cancer, or for surgical treatment of endometriosis, in order to detect endometriotic nodule, or in order to evaluate the vascular assessment of the perfusion after bowel resection, ureterolysis, or colpectomy, deep colpectomy. So focus of endometrial cancer, we consider that we can use this new system for apparent uterine confined endometrial cancer. So the level of recommendation 2 grade over recommendation A for the use of sentinel nodes in low risk or intermediate risk is considered by the new guidelines of European Society of Gynecological Oncology and European Society of Pathology and ESMO. So at the moment, you can say that systematic pelvic lymphadenectomy is not more recommended for this low risk and intermediate risk group of patients. So if we consider the pro and the contra of the use of sentinel nodes, you can say that the use of sentinel node mapping has less morbidity for the patients, reduction the extensive use of lymphadenectomy. low variability of staging procedure, increase with ultra staging, the staging accuracy of our diagnosis, with detection of lymph nodes in unexpected area with increasing of detection rate. At the contrary, we have only the specific training that we need and the equipment that absolutely we need to do this kind of use of technology. Where we use the tracer, the injection site, we proposed in the past these three possibility to inject in the paracervical area for detection of sentinel node in endometrial cancer. At the moment we use this injection site, so at 3 and 9, we use in the total 4 milliliter of indocyanine green solution, 1 milliliter very deep at 3, 1 deep at 9, and then 1 superficial, 3 millimeter superficial on 3 and 1 milliliter superficial on 9. So then we go to evaluate and do the detection of the sentinel, and this is our experience from in less than 1 year, 11 months. We treat 80 patients with endometrial cancer. Endometrial cancer, not only low risk or intermediate, but also high risk endometrial cancer. And this was very important results that we had if we compare the our use of standard camera that we started to use in the 1st of March 2020, and we compare with the new system of Rubina that we started to use from September 10, 2021. You see the difference in terms of bilateral detection rate that shifted from 61% to 74%, and the time of operation went to lower from 100 minutes to 80 minutes. So this is important because we don't need to change the camera from white color to the other one, but you can use the same 4K camera and use of indocyanine. So this is the vision of 4K 2D system. In few months we will have the 4K 3D vision for indocyanine green. This is a 2D at the moment vision, and this is the preparation of the paravesical plane first, and the visualization in overlay with green of the small lymphatic vessel that provide to evaluate the lymph node. In this case, the lymph node is between the external iliac vessel and the internal iliac vessel. So we do this kind of very simple preparation. Following the lymphatic, we arrive to evaluate the first lymph node. So the obturatory nerve is mandatory to check, like landmark, and then we don't need to do the preparation for the systematic pelvic lymphadenectomy, but we arrive directly at the level of the external iliac vein, artery first and then vein, and when we can separate the lymph nodes, and we send to pathologists for the ultra staging. So no frozen section, but ultra staging is absolutely important to increase the accuracy of our diagnosis. And now I want to show you the use of indocyanine for deep endometriosis in order to detect the endometriosis nodule, in order to evaluate the vascular assessment after bowel resection, after ureterolysis and after colpectomy for radical hysterectomy for endometriosis. So if you compare the white light imaging with the near infrared imaging with the new Rubina camera, injecting intravenous of indocyanine green, probably this technology can help us in order to identify the area of infiltration of endometriosis. This could be an example. The indocyanine green and fluorescence go inside the third space of the tissue, and so it seems to be very promising to evaluate the tissue involved by endometriosis. In our experience, we prefer to do a preoperative ultrasonographic evaluation for deep endometriosis, of course. So it's a preoperative diagnosis of deep endometriosis, but sometimes for very small localization of endometriosis, this system probably, I say probably, can help us to identify better the area of infiltration of endometriosis. And the use of this system could be probably is important in order to evaluate the vascularization of a ureter after deep ureterolysis, after ureter resection and end-to-end reanastomosis or after ureter resection and ureteroneocystostomy. So if this is the vision of the vascularization of the ureter with the overlay vision in green, you see all the small vessel around the ureter, and you can assess the situation at the level of the ureter after a complete parametrectomy on the left side. This is the monochromatic vision that we can use in order to check with the intensity map the area in blue where the vascularization is poor, and we can change our technique in order to reinforce the wall of the ureter, or in order to put a stent inside the protective stent inside the ureter, or we can remove the part of the ureter with less vascularization with the resection of the ureter or reimplantation of the ureter. For the bowel endometriosis, at the end we can say that the evaluation of the perfusion after surgery, colorectal surgery, could be very important, and this is an example of evaluation with the Rubina system overlay indocyanine green new camera to evaluate the vascularization with green after reanastomosis, after segmental bowel resection. You can see the green that arrives at the level of the resection line, and we can in case of not so good vascularization, we can do another stage surgery lower, or we can reinforce with the single stitch the wall of the bowel. In my opinion, this monochromatic vision is more important in order to see better the resection line and the microvascularization of this area. And so, in conclusion, we can say that the use of this new technology is very important for the surgeons in order to improve the quality of our surgery, and so in order to improve the quality of life and the results for the patient. So the purpose of technology is not to confuse the brain, but to serve the body. Thank you so much. Thanks for your attention.
Thank you, dear Mario. As always, you've shown us miracles of artificial intelligence that we use in our operative gynecology and endoscopic surgery. I request that you should also stay in line We will now give the floor to a great friend of ours, to a surgeon who has brilliant stitching technique, Professor Armand Romero, and then we'll all be involved in a very brief discussion. Armand Romero, please, have the floor, dear colleague. Armand Romero, the presentation is titled Technique of Stitching. Armando Romero is in charge of a project of a research and education center in the University of Torino, Italy. Armando,
thank you.
Now have the floor.
Thank you. Good morning. Good morning, Leila. It's a pleasure to be in your Congress. It's a great honor for me. And I will start ready. I want to share the screen. Just a moment. This one. And I share the screen. Share. I open my... just a moment. This one. Ready? It's okay. First of all, today I would like to talk about the suturing technique. And first of all, is sorry. Here. Okay, fine. Now I am ready. Okay, perfect. I will talk about a very simple question. Is important the monomanual or bimanual technique? Which is the future of knot tying in laparoscopy? I think, in my personal opinion, that before we have to define a very clearly what is the knots. One knot could be a blocking or no blocking sequence. One blocking sequence could be safe or unsafe. I want to be clear because it's important to understand that a blocking sequence is a sequence of knots, knot combination made by monomanual or bimanual suturing technique. And then we can do half knot or half each, and which gives to the knot a complete blockage without breaking the thread. This is a knot, a safe knot. This force is called knot tensile strength or thread breaking load near the knots. The knot is completely blocked and is not possible to open it. This is our target. If you see, normally the question is very clear that we have to do a combination with 5 throws because the true blocking sequence is made by 5 throws. Could be all half knot combination like this, or all half each combination, vertical combination like this one, or could be a mix, could be made the combination by half knot is the base, and then we can conclude and blocking the sequence with 2 blocking half each. At the end, we did this paper and there was a provocation. What is the best surgeon knot? And we did an evaluation of security of 2,000 different blocking sequence. And we saw a very, very nice situation. We did a new classification. We need to study the knot combination in horizontal and vertical. We need to understand what does it mean symmetric and asymmetric definition of the knots respect to the previous one. And we defined the blocking sequence and the safe knots. In this classification, we studied the minimum blocking sequence and the Romeo Gladiator rule technique to perform it. I want to introduce the main actors of this story. The DNA of all all knots around the world are made by these two gentlemen. The first one is the half knots, H, we call H, and the second one is the half H. There is a familiar because they are similar, but not the same. The behavior of these knots are totally different. When you put more half knot in horizontal way, you can combine H1, 2 throws H2, 3 throws H3. The difference between the first and the last are friction, actrite, strength. I want to say, I mean, the H1 is no strength and the tissue open. The H3, if you use, for example, in myomectomy, you make an H3, has a very good strength, and you can drink a coffee and then go back in the operating room, and the H3 is in the place. What changed when you go to the vertical area? You have to introduce, I'm sorry, you have to introduce a new concept of symmetric and asymmetric knots respect to the previous one. The first one is symmetric on top, and the other one, you see the difference between the outcoming of the thread. And the second one, in the asymmetric, the second knots is totally in the different plane respect to the previous one. And this is changed totally the behavior of these knots. For example, one double single, H2, H1A, asymmetric, is totally dangerous respect to the H2, H1 symmetric. And then who is the guilty of this question is the counterclockwise or clockwise of your needle holder in laparoscopy. And then take care, because you see here, for example, you have to if you want to perform an asymmetric respect to the previous, you will see here, we have to reinforce the knots. And it means the H2, H2 are similar for space, for surface, and are more safe than H2, H1. One double single is very dangerous. The double is a very great base. They are 4 throws, they are strong, and is not important between symmetric and asymmetric. They are strong, the same is strong, the H2, H2S is strong, H2, H2A. As you can see in this picture, when you tie, the symmetric is totally different of the asymmetric knots. And this means the asymmetric knots is more strong respect to the symmetric. It means that the monofilament, for example, like the asymmetric situation. In the monomanual technique, means that you use only one hand, right or left. If you want to perform symmetric knots respect to the previous, you have perform alternate rotation. If you want to perform asymmetric knots respect to the previous one, you will do the same rotation. This means in the monomanual technique, but you pay the bill. Because when you go with only one hand, you have absolutely to cross the hands to perform a square knots. It means the first you will perform the double knots, H2, and then you have to cross, otherwise you don't come with a square. This is a typical knots, double, single, demi-clé, half each blocking, half each. I want to say, If you perform an H2 square, is on top. If you don't cross the thread and you leave without crossing, you have S2. S2 is a very dangerous knot because it's not a fitch, it's a totally wrong, big mistake. You will see here in this short video exactly what does it means. The two-color thread will tell you the mistake. If you take here, you have a mono manual technique, you go inside and you have to cross. Without crossing, this is crossing and square knot. Without crossing, you perform S2, that is no knots. It's a bastard knots, it's a mistake, it's a big mistake, and you will continue to perform mistake. It means that you perform another one and you don't come with a good knots. You come with an half hitch in the same side with the same running thread and you perform another sliding knots. It means that all your sequences will be unpredictable. Could be good, could be open. This was the result of our paper. It's important to understand another big question when you use only mono manual technique in suturing. Here in this paper, we study the reorganization of the knots because it's a very easy to perform reorganization of one blocking. You can see here a typical reorganization of beginners. You perform H2, double knots, you perform correctly crossing, you come inside with the tail, the green one, you discross, and you can see you perform a square correctly knots. Until here, you are fine. But in laparoscopy, many times you go shortly in the tail, you pull the tail before, and what's happened? You make a big mistake. You do a reorganization of these knots that from blocking became sliding and no strength in this combination. Look at here. You perform exactly one sliding reorganization of your knots. And this is a disaster because you continue to perform another half hitch and you continue to perform sliding. Only this change save you because you change sleeping thread and running thread and you perform one half hitch with blocking sequence. I want to say, if you feel the second knots sliding on the first one together, you have to perform two blocking half hitch. Otherwise, the whole sequence is totally sliding. You can see here in the live surgery, one beginners, look at here. She will perform correctly the knots. Okay, this is fine. But now start a sequence of mistake. She takes very short the matrix. She performs two double knots and pull the tail in a very wrong mood. And look at there, a reorganization of the double and open and transform these knots in a very big disaster. It's a very important to perform a good technique. How we can avoid this mistake, this reorganization? I study along many years during the course of suturing, the beginners, fellow, and I understand at the end, after the last paper, we wrote that is a very dangerous to do reorganization, don't cross, you create a very big mistake, and the solution is in the technique. It's not important, the smiley technique, gladiator, okay, is fine to start, but the true big future challenge is by manual suturing technique. You have to teach to your fellow for the future and perform the bi-manual technique. What does it mean? It means that is a very important. We perform, we wrote a paper with Fernando Almeida Asensio, me, and we wrote the difference during suturing course with fellow between bimanual and monomanual technique. The conclusion was very, very important. In conclusion, the knots that the group of my manual suturing was a little bit more time, of course, but the 90% of the knots of the sequence was safe. In the mono manual technique group, only 30% did a very safe combination. It means that in conclusion, it's important to perform bimanual. Why bimanual? Because bimanual technique, you have no cross. You have just to start with the hand in the opposite side to the tail, but you will do always square half knot. In other words, if you perform bimanual technique, you will have always exactly half knots, very safe combination, no make a good traction, short traction in the tail. You have no, you are not afraid about the short thread. This is very important. Here you will see exactly
different blocking sequences,
the difference between the blocking sequence. You will see the same knots performed with monomanual and performed with the bimanual. The same knot,
surgical knot,
is a double, single, half each.
In this blocking sequence,
this is a vaginal cuff.
The surgeon is
You will
performing
see double knots.
half knot using the right hand.
First of all,
the needle holder comes from
you need to
above
cross.
the horizon of the thread.
Otherwise, it's a
Romeo's gladiator's knot tying technique.
Mistake.
In a
You
clockwise
cross.
rotation of the
Exactly, you
needle holder
cross,
tip.
and you
In
have a
order
square
to have
knot.
a flat knot,
And you
the
pay the
surgeon
bill.
must
You have to
apply
cross
symmetric
always.
traction on each
And
thread.
it's not
In the
so
second
easy
half knot,
many times.
the needle holder comes
You
from
perform
below the horizon of the
counter
thread,
traction,
and the knot is
counterclockwise
rotating the
movement,
needle holder
and you
in
perform symmetric
counterclockwise direction.
knots.
Symmetric traction is also
Okay.
applied in order to
And
have
then
a flat knot.
You perform
There is no
two
need
blocking
to
half
uncross the
each.
threads. In order to have a safe blocking sequence, two blocking half hitches are performed. The first one using the tail of the suture as passive
Perfect.
thread, and the
second one, you
using
change
the matrix of the suture
The
as
sleeping
passive
thread. Look, put in traction the matrix with the needle and go down with the tail. And this is very
Surgical
nice
knot
sequence.
using both hands.
Same sequence
In
with
this
both
block,
hands,
the
bimanual
sequence, the
technique. Look
surgeon
at
is
here.
performing the same sequence demonstrated
You
previously
start in front of the
using
tail.
manual knot tying technique.
You don't
The
need to
first
cross.
knot is a
First
double
benefits.
true half knot using the right needle holder coming from above the horizon of the thread in a clockwise rotation of the needle holder's tip.
Perfect.
Symmetric traction on the threads is
But
applied in
you
order to have a
need
flat knot.
to perform with the
In
other
second
hand.
half knot, The needle
the left.
holder comes also from
And this
above
is the
horizon
challenge.
of the thread.
Educate the
And
people
there is no
to
need
use
come
no
across the
dominant
threads
hands
in order
to
have a
perform knots. And then you change again. You use
The third half
gladiator
knot is performed
with the
using
right,
the right needle holder
and you
coming from
perform
above the horizon.
square knots. And at the end, alternate left hand.
Finally, the fourth half knot
The true
is
challenge
performed
at the end
using
of the
left
course,
needle holder coming
the
again
participant
from
has to
above the
perform
horizon of the thread.
bimanual technique. And you, at the end, is important. This is another paper that show the importance of the technique. Romeo Gladiator rule is a very nice technique. Many people perform it, and is a very easy for the fellow. Very easy because it's repeatable, it's easy. In the intracorporeal technique of gladiator, it's important to prepare before not tying the home base and the thread horizon are two big landmarks. And the name of Romeo Gladiator rule is made because when we perform the technique, we use always the branch, the top of the needle holder, the dominant needle holder, open. The jaws is always open and is similar to the pollux versus of the Roman Emperor. For this, we called this technique Romeo Gladiator rule. It's important to understand that the open jaws permits to hook. I use like a hook and permit a very gentle kill the gladiator, save the gladiator, kill the gladiator, save the gladiator. And you can perform a very easy technique without lose the thread. And then you kiss both, you stay very near, very close, and you perform crossing, of course, because I am in manual technique. You have to cross in order to have the square knot, the first double square knot. And it's a very simple, easy. I saw people here just in 2 days, they perform a very good knot tying with the right hand, with the left hand, and this is a very nice question. At the end, in conclusion, I think that the question of the future, the challenge of suturing technique is to educate the non-dominant hand. All people, 90% of doctors and surgeons are right hand dominant right hand. But in laparoscopy, as Mario said, Arnaud said, the future is a bimanual technique. You have to use two hands. And in the suturing technique, the question and the future challenge will be to perform training courses online and presential. I hope to be presential in Moscow next time because I love your city and the Russian people. And the future is to perform bimanual technique at the end. It means it's not important. The gladiator is easy or smiley technique, whatever you want, but not with only one hand or this or this. The future is bimanual technique to avoid problem of crossing, to avoid mistake, to avoid reorganization. Thank you very much for your attention.
Thank you very much, Professor Romero. Well, we should use two hands in all situations, I guess. A one-handed person or a bird with one wing is difficult to fly. Dear colleagues, we need to see all the speakers. We need 10 minutes for the discussion. And I would like to see all our professors. Well, it's nice to see your pictures, and let's have a discussion. I do not see Arnaud Vatiers. Where is Arnaud Vatiers? Arnaud, where are you? All right. Well, I would like to ask each of you, we have just 10 minutes. Well, right now, we are living in the era of artificial intelligence, new achievements. What is happening right now in operative gynecology, in endoscopic surgery, robotics, well, the use of different energies? Well, each of you has 10 minutes to tell us what is happening in the era of artificial intelligence. We have thousands of people in live streaming. So what is your view? Today, we have more and more artificial intelligence, new technologies in surgery and, robotics, etc. But at the same time, it looks like we use robots, but they try to model after you, to copy after you. You are like robots, and robots, real robots, are trying to copy you. And because future robots will be operating like you. Arnaud Vatiers, 2 minutes. What is the good message that you would like to give all our Russian and international listeners in this live streaming? We must finish at 10 Moscow time in 8 minutes. Arnaud, please, 2 minutes, your main message for all of us.
I think the message is very simple. Until today, I don't know for tomorrow, but until today, all robot, all whatever technology are tools. And so a fool with a tool is still a fool. And so far, the decision maker is the surgeon. And you cannot make decision or good decision with an extensive knowledge. So we do minimal access surgery that impose us a knowledge which is even more compared to traditional surgery. For example, for traditional surgery, you don't learn how to suture. For traditional surgery, you don't learn about energies. For traditional surgery, you know the anatomy from an external view. When you do laparoscopy, you have to know the anatomy from an internal view, which is a bit different. So I mean that the message is learn as much as you can, train as much as you can, and then you will become, as I say, you will become much more predictable, which is, I think, good for the patient, but is good for the surgeon himself. In our difficult period, if you are predictable, your rate of complication will drop dramatically. And so it will make you safer also.
Thank you, my dear. I'd like to ask the same question to Philip Konings. Philip, we've been in surgery for too long a time. What is your message in the 21st century to our doctors who are listening and watching us right now? It's the time of the pandemic, but we've done a lot. Nevertheless, a message from Philip Konings, please.
When we started laparoscopy in 1985, we thought it was going to be a revolution. We learned soon thereafter, it's much more difficult. It's much more difficult, and you need much more anticipation. And I would say where open surgery, you can do it always the same. We have, and this is very typical in the lessons this morning, laparoscopy requires that you know what a suture and how to tie a knot. You have you heard from Mario that electrosurgery, this is the industry how to listen to us and to say, if you have a different instrument attached to the machine knows this. So the surgeon doesn't have to know. The study of the overlaying images, it's just technology which is helping us. But the key study of endoscopy is we have to understand today what yesterday we were doing just as technicians. We are becoming intellectual surgeons, where before we were much more technicians.
Thank you. Mario Molzani, please, just a couple of words. What message? You are the youngest among all of us here. What is your message to the audience, please, Mario?
Yeah, Leila, my message is very clear. We have now disposable very different technology that we can use. We have to consider always the benefits for the patients and the quality of our surgery. So please use only the instruments that can help us really. So don't increase too much the cost of our surgery, because we don't need to increase the cost, and use correctly the technology. So starting from a preoperative correct evaluation of the patients, clear indication for correct surgery, and then always putting on knowledge of our anatomy, on training, and use correctly the technology that we have disposable now.
Armando, please, just in a nutshell.
Yes.
A gladiator forever, or something else you can offer us?
Leila, my message is very, very, very easy. And I want to call your attention and the attention of, in one big question. When Da Vinci born, the robot, the telephone, the mobile phone was iPhone 2. Without no competition between other company, Da Vinci continue to stay in monopole market. It means no competition, no advance, no development. It means the iPhone now is iPhone 12. Mine is 10, of course. Mine is 10. But it's 12. And in my personal opinion, the increase, the growing of technology in Da Vinci remain, in reference of the advance of other technology, remain a London cabin box of 12 years ago. I want to say, without competition, Da Vinci is a big trouble. And I continue to have an idea. Without laparoscopy, the robot make no robotic surgery. The robot is just a tools. I agree with Arnaud. It means the robot without surgeon is a box without life.
My dear colleagues, thank you very much. We have finished the first day of the endoscopic surgery at 10 o'clock sharp. We'll have a short technical break at the request of Ria Novosti, and then all our surgeons, Arnaud Vatiès, Mario Molzani, and Romero Armando and Philip Konix will keep working. We'll have a special course on robotic surgery, on prolapse, on endometriosis, on malignant tumors, on malformations, congenital malformations. Congratulations on the beginning of our endoscopic course. Thank you so much. And I will be here for 4 days with you. And it's a great pleasure for me to be with you and to exchange knowledge in this question. Let's have a technical break, and we start at 10:10 sharp Moscow time in 10 minutes. Then will be the opening of the 34th International Congress with the course of endoscopy called New Technologies for Diagnosis and Treatment of Gynecologic Diseases. the director of the Kolokov Center of Obstetrics and Gynecology, Professor Gennady Sukhik, will open the Congress. There will be a welcoming address from the Minister of Health of Russia, Mikhail Murashko, Alla Samoilova from Roszdravnadzor, Russian Healthcare Protection Service, Galina Savelyeva, our teacher and our big friend. She is an academician at the Russian Academy of Medical Science. And after this, we will get down to our program. See you in 10 minutes.
Nadia, you're on live. Dear colleagues, dear Leila Vagoevna, it is my great pleasure to welcome you this morning. We are so far away from one another, but we are all of us together. For me, very much like for Leila Vagoevna, who is my co-chair, it's a great honor to welcome our colleagues from Russia and from overseas. For us, it is very important to hold this 34th International Congress that has this name that has always been with it, Novel Technologies of Treating and Diagnosis of Gynecological Diseases. May I say that it started last century and was initiated by academicians Kolakov and Adanyan, and a huge number of our colleagues joined this Congress as time went by, and it used to be called less invasive surgery. And to some extent, it became a powerful impetus and platform for the broad transmission of this novel technology of endoscopic surgery in Russia. We'll have 4 days ahead of us. I'll try to save all my presentations because each of you will have an opportunity to say some kind words for this Congress. And so now, today, it is our great pleasure, knowing how busy the schedule is of our Minister of Healthcare, Mikhail Albertovich Murashko. It is my great pleasure to give him the floor because he will have a welcome address for this Congress and he will express his opinion on this Congress. Please, Minister, you now have the floor. Dear colleagues, I congratulate you on opening the 34th International Congress with a course on endoscopy, novel technologies to diagnose and treat gynecological disease. Given the demographic situation today, special attention is paid to preserving reproductive health of our population. The government has been taking unprecedented measures to support the birth rate, both in terms of financial as well as promoting healthy lifestyle, so caring for reproductive health of the youth, promoting families with many children, and promoting responsibility for one's reproductive health. We need to work hard to cut down on the number of abortions and involve volunteers in psychological services, but special responsibility lies with us. A course on endoscopy with specialist surgical sessions on intrauterine surgery, seamless materials, and experts on laparoscopic surgery, hysteroscopy, malformations of the reproductive system, fetal system surgery in endometriosis and cancer, topographic anatomy, dedicated masterclasses that will be held by global top experts. This is something you can look forward to. I'm sure that the knowledge that you will get will be highly in demand in what you do every day. Our physicians have to adopt these technologies in everyday practice, as well as come up with patient-focused approach with very kind attitude towards the patient. We need to adopt saving technologies. This Congress will be addressed by 63 Russian and 34 international experts from 12 countries. Special attention will be paid to reproductive health under COVID-19. I suggest you should discuss the feasibility, viability of vaccination for pregnant women. Although, despite the pandemic of COVID-19 and the restrictions that we impose, this Congress is held online today. I'm sure it will not stand in any way in your very good and productive discussions. I wish you success, good luck, and of course, very good health. And for that matter, please also remember about the vaccination. Mikhail Rich, thank you very much for this welcome address and for these good wishes. We are so pleased about it because Mikhail Albertovich, in his professional capacity, has a background as an gynecologist obstetrician. So he's our leader, he's very dear comrade and friend. So dear colleagues, it is a great honor for us to be addressed by Alla Vladimirovna Samoilova, in charge of the Federal Service on Healthcare. She's also our colleague, a gynecologist and obstetrician. dear organizers and participants of the 34th Congress on Novel Technologies in Diagnosis and Therapy of Gynecological Disease. On behalf of the Federal Service on Surveillance and Healthcare, and in my personal capacity, I would like to congratulate you on the opening of this large-scale event. This Congress is addressing very important issues: how to improve the quality of gynecological care for women, how to adopt novel technologies by our specialists, how to create and update the guidelines, how to improve the professional standards for physicians. In doing so, you are carrying on with the line that the government and the state has posed before this, how to preserve and care for reproductive health. I'm sure that this agenda that fully is in line with modern and cutting-edge technology, in terms of diagnosis and therapy of gynecological disease, will help all those who attend find answers to the questions and move forward in implementing what we have to do to improve the quality of care for the women residing in the Russian Federation. I wish you fruitful work, inspiration, new ideas, and every success in whatever you do. Thank you very much, Alla Vladimirovna, for these warm words. We are very thankful to you for the huge support that we get from you for this grand mission that your colleagues are pursuing, that is so much needed as you do your work in regulating our work, ensuring that we fully comply with safety, and you put sort of a corridor of flights which is supervised by agency. Thank you very much. Dear colleagues, as I introduced Galina Mikhailovna Savilyeva, I could say that she's honorary professor of the Department of Medical Institute number 2 in Moscow. I could also mention that what Galina Mikhailovna Savilyevna has done over decades of very fruitful and productive professional life, as she met great people who were the founders, honorary founders of many chapters in modern surgery and G&O. Instead, I would like to just say that we now give the floor to great Galina Mikhailovna Savilyeva, academician of the Russian Academy of Science, our classic, living classic, our supreme authority, and we very much know that it is how well motivated, and she carries the honorary title of Hero of Russia. You are now a star, and you carry a star. This order has the shape of a star. Galina Mikhailovna, please, you now have the floor, dear colleague. Well, dear organizers of this remarkable Congress, Gennady Tikhonovich and Leila Vladimirovna. It's been a year, and we are back online, and I would like to say that I do hope that all the colleagues who attended this Congress last year are again with us online and will be listening to whatever new things will be presented over the achievements of last year. I'd like to say this is a special Congress, a specialist Congress. First of all, it was the first Congress to be produced in this clinic. Before it was known as a center, it was just known as an institute, and is now annually held with great success. I used to think, well, what could come up new over only 1 year? Why do we hold these congresses every year? But you know, as time went by, I realized how important it is to carry annual congresses. Some people may have heard something this year, somebody have come up with something new over this year. So surely this Congress is very much unusual. It is unusual in the sense that you involve so many researchers from abroad. This is what only this Congress can boast of. We not only listen to presentations during this Congress, but we also can see what the surgeons do while they are doing operations, these top cutting-edge surgeons, and it is so important for us. I want to highlight that as we adopt novel technologies, for example, when we seek to create to a certain degree standards, or maybe guiding instruments which would serve as guidelines, for practicing physicians. All this is very important. But now I'll say something that goes against the grain of this Congress. Well, dear friends, all those attendants, please remember that despite adoption of novel technologies, important as they are, despite scientific intellects, and we'll listen to the first presentation on adoption of AI, artificial intelligence. I will be saying something absolutely factitious. Still, please remember, clinical thinking is what clinical judgment is what matters most. No matter what cutting edge achievements we adopt, clinical guidance, clinical thinking, clinical reasoning remains the most important thing in any physician, and especially so for gynecologists, obstetricians, and perinatologists. I wish you all very good health. I wish you very productive life, both in terms of personal and in your professional capacity. May I say that I also was vaccinated. So given my age, please join me and follow my example. I wish you all very good luck and be well. Thank you very much, dear Galina Mikhailovna. You always serve as an example to all of us. Galina Mikhailovna, I don't suppose you realize how often we really and truly keep looking up to what you do, to what your lifeline has shown us, as we try to model your activity, what you and Viktor Sergeyevich, a great friend of ours, have been doing. I've been saying you, for me, always exist only as a couple, as a pair of specialists. Thank you very much for these remarks, that clinical judgment will never stop being important, will never be replaced by anything. I will also would like to support you in this line, but a great friend of mine, Leila Vagoinovna, started this day very early, as of 8:00 a.m. And we all realized that 37 presentations from our overseas colleagues, this boils down to the work she has been doing. Not only it is the 50th year, 50, working for major gynecologic surgery, it also means 50 years working in the world, working among the top-known researchers, physicians, doctors, surgeons, somebody who are on the cutting edge of technology. And I would very much like Leila Vagoilovna to present us briefly. She would acknowledge the contribution of our colleagues from abroad who will be addressing this Congress and will be stars shining on the horizon of this Congress for 4 years. Leila Vagoilovna, you now have the floor. Well, dear Gennady Tikhonich, dear Galina Mikhailovna, distinguished colleagues from Russia, from all the regions across Russia, chief specialists, professors, and practicing physicians, thank you very much for your confidence, for your trust. We're being viewed by a huge number, by the audience numbers in a matter of thousands. Early in the morning. It means you've been looking forward to this Congress. I would like to thank all who will be holding these sessions and who will be spending these 4 years with us. We give a ceremonial pledge not to upset anyone. You will see very much state-of-the-art, cutting-edge things. You will see the friends you've known for many, many years. And you will also see where research and science are moving to, how we adopt novel technologies. And as was quite rightly put forward by Galina Mikhailovna and by Arnaud Vattiers, if a surgeon is talented, he will make right use of novel technologies. But if Lord didn't grant him this, then you can spoil everything and you can produce negative outcomes. So my dear colleagues from abroad, today we have 34 physicians who are watching us from abroad. I'm very grateful to you. I wish to extend my thanks. This time you will be working with us in Russia, but online. Will be viewed by many foreign audience, and I do hope that in the very near future we'll be able to resume our annual congresses. Just a word for your information. The first congress was back in 1991. Quite rightly, was put forward by Gennady Tikhonovich, that was led by Vladimir Ivanovich Kulakov and your humble servant, Leila Adamyan. We created an association, and this association has never let you down. No matter what, the pandemic or whatever else, I do not dwell on it longer. I shall be with you working for 4 days without raising from this chair, so that we could ensure it all, both the imaging and the quality, plenary sessions, as well as broadcast operations from the OR. Whatever we promised, we will deliver, and we commit to do so. I wish you very good health, enjoy it, be in good mood. We wish you good luck, and please be well. Thank you, dear colleagues. Enjoy this Congress. Leila Vagoina, thank you so much. We appreciate your input. And we wish you, since you are the chief person who started this Congress, I do hope you have prepared a number of costumes you will be changing during these 4 days today. You start on this marathon, so please save on your energy. Allow me, please, to begin with a very brief presentation, dear colleagues. Please, could we have my first slide up, please? Because what we are saying is that, could we have my slides up, please? Indeed. This is a matter of novel technology as we open this Congress online. It's easy for me to do so. Usually we've been talking about the agenda for this Congress. Today we are on the 8th of June, 2021. We began, as I put it, very early in the morning at 8 a.m. Moscow time. And we had an excellent education course for our young specialists on endoscopic surgery. Today, we're about to discuss endometriosis, laparoscopic surgery for polyps. We will review updated guidelines that are so important today. Tomorrow, on Wednesday 9th, we'll discuss malformations of the uterus in vagina, hysteroscopy, and fetal medicine. This is something that we're newly adopting, and we're very thankful to our foreign colleagues for sharing their experience. We'll continue working on Thursday too, where we'll discuss endoscopic surgery, oncogynecologist, and may I boast that we opened an institute of oncogynecology within our national center, and of course, reproductive health. You see, we are growing, and we couldn't possibly fulfill this agenda during 3 days as we usually did. So we will finish our work on Friday, on day 4, where we'll have several plenaries as well as competition of young researchers, which is so important for every Congress. Indeed, Galina Mikhailovna and Leila Vagoilovna mentioned that we should keep the time. Time has been giving us endless change. COVID, maybe this pandemic, which we call a war, sometimes we call it pandemic, surely has made a great impact on our thinking, or rather to accelerate this moving forward. We can see what this digital transformation stands for, which describes the 4th industrial revolution. It has to do with adoption of internet, integrative systems, simulation and modeling systems, robots, big data, additive technology, and surely augmented reality, AR, and something what we call very romantic, cloud calculations and cybersecurity that is standing next door. So it is such a great pleasure for me that some people are always thinking very much on the cutting edge of modernity. Klaus Schwab is a European contemporary of ours that organizes remarkable fora in Davos, president and founder of the Economic Forum in Switzerland, Davos Forum. And please note, he said that we are living in surprising time, an era when we are witnessing radical change in technology under our very eyes. And indeed, time seems to have been pressed. We seems like changes in laws of physics. Whatever seemed science fiction yesterday is reality tomorrow. It's down to earth, common things. And we're not really aware, we do not fully realize that we're living within and during 4th revolution, industrial revolution. It is going on as we adopt digital healthcare as something truly serious, because this is the path, this is the trajectory, this powerful leap forward as we see novel instruments that we are adopting when we see the expansion of a huge network that has never been socially, professionally, could never be reached before. Internet, imaging analyses, universal databases that have become accessible to all. These information systems that are describing what is particular and what is common for every healthcare system. And we seek to achieve clinical outcomes. This remarkable novel medicine, we would like to make it preventive, prediction, that it is about management. We seek to achieve control over diseases. This is something we are really living through. We are at pace of time, and the WHO seeks to establish Sustainable Development Goals, SDGs. And this is where digital healthcare is on the forefront, which will help us achieve the Sustainable Development Goals that the United Nations has posed in terms of healthcare and well-being. So SDGs 4 is coming 15 years. They seek to ensure maximum possible quality of care and healthcare, and global strategy in the health of women, children, and teenagers, I believe, has beautiful words: to survive, to prosper, and to change. We realize as we seek to eradicate preventable deaths, which unfortunately goes hand in hand with all of us, whatever continent we may be living in, ensuring the health and welfare, well-being, creating enabling environment, given this quite unique planet we were fortunate to live in. So WHO concept on digital transformation. This is a foundation and the instrument for clinical guidelines and recommendations. This is something that seems very irksome, difficult, burdensome for us, but it is the guidelines, clinical recommendations that are now undergoing digital adaptation. Nowadays, they are widely adopted as a standard and model of care in terms of how to take care of our patients. And surely this is a model that seeks to create a model of precision medicine. And we need to ensure that software is available. Most importantly, something a sine qua non for today. Surely digital technology in medicine, in life, it requires very much different background as we train our specialists. I'm so sad that this slide about digital personnel and competencies, it says, search for this blue color. The share among university leavers where we stand, only 7% of our specialists are ICT. In terms of ICT per million of population, we went somewhat up above 250. How many of them work for ICT? Again, we are 2.2. The percentage of those who work for ICT, 1.6. Where's others? It's South Korea. This came as a surprise. Finland, Estonia, Sweden, Switzerland, Finland, Denmark, UK, Ireland, Australia. Well, this slide speaks for itself. It poses and gives us a very truthful reference point where we belong here and how far we have to travel up, not to be lagging behind. Surely this Congress is on surgery, and in part, I don't want to sort of spoil the presentation by Leila Vagoyevna, and she was enthusiastic about preparing and delivering it. Look at this surgery, surgery for curves and open surgery, then nice line as laparoscopy rose. Then even further on this melting point between digital surgery, we saw the rise of robots. We've adopted robotic surgery for the last 15 years, and then digital surgeries where we're moving ahead. This is something that we will see tomorrow, but what will this be tomorrow like? What will it give us? Digital surgery, 5 pillars. Robotics, surely number one, because we already it's something tangible to us. Ongoing mad race to improve and perfect equipment, better imaging, advanced instrumentation, enhanced visualization, connectivity, huge amount of data, and machine learning, which probably we will call something that will help us take decisions, and maybe AI. Digital surgery, what definition could we give? A combination of cutting-edge technology that covers both surgical approach using equipment and techniques, visualization and imaging, as we seek to adopt more and more devices and gadgets, AI for only one purpose, to improve the outcomes both for surgeons and for patients. We perfectly realize that artificial intelligence, AI today, we are probably abusing this word, using it way too frequently. Surely it has a place of its own. Its proper position today and tomorrow will be widely adopted. So we can see what this AI gives us, what it seeks to achieve. We see that on the bottom of my slide, we realize that they are the purposes for using technology and AI and machine learning. As we go back to robotics, I'm still never delivered the promise that I gave to academician Leila Adamian, where I promised to her, and only after I visited our center several days ago. This is the premier of this country. He gave this gift to academician Adamian, and we will soon get Da Vinci robot. But this is what our colleagues enjoy in medical university number 1 and in dentistry university number 3, but nevertheless, beginning with 2007, it's been 18 years, over 20,000 of operations have been performed. We can see that overwhelming amount of we would like to thank the speakers, because this equipment was created actually for males, and very modest figures of its adoption in gynecology. In this system works for cancer. Indeed, we see that the future of surgery, not about surgery, conventional surgery, as we are accustomed to see it. We first and foremost realize that we need to plan and design surgery. We may use 3D printers for or some accessory devices that need to be implanted. Surely virtual reality technology, VR, as we need to perceive the events in 3D dimensions. A huge amount of telemonitoring, for sure. This is intra-op diagnostics, which goes hand in hand with mass spectrometry, and I will discuss this. And something that is my pet subject, regenerative medicine. And it is difficult to contemplate the future of surgery. Genomics, or rather all these omics, which are now the basis and foundations of every clinical medicine, including medicine and surgery first and foremost. In point of fact, it means closer tie, close interaction between us and medical technologies. So this rapprochement, this harmonization probably is the bulk. AI in healthcare is used to do diagnosis, to identify the language and predicting the events, forecasting the events. This stands for robotics and mechatronics. AI in surgery stands for analyzing absolutely huge bulk of data. And this stands for opportunity to raise high up into the sky. We can evaluate the risks, the survival, take the right clinical decision, and ways to predict complications and morbidity. To confirm what I've been saying, this is the rise of publications in cancer to your right, in our surgery, conventional surgery, not cancer surgery. We see these soaring columns and the number of articles and publications that are now coming in hundreds in brilliant magazines and specialist journals. New paradigm of surgical education and training. This is a sine qua non. It should be a versatile specialist who takes decisions on after he or she has analyzed huge bulk of data. He or she should be very well versed in digital technology. And I feel so ashamed that I'm continuing my studies here, and I'm very proud of my colleagues who are, well, dozen times better and have better understanding of this all. And our super communication and connectivity, surely. And of course, leadership for future surgeons to be somebody who are enriched not only with the talent of knowing how to hold the scalpel and how to sew, but this is somebody who is brilliant among the digital technology. Surprisingly, but ethical problems about AI and digital medicine are just soaring very much like dough, because this has given rise to, we may be taking mistaken decisions, but the question is, who will be held accountable for these results? How can we switch and how can we protect this data? How should we overgrow our misconceptions and myths that we were guided by before? And we realized that somebody we lost 3 years ago, Stephen Hawking, man of endless courage and talent. It is for good reason that in UK they thought they would bury him close to Newton. Please look, many years ago, well, at least over 5 years, he said creation of AI may be the last technological achievements of humanity, unless we learn how to control our risks. I suppose this is a fundamental phrase we should grasp and remember. We've seen a slide where regenerative medicine and genomics were on top, although the slide was on surgery. We perfectly realize that unless we learn how to understand the basics of our evolution and our existence as a very complex biological system, we cannot move forward, neither in medicine or in surgery in particular. We perfectly understand that in the last 20 years, may I remind you that the first genome was deciphered between 2000 and 2001. It took over 2.5 years for a dozen of teams. They spent over $2 billion on that to do incomplete sequencing of human genome. But look at it now. It has become basically routine. Something down, I wouldn't say it's routine, but it's down to something pretty common. Routine in Russian sounds a bit disparaging, but I believe these great achievements, and it's not just a path, not just a track, it's some speed light at which we travel this path over these 20 years. And I'd like to say how remarkable it is that medical community came to grasp very fast. You shouldn't study the genome at large, it's huge, but only under or about 1% of our human genome. It stands for 300 billion pairs of base pairs, BPs. They are the genes and proteins that are responsible for our receptors, ligands, what makes us as humans. But as they were sequencing exome alone, that would stand for a lot. You can really predict what is ahead of us in the future. For us, it means the childbirth. That's why my son was bursting, why I'm so grateful to the minister.
Mikhail Murashka, who just visited our conference, and Tatiana Golikova, who supports our initiative in 10,000 newly born children. We decided to do a whole genome sequencing of the DNA of umbilical blood. So there are other issues like ethics and the transfer of information that we can provide for the children, for the parents of such children. And that's what we call personalized medicine. Just one example, a wonderful article published in 2021, 60,000 women with breast cancer and the control group of 53,000 women, BRCA1, BRCA2. If we look at the first gene mutations shown on the right will miss just other mutations and will miss many cases of breast cancer. That's why we should deal with exons and the genome sequencing. In this case, we will be able to get out of the situation and solve our problems. We understand that the competitive advantages, and they can be achieved if we use the best equipment, the best technology, the most skilled staff, the best competences, and the heart that we should put in our specialty. At the same time, we realize that the tumor development or age degradation, I hate the word aging, but that's what we encounter in our situation. Unstable genome genetic changes when genes are switched on and off, the protein balance, the proteostasis, preservation, cell identification, the identification of our destiny, so to say, what kind of cells we're going to have, the depletion of stem cells, the loss of biological ties. And this is a universal model of the life cycle and aging. My God, Galina, we're very happy because we represent the best medical specialty, because for 5 days we can see the first days of life of an embryo. We can analyze the best mechanisms of the early development of an embryo, and the same mechanisms are used in aging, in developing tumors. Unfortunately, that is why DNA damage, unstable genome, epigenetic problems that we have due to different factors, the loss of cell identity, cellular aging, diseases. Well, here is when surgeons come in. Unfortunately, even if we have wonderful skills, wonderful technologies, but we do not know how to do it. In this case, nothing will happen. Maybe we should just reduce our surgical activity, use surgeries where they are absolutely necessary. And as academician Sverdlov once said in his 2 books called A Look at Life Through Hormones, our complex, unpredictable systems do exist, and we should use a cautious approach to treating such systems. When we look at the ligand, at receptors, when we can just add something to surgery or to remove something from surgery, that's not the task of the third decade of the 21st century. And the best way to predict the future is to create it. That's the way in surgery. It should be based on modern molecular biology, genetics, bioinformatics, on emotions and competencies. And Abraham Lincoln did say the best way to predict the future is to create it. That was the guy, to create it, not to predict it. And Sir Winston Churchill said, never let a good crisis go to waste. Well, there are no crises in surgery. Thank you once again for your attention. I spent 22 minutes during this opening ceremony, and I would like to foresee the presentation by Leila Adamian. And I'd like to say that Leila Adamian is the Deputy Director on Science at the Kulakov Center of Obstetrics and Gynecology. She has been in this profession for 50 years, and she's a great surgeon. She gave life to this center, to many patients. And it's a great honor for me to give the floor to Professor Leila Adamian, who will be talking on the artificial intelligence in reproductive medicine and surgery. Leila, the floor is yours. I stirred everything up. Well, distinguished Professor Suchik, distinguished Galina Mikhailovna, esteemed colleagues, I decided to make this presentation just to tell you what is the most important thing for a doctor. But nevertheless, a doctor is the most important factor as a person, as intelligence, as intuition, but times are being changed right now, and we're changing with them. And please share the slides of my presentation, and there will be short videos that I am planning to show. Please launch the first video. Well, that's the Unified Medical Digital Database. It will happen in 2022. Artificial intelligence will prevail over human intelligence in 2024, but I'm thinking about it. I think this won't happen. Nano drugs and individual vaccines in 2026. Well, organ printing as well as cellular printing in 2028, understanding in how our brain works in 2030, modification of human genome 2032. These are predictions, and the notion of pension and retirement will lose its meaning. So these are the projects taken from the documents Technological Singularity in 2045. What does the future hold for us? The 21st century will be the century of digital economy as the national policy of Russia. Artificial intelligence will become the global priority starting from 2021. Accelerated introduction of digital technologies. There is the federal project called Artificial Intelligence from 2021 to 2024, 36 billion rubles will be spent on this. Support of technologies, that's what we're going to do. Bringing to bear the demographics, increasing the birth rate, that's the most important problem. Russia will become the 5th global economy of the world, according to President Putin. Artificial intelligence can drastically change our medicine due to predictive technologies, but the foundation of digital medicine is a specialist who can run those technologies. And we hope that Russia, as a great country, will become also a great digital power. How is artificial intelligence going to be introduced in medicine? It will improve the diagnostics. It will contribute to the development of new drugs, including those mentioned by Professor Suchik. He is always ahead of the entire planet. It will improve the quality of medical services. Artificial intelligence has boundless capabilities due to its ability to use predictive technologies. As for increasing the birth rate, well, we know that there is a trend towards a decline in the birth rate, and about 15% of couples use assisted reproductive technologies. Usually such methods as cryoconservation of oocytes and embryos, pre-implantation genetic testing, well, assisted insemination, the technique for embryo selection. But what are the results? despite the fact that we are using such methods of assisted reproductive technologies widely, the efficacy is still at the level of 30%. Embryo selection is often done by hand. Not all specialists are the same, depending on the country and even the region. The assessment of an embryo is done just visually by a person, by a reproductive specialist, and the results obtained depend on the skills and the qualification of specialists in reproductive medicine. The use of data is another important aspect. We hear that data are the most important things, but 78% are unstructured data. The sources of this data are clinical data from electronic medical records, from different imaging methods, the use of drugs, and so on and so forth. Unfortunately, we haven't erased the generation of specialists that was mentioned in this video who can easily use these data, and the only mistake in this database can lead to dramatic consequences. Artificial intelligence can be applicable to the medicine of today. For example, we can do the analysis of MRI, ultrasound, IVUS, X-ray. We can monitor patients and doctors, as well as other staff. Artificial intelligence in assessing monograms is used in this Bear system. The Botkin program is aimed at assessing mammograms as well. Third opinion platform means analysis of different clinical imaging, and today we have a very advanced Skolkovo system. We have 300 clinics in Russia which use different types of artificial intelligence in one or another way. President Putin has said that there is going to be a federal project, artificial intelligence. It has already started from January 2021, and on December 31st, 2024, the first stage of the project will come to an end. How can we introduce artificial intelligence in OBGYN on the basis of big data? Well, provide for the selection and storage of information, support the introduction of AI in healthcare facilities, to develop standards on clinical recommendations in the use of AI in healthcare. These are specific tasks that we need to fulfill. Moreover, to prepare at least 100 sets of different data, 2,000 specialists who know how to manage big data, to introduce 60 services that will be using AI, and to create a unified database in the field of reproductive medicine. Dear colleagues, I'd like to say that the only database that we are going to have is the database at the Kolakov Institute of Obstetrics and Gynecology. I've been working in the center for 60 years, and this center can and should be the center where we will have this database. In his State of the Union address in 2020, President Putin said that demographics is one of the major problems for Russia. That is why we need to have this database at our center that will be for the benefit of all of us. I, of course, have the data here, which are not mine. Well, basically, these are data of the government and other sources. What's the role of artificial intelligence in modern medicine? First of all, the development of an algorithm, detection of patients prone to specific complications during pregnancy, the advantages of big data to identify the risk factors, especially preterm births on the basis of genome study. Artificial intelligence in obstetrics and gynecology can help us in diagnosis, prevention, in identifying specific diseases, as well as to make a prognosis, to monitor patients and medical staff, pharmacotherapy, individual selection of drugs, the management of our industry per se, and many other aspects, interpretation of the results of cardiotocography using artificial intelligence has shown very good results when this data can be sent to specific servers and we can make a prediction of premature births and complications during the pregnancy. I cannot say that I do not believe that or I am totally sure about it, but the pandemic has shown that we need some big brain that could process all this data and indicators. The Kolakov Center has two powerful structures, the so-called VMIS, I like this word, that's the vertical integrated medical information system. And it seems to me that VMIS will be of big help in developing artificial intelligence in monitoring the conditions of our patients in different regions of Russia, in big cities, small towns and villages. We must monitor our patients the way we did it during the pandemic. Artificial intelligence can help doctors make specific decisions, but to avoid the burnout, a doctor needs help. Well, of course, while being at the point of care of the patient and in the operating room, the doctor cannot just enter all the data. For that, he needs specially trained specialists. The use of 3D printers is another possible way of development. And of course, I'll be talking about robots. Well, we need to have robotics, which I consider not as a panacea for all diseases. Professor Vatiers said that robots are great, but if a fool uses a robot, if a fool cannot just hold a scalpel properly, this would be a disaster. The artificial intelligence models after a person, the same way a human brain processes information, so that to interpret specific data, add up to this data. I know that every second OBGYN encounters the problem of burnout because of the mammoth task that this person faces. Well, I cannot solve specific problems related to computers. I do not know how to use the computer properly. Well, I can use my cell phone to send an SMS, but I know that there are specialists who know how to use the computer properly, and we can create artificial intelligence if we model after such specialists, if we just copy after their dreams, after their aspirations. This will be a major step forward. Precision medicine and artificial intelligence. Here we're talking about the selection of therapy depending on individual characteristics of a patient. We cannot just administer one pill 3 times a day to a person who is 50 or 80 or 30 years of age, or when the person weighs 100 kilos or 50 kilos. I think artificial intelligence will play an important role in selecting specific drugs and dosages. Well, the population can be divided into subpopulations with specific diseases depending on biology, the clinical forecast, response to treatment, uniqueness, because each human body is a unique structure. And I will be very happy if we manage to do this ranking. What person should get specific treatment? Someone might need stem cell transplantation, others might need antibiotics, others might need just solar light and water, and AI will help us here. AI is already working in obstetrics and gynecology, monitoring of the health of the child and mother, well, monitoring of mothers with diabetes mellitus, well, monitoring of women to detect twin transfusion syndrome, well, also in the post operative period, we can also show very good results. And our center has shown that during the pandemic, we managed to use telemedicine to identify every female patient in Russia who has specific problems and to participate in the process of treatment, to send teams to specific places where our patients needed help. And that was very gratifying to see, because the Kulakov Center is both artificial intelligence and natural intelligence, because we have super specialists working there. Monitoring the fetal condition is another important aspect. There are different programs here, Cafe, Infant, etc. The goal is to help us interpret specific data during delivery, to provide for reliable results when we do a specific analysis. In Indonesia, for example, the use of AR to predict the preeclampsia, more than 2,000 patients were analyzed, risk factors, family history, and they developed algorithms on the basis of AI predicting the development of preeclampsia and how to prevent it. Well, as for gynecology, I should say that as for PGD or PGS, well, premarital counseling, if we enter all the risk factors into the database, we can identify risk factors, the assessment of ovarian reserve. Why should we just think about fertility when a person is 35 and older? Well, I think, and that's the policy of the Kulakov Center, is to study the child when the child is still a fetus, and to do non-invasive genetic testing to have a lesser number of surprises in the future. That should be our approach to reproductive health of our women. It would be nice if we could motivate, incentivize our women so that they could give birth to children when they're from 20 to 25 years of age. In this case, we would have healthy births, and that would reduce the burden for the healthcare system of Russia. Well, I am trying not to overrun my time, but as for AI in reproductive assisted technologies, there is an application for smartphones, well, like the DNA integrity, well, ejaculate assessment, well, there is no need to go somewhere to have the PGT done. We can assess the development of embryo before it goes into the blastocyst stage. We can do the imaging of oocytes before ICSI to assess the competency of oocytes in IVM, and many other things as far as assisted reproductive technologies are concerned. As for fighting against the COVID-19, AI has shown that we can use it for diagnosis of COVID-19. There are 18 servers, and During imaging, we can identify different kinds of diseases, including COVID-19. There is a CT calculator, which determines and identifies the lung damage. Specialists at the university in Tatarstan learned how to use the neural network to diagnose COVID-19 on X-rays. The 80% result of this bare artificial intelligence can identify coronaviruses on the basis of cough, the sound of the voice. Well, I do not believe in miracles. I've always been a surgeon, and with the skills of a scientist or a lecturer, well, at least I have 49 patents that I obtained in different periods, probably one per year, but COVID-19 has taught us a lot. The vaccines that have been developed in Russia, as both the president and the prime minister have mentioned, are also thanks to the use of AI in Russia. Right now, we're slightly lagging behind in terms of vaccination. Well, but all organizations such as the WHO, NRH, CDC, and other societies say that COVID is a disaster for reproductive health. We just analyzed 81 patients in hospital number 15, and I know that that is really true. And I know how our center works and how we can see the relations between COVID-19 and pregnancy, and how COVID-19 has a negative impact on pregnancy. If a woman is in a high-risk group, she is going to get pregnant. It's better to do a PGT before vaccination, and during women in the high-risk group, well, they can be vaccinated during pregnancy. There hasn't been a single complication. You can see the results of hospital number 15, 881 patients. The risk of premature birth is 3 times as high in those patients who have the coronavirus infection, not because this infection affects the fetus, but because the coronavirus leads to a dramatic situation when an OBGYN together with resuscitation specialists have to do a cesarean section due to the systemic inflammatory response and many other problems related to hemostasis or other life-threatening conditions to a woman or to a fetus. Well, maybe Professor Suchik didn't expect it. I pride myself on having our center as one of the 4th major centers
that can do it. And we will build a vertically integrated healthcare information system. It's just taking the first steps. I'm sure it will be a unique institution, given the people who will be working for it, as well as the desire and motivation to perfect. The role of AI in reproductive surgery will not be disputed. The greatest AI are people like Galina Mikhailovna Savelyeva, surgeons, top-class surgeons who we are showing here, and we've been saying since 1991. They are unique. The robot seems to be mimicking what they do, and then things will work. But nevertheless, technologies have become available that lend a helping hand. What is being done during robotic assisted surgery? First, helps us visualize. Secondly, recognize and detect and make it digital. Send it into a cloud and say, other than your own competencies, you may get to know what it is. Then decision, analysis of best practices in the world, and, God willing, transformation of what surgeon hands can do from a distance, remotely. Down below, you see one doctor works on the Da Vinci and the other has ASD, are sewing this grape, or, well, this is a character of national folklore in Russia. who is so well versatile in minute work. So today in surgery, we moved over immediately to down-to-earth practice. And now we are doing this. We're trying to transform the methods of visualization, including ultrasound, 3D, MRI, CT, and see how this navigation works. How can we make it work, especially for patients with malformation? Well, a pilot registry has been drafted of 5,331 patients. Our center is the expert center for malformations, but such as aplasia of the vagina or uterus, people still cannot recognize where this cellular space is. There are malformations of adjacent organs too. Now, our very young and talented researcher is undertaking it, and I'm sure it will work well. His scientific advisor is Professor Lobochenko, and our imaging staff and Gennady Tikhonovich allowed genetic tests to be done to these patients so that we could demonstrate and model operations, tailor the operations to suit the patient's needs. I'm quite sure that very soon we'll not only shall have navigation and modeling, but we can standardize these operations. These operations will be standardized for your sake, dear colleagues. Indeed, what is required is standardization. These operations that, well, our center, we are reference center, we have several surgical departments. I'm so happy for it because surgical departments, you can't have too many. It means that people that have different specialty, different background, different professional track, and it helps us so much to have such a mind, such a brain. I don't know whether it is AI or not, but thanks to this AI, I've been showing you what our center have been doing. We may well ahead to take a look not only at the patient's anatomy, but also decide. And for a minute and a half, 90 seconds, let's listen to what our premier is saying. Here is AI. Well, platinum gold of the 21st century, and data may be both the source that can make your living, but also can destroy. Only basic and fundamental data are reliable and robust. They are needed to make discoveries, to create state-of-the-art technologies and breakthrough solutions that humanity is now proud of. Please note that all successful modern solutions are based on multidisciplinary approach and many-new technologies. Best results are achieved by those who get to be the first to get to know, get to understand how it works, and know how to integrate it and use it to ensure a more convenient product for people. Today, knowledge becomes an asset. In its day, society znание, knowledge, used to use Bacon's parable, knowledge is power. Our country has been talented, has been rich in talent, and Russia has impacted humanity's development. Well, our compatriots such as Tchaikovsky, Malevich, Tolstoy, Lermontov, Pushkin, Mendeleev, Lobachevsky, London are known everywhere in the world. We have something to be proud of, dear friends. The president in his address identified priority for supporting innovative projects that are mattering for this country. To set up Russian-based technology for production of vaccine, next generation drugs, evolve with novel approaches as nuclear and hydrogen-based energy, renewable energy, and way to accumulate it. Well, where can we foresee breakthroughs? Medicine and healthcare, human health, longer life expectancy are still a priority for the Russian government. And this is where we have a lot we have achieved, especially in basic medicine. These are good examples. Last year alone, Russia became an indisputable leader in creating an effective vaccine against coronavirus. We now have 4 vaccines available. We see this transferred abroad, where and vaccination coverage is rising. Dear colleagues, I tried hard to deliver this, to draft this presentation. What I can say, no matter how much artificial intelligence can do, but doctor matters most. Please feel free to ensure AI, this is our objective, to use it safely. AI will not address the basic problems that humanity face today, such as environmental degradation, civil wars, famine, poverty, but we should not allow it so that AI should be leading us. We should be well versed to master all that AI can offer to us. We should strike a balance between AI and humanity. Even if big data and AI will have a technical advantage over humans, which is natural, but their success will develop only on the data that we put in. Just one mistake of a clinical ordinator into big data may just produce a dramatic situation. We may always expect mistakes and errors. Nothing would ever replace this contact between specialist and patient and the responsibility the physician assumes. Nothing can replace human intuition that doctors have and trust of a patient for the doctor. I hope I could open the eyes of us as physicians on AI. I am a strong supporter of this. Thank you. My presentation is over. Gennady Tikhonovich, please take over. We can see you very well. Unmute your mic, please. Unmute. Yes, can you hear me now? Yes, we can. Thank you. Leila Vagovna, I wanted to thank you for this brilliant keynote address, but I was wrong. This is not your presentation. It is also prepared by my beloved, remarkable, clever, refined, beautiful, wise, endlessly willful Asia Arnoldovna Stepanyan, who certainly was known as Ney Adamian. I see if you can hear me. I'm sending my love and words of gratitude, both as well as to your colleagues, so certainly who are standing next to Leila Vagovna. Your presentation was remarkable, very much holistic, bright spirit, and indeed it came to be as the keynote address. Thank you for this remarkable 30 minutes. I'm not even want to remind you for 9 minutes over time. So dear colleagues, now it is a great pleasure and honor. I can see Anton Sergeyevich Olenev, who is now logging in, a great friend of ours who is in charge of a department of perinatal center, and most importantly, chief specialist of the Department of Healthcare of Moscow on obstetrics and gynecology, OBNG. Remarkable professional, a great friend of our center, and a wonderful, fantastic, refined person. Anton Sergeyevich, the floor is yours. You will discuss the so-called tints of health in Moscow. Well, Galina Mikhailовna, Leila Vladimirovna, Gennady Tikhonovich, distinguished colleagues, allow me please to share this, well, modest experience that we have now as we carry out this unique project in Moscow, when we hold large-scale screenings, so-called pavilions or tents of health. I will tell you how it works in Moscow. First of all, may I show you this dramatic situation, which I'm sure is rising everywhere in every region of this country in Russia. And regrettably, for the first time in the last 10 years, we have seen natural population decline, overshadowing, and is something predetermines our further steps. This is what we have in absolute figures, over 12.5 million people officially residing in Moscow without suburbia. Over 3 million are women in reproductive of WOBC, women with childcare potential. And these are obstetrics clinics. Where I want to draw your attention to is, as I was telling you, out of half, over 40% only, are patients who are registered in the Russian 121 so-called female consultations or antenatal clinics, NCs. A large share of patients do not, for some reason, are not registered and never go to these ANCs. I'm not speaking about ANCs alone, I'm also speaking about outpatients clinics. That's why we thought we would put in place these called tents or pavilions of health on, so that they would become familiar to Muscovites. This is what we did. What is unique about this when we brought this together? These are a part of these ANC clinics, hospitals, and dedicated female clinics, and there's proactive support for patient, what it looks like. This very name of our Congress is Novel Technologies. They are novel. We carried out Project Healthy Moscow, and within a park, we see referrals that are registered in the registry. And as we analyze this data in a telemedicine center, patients get feedback not only about pathological findings that we discovered, but they also referred elsewhere to the physicians. We realized that we need to set in place an effective prophylaxis and prevention systems, but something that should be in close proximity to our patients. That's why we put in place 46 pavilions, or tents, if you will, in parks, in green areas, in recreation areas. What was our contribution? Almost 200 of obstetrics from 18 medical organizations that were referred to work there. This is what it looks like on our map of Moscow. Please note that depending on the needs and the size, we came up both with large scale tents as well as 37 small camps. They work from 8 o'clock in the morning to 8 at night. And we will extend this practice till the 15th of October. And the experience I wish to share with you right now, it's based upon less than 1 month that these pavilions have been around after they were set up. But right now we have something we could grasp. So this is what starts immediately at a park or this green area. Well, this is what these pavilions look like. Large and small pavilions, this is what they look like. We see they certainly differ in design, but what each pavilion or tent has, we can do vaccination there against coronavirus infection. We can, and I would like to support what Galina Mikhailovna say, I also got vaccinated against coronavirus, and I urge you all, those who haven't been vaccinated for a number of reasons, please do so. Any place close to you, for example, one of our pavilions. So again, as preparatory work has been done, and it took us several weeks to prepare, we came up with clear-cut algorithms in terms of what tests need to be and what workup has to be done, both for women and for males. The difference, of course, in terms of age, women under 39 and over 40, for sure. There are somewhat different workup algorithms, which is natural. To avoid excessive, unnecessary tests that were recently performed, we used from our database, we looked up what is it that the woman did recently in the last 12 months, if she did, of course. This is what these pavilions or tents look like. No, they are in very attractive sites. When people just take a stroll in the park, why not get into this tent? It will be short and it will be very nice. Anything between 47 to 60 minutes. So within 1 hour, you can get this medical checkup done for free, mind you. What is going on in the pavilion when a woman or a patient gets in? The first thing they do is a reception staff who inform the patient of what is going on to happen here, who provide necessary informed consent, consult the patients when they measure the temperature remotely, and they help patient. This is the first informat, or this informat, this display, so that the woman can answer the questions of questionnaire, because everyone in Moscow can get the data from their electronic medical record card. So they enter this system, they get information, they sign informed consent form, and then We identify the patient, and we, looking up at their medical record, we decide what can be done. 7 minutes, this is as long as it takes to answer the survey, and 4 different paths, 4 different questionnaires, depending on the age, sex, and based upon the findings, based upon what the patient put into these, on what he can do, we can further on come up with further recommendations. We can identify risk factors, and we can refer the patient to be seen by a specialist later on, and or say refer him for the test. So this algorithm or marshrutisation or routing, it is what we call pre-examination by a paramedic. The general practitioner may later see the patient having a lot of information at hand, so that he can take the right decision very fast, and can, this anthropometry, we look at the blood pressure, this is what these paramedics do, all these rapid tests that don't require a physician, but when he's seen by this paramedic, the patient comes out of this room with a lot of information on hand. A female patient is then sent to the examination room, where patients under 40 run an ultrasound of the breast, and a midwife takes a cytological smear from the cervix. A great attention is paid to the technology of how to harvest this smear. Each midwife was properly trained, so that we analyze what she does, so that we shouldn't get data that doesn't really give good information. Well, it is clearly described, and each member of the staff knows what they have to do and where to refer the patient further. Going back to the mammary gland, young patients get ultrasound of the breasts. Most importantly, all the findings are done using Beirat's scale. Further, the patient goes to general practitioner, where the doctor examines them, comes up with some conclusion, gives them recommendations on further lifestyle or further tests or further workup. Of course, we realize that further on, these patients will be sent via tests, findings, whatever was available later on. But if we discover something suspicious, for example, a suspicious mole, the patient is undergoing dermatoscopy right there in this tent. And later on, they will be sent by email or otherwise the tests findings. After the patient receives, this telemedicine center sends all this information not only to the patients where we discovered some pathological findings. The patients got this test, or if even case of positive things, the patient is informed that things are okay with her. But if we see some pathology, we immediately send this information to the local cancer clinic, or it may be this antenatal clinic and see, or any other. And the objective is to be proactive, to make sure that this patient should show up for examination. This is how we do audio or video consultation. We come up with the conclusion. The patient doesn't have to first go to her clinic and get a paper referral. No, we try to do it all, if we can, electronically, and do it as fast as we can. We try to move away from paper. From paper forms, we do it electronically. As we see, well, Beirat's or cervix after B test, we come up with the recommendations which explain what else the patient has to do and where she or he has to be referred to. Well, as I told you, we are coming up with the registry of patients. Both patients who had all positive findings, nothing bad about their health, as well as patients with pathological findings, they all go into this registry. And specialists from medical prophylaxis room, how they can cope with this situation. We see our mission not about holding this event and forgetting about it like one-time event. No, we want our patients to get accustomed to doing these tests regularly, so that the patients should be in line with this calendar. They know they would get reliable and robust information. This is how we support the patient. And there are single uniform protocols for examination. This is our electronic medical and analytical system. And we can see each patient, the stage they're in, which step they're on, how many investigations they have done, how much was needed. But most importantly, further on, this explains where the patient will be referred next, whether he or she will be sent for further examinations or therapy, both as basal screening as well as part of this, what we call onco-check, when we do screening for cancers. These patients would be further referred to. Well, this is a slide that requires greatest attention. These are the preliminary findings that we got in less than 1 month since those tents were open. First of all, overwhelming majority of patients who called in are women. They account for 70%. Almost half of them went through the so-called cytological examination, and in 202 patients were identified cancer at that. Please note, degree of malignancy may vary among those 200 patients. And further referral will be controlled by telemedicine center, and there's 202 patients whose results are available at hand have been already referred to be seen by oncologists. This is testing of the breast tissue. You see, out of over 12,000 patients, most of them were young, under 40. We identified 2 malignancies in the breast, and a certain number of patients, they require further tests and follow-up. At this, I would like to thank you for this opportunity, unique opportunity to take part in this significant forum. And if your family or friends or yourself go to visit one of our tents, we'll be incredibly happy to welcome you and show you what we can do. What are the capabilities there? Thank you very much. Thank you very much. Thank you. I do not see Gennady Tikhonovich online. Dear colleagues, now we continue with what we do. The plenary ceremonial opening is over. We're now about to start plenary session number 1. It will discuss endometriosis diagnostics, therapy, and rehabilitation. Anatoly Sergeyevich, who delivered a brilliant presentation, will certainly now stroll in the parks and will call on your tents. And thank you very much for your personal effort, what you do for Moscow, not only. It's always such a pleasure to talk to you and discuss the recent news and good things, and sometimes are nasty things that we have to discuss, but you're always there for us, always. So thank you very much, dear colleague. The first presenter on our list would be Philip Konings. He will open the plenary session, and he is fully entitled to do it. Philip Konings. Development of endometriosis. Dear colleagues, please, those who listen to us from abroad and all across Russia, since we're working online in RIA Novosti, this is the main news agency of Russia, this Congress is broadcast in 2 languages at all times, both in Russian and English. Please feel free to listen to the language you are comfortable with. And since people log in from all the countries, we cannot unfortunately be behind the schedule. Once this presentation is over, unless we cannot catch up, I'm sorry, we'll have to interrupt the speaker. So please mind the time, dear colleague. Philip, the floor is now yours.
Thank you, Professor Damian. It's so nice to speak about endometriosis, part of the visions we developed together. That's why I changed the title View of the Moscow Group. In fact, I have to explain a few things. Epigenetics. We all have the same DNA. All of our cells have the same DNA. We come from one cell. And then you have some differentiation, and this is the epigenetics. It means that if you have the chromosome and then DNA, the double-stranded, and then you have parts of the chromosome which are easily accessed, which are upregulated, and other parts which are becoming hidden. And this makes the differentiation of our cells. A little bit more difficult with stem cells. All the stem cells are not the same. A stem cell from the liver and a stem cell from the endometrium are not exactly the same stem cell. So embryologic rests are cells which have had some kind of differentiation, but not yet really differentiated. Metaplasia is a very difficult concept. It's just histology. And it means that the differentiated cell can differentiate into another cell. And then you see all this is, the question is, what is reversible and what is irreversible? And then you start to transmissible abnormalities. If something happens to the DNA, it becomes clearly irreversible. And then you have the last word is clonal. If in a series of cells you find always the same reversible or transmissible change, then you say it comes from one cell. Difference between macroscopy, microscopy, and molecular biology. This is top-down. It goes for the body, the organ, the tissue, cell. Molecular biology is bottom-up. And you see here in this interaction of cell machinery, there is not yet a good translation. And it's one of the discussions which we have sometimes about microscopy and histology. Nobody knows the accuracy of microscopy because it's the golden standard. And the golden standard you cannot compare with something else. Pathology is artificial intelligence. I heard speaking about artificial intelligence. This is the training of our brain. I would say today, all breast cancers are probably not breast cancers. And I estimate that of all women treated for breast cancer, maybe 20% never had a real breast cancer. It just looked like a breast cancer. So you see, and this explains also that all pathologists are not really agreeing. The translation of genetics, epigenetics into microscopy or vice versa is something which is still very difficult. For endometriosis, remember, it's the only tissue which is defined by routine pathology. It was done 100 years ago when we only had a microscope. And then you see uterus, drusen building and say all these adenomyoma, but the name endometriosis is coming from Samson in 21, and adenomyosis, you have to wait for 46 before you hear this. Pathophysiology, even 1800 and so many, they were talking about metaplasia. And then they saw retrograde menstruation, and you had the hypothesis of implantation. And then today we have genetic epigenetic. Still, this is incomplete, but we have to take into account fibrosis, retiar, and you see that some aspects like stomatosis are excluded by definition. This is very clear, so you make a hypothesis of attraction gravity. The day you see one apple who is falling upside, then the hypothesis is wrong. Endometrium and endometriosis, endometrium cells outside the uterus. There are many aspects which we know, the subtle, the typical, the infertility, pain, and so on and so on. I'm not going to recall this, but I'm going to try to explain to you that hereditary factors are probably the predisposition for endometriosis, but also infertility, immunology, pregnancy outcome, and so on. This explains that if you have surgery for women with endometriosis, the pregnancy outcome is not going to change because this is hereditary. And then you have infection, oxidative stress, incident, clonal tumor, and then they start to develop. Let me review this with you from the beginning. There is no animal model. The endometrium is the fastest growing tissue in our body, which means fast growing, high risk of errors. But each time there is an error, you have monthly eliminating of these mistakes. You have retrograde menstruation, And retrograde menstruation, there's no shedding, it stays there. The endometrium has a specific hormonal sensitivity, which we do not know exactly today, the difference between the basal layer and the functional layer. There is peristalsis, the junctional zone. I'll come back to this in a second. This is something very specific. You have the invasion of pregnancy, and if you do not have the change in the arteries, you get preeclampsia. So this is what is important. The endometrium is strange for other reasons. The endometrial cells are viable, but they are invasive. And it's a junctional zone which limits invasion. And the day you have done a C-section for an abdominal pregnancy, you understand exactly what I mean. When you put endometrium on the chicken allantoic membrane, you see it's invasive. And ectopic endometrium is much more invasive than any other cells of the body. On top of this, they are mobile. They go from endometriosis to the endometrium. We know very well that it is we know very well that endometriosis is an hereditary disease. I'm not going to get into detail. We do not know exactly what is important, but the genome-wide scanning has shown that most of the loci which we have are in regulatory reasons. You can have this pregnancy outcome. During pregnancy, you have small phodates, more severe endometriosis, does not reverse after surgery. And this is one of the things which is important for endometriosis. There is the cause and the consequence. Natural killer cells are low before surgery and remain low after surgery. This is probably the genetic origin. CR125 is the consequence of endometriosis. It's high before and it's low after surgery. And you have the classic data of rear of dioxin and endometriosis. Most important, I think, is that endometriosis lesions are clonal. It's one cell which develops in many other cells, which means in this cell, something has happened. And this is the reason why I would say today, the Samson implantation theory is the past. Because this clonal aspect, it means that we have seen an apple which falls in the other direction. And also someone is poorly compatible with deep endometriosis starting after menopause. It's poorly compatible being hereditary, does not explain and so on. This is the reason why we wrote together the genetic epigenetic theory. And in order to explain this kind of difficult slide, it begins with the cells is not important, endometrium, stem cell, bone marrow cells. This is carrying the predisposition, infertility, changes in the endometrium, so all the things which we have seen. And if they implant, at that moment they give subtle lesions, but I do not think on microscopic endometriosis, this is probably not yet pathology. Pathology begins when after this you get genetic, epigenetic changes because of oxidative stress, retrograde menstruation, and most important, infection. And this explains it's one cell who gets something wrong, and so you have clonal aspects and further development to typical and cystic and deep lesions. You have to understand very well that if you go from here to here, you take the motorway. If the motorway is blocked, you take a small way. But it means that you can have redundancy, that many errors can occur before they become visible. It means these incidents only after a certain moment, it becomes clear. So it's something which is progressive. You begin with some incidents, you add during life incidents until this one too much. And then you have a cell with a specific set of incidents, and this is the endometriosis cell, this is the clonal cell. It means that all the types of endometriosis are different. Some have estrogen production, some have progesterone resistance, some bleed, some don't bleed. And this is the risk of recurrences of new incidents. It's again bleeding in the lesion, and it's like breast cancer. Breast cancer is a series of clones because when the tumor develops, you get other incidents which occur. What I think is going to be very important in the future is infection. Women with endometriosis have more infections. They have an altered microbiome in the endometrium, in menstrual fluid, in the peritoneum. And in the endometriosis lesions, you have more HPV and molecules. To cut a long story short, this is the only explanation I have found today that exercise and food intake can have an effect on endometriosis. So with this, I explained everything what's coming from the hereditary and then what started in order to have a clonal tumor. But once you have a clonal tumor, he has to grow. And he grows in the environment of the peritoneal fluids. You have a lot of inflammation and growth factors around. You have bleeding in the lesions with another inflammatory reaction. And then growth is a self-limiting process. I'm going to explain this in a second. This is what experiment which has been done over the last 25 years. The angiogenetic factors, the bioassay of VEGF and TGF, cytokines, growth factors, low-grade inflammation, immunology of endometriosis. There are about 30,000 papers about endometriosis today. This was one of the very first experiments which was done about this. You have this kind of paper you put in peritoneal fluid, chicken allantoic membrane, and you see clearly the angiogenetic factors. Just to say, you do not always have to have very complicated experiments to demonstrate something. When we look at the data which we have in Leuven, this is about 5,000 patients, and you look at the area of typical endometriosis, and you see with age between 15 and 50 years, it does not change. And if you go for, this is the volume of deep endometriosis, it does not change. It means that endometriosis starts at some moment and then grows to a certain point, and that's it, and stops there. It means endometriosis is a self-limiting growth. Conclusion, initiation and growth has to be separated. The initiation is a genetic epigenetic incident. The growth and natural history varies with genetic epigenetic incident they start with, the environment, and the self-limiting growth. In brackets, but not yet accepted for publication. Recurrence rate is the risk of new incident, and it's unclear the immunologic changes and the importance of migration of endometriosis cell to endometrium. What is the advantage of it? What does it change for us? Is that we can reduce oxidative stress by oral contraceptives, continuous oral contraceptives, by antioxidants. We can modify the microbiome by food and intake and exercise. And I think this is something what's going to be important for the future. It means also that you have to individualize therapy. Not each lesion is the same as another lesion. There's no something like endometriosis. The endometriosis is specific pathology. And we know this already from cancer and chemotherapy. This means that we need to change also how we look at the data. If you have something that helps, endometriosis, whatever, and in 20% things get worse, if you do not look at the individual data, you will never know, because ordinary statistics are not good enough for that. With box and whispers plots, you could have an idea, but just remember, have to look at the individual data. This is the problem of medical therapy. Mean and standard deviation is not useful to judge. Maybe it's harmful in some women. And if you say complete progesterone resistance, it means you only give estrogens and you probably stimulate. Another reason to say we have to individualize. We already see that the progesterone receptor status are going to predict the response. I'm not going to get in detail here, but it seems to work clinically. This genetic epigenetic pathology is an additional argument not to delay surgery, including in the adolescent, but that's another talk, not to start IVF too liberally. Management of endometriosis is a benign tumor. Like all benign tumors, the therapy is surgery. The suspicion, that's how it starts. The medical therapy without the diagnosis for longer periods is something what I call a mistake. Try and see is the way to go. And then I would like to be a little bit provocative. What I think is that the periphery of endometriosis lesions are metaplastic cells, are not those which are genetic epigenetic changes. They look abnormal, but they are not abnormal. So already today, I think by discussing with each other, we begin that understanding the pathogenesis of endometriosis is something which is changing our therapy, changing our attitude to adolescent and endometriosis. And the nice thing, I think, is that after surgery, medical therapy to reduce bleeding and prevent recurrence is going the future. Thank you for your attention. Thank you for listening. And thank you for the invitation.
Thank you, Professor Konings. You are always on top of this subject to give the main aspects related to epigenetics in treatment. You are the best specialist in this field. So if you can stay with us until the end of this breakout session, please stay online. Thank you so much. Distinguished colleagues, our next presenter is Professor Kübker, Lübeck, Germany. Does adenomyosis affect fertility? Insights into a controversy. Please do not overrun your time, otherwise I'll have to stop your presentation. Professor Kübker is a professor at Lübeck Medical University, Germany. Does adenomyosis affect fertility? Insights into controversy. Well, Dr. Kübker, the floor is yours. Thank you. Looks like we have no connection with Dr. Kübker.
Hello? Can you hear me?
Mm-hmm.
Yes, we can hear you. Please go ahead.
Okay.
Please start the presentation.
You can see my slides? You see my slides?
Not yet, not yet, not yet. Not yet. Try to share your screen with us. There's the function screen sharing at the bottom. Click on it and the slides will be, yes, now we can, now this is just the Congress slide. Now we can see them, but they're small. We
Yes.
need a full screen.
Okay.
Yeah, we can see the slides, but they're not full screen.
But now.
Yes, now they are full screen.
Okay, thank you very much. Good morning. First of all, I'd like to thank the organizing committee and in particular Professor Adamian for inviting me once again to this wonderful meeting, but I deeply regret not being with you in Moscow right now. Maybe we have the chance in the near future. I hope so. So, ladies and gentlemen, I'm going to continue my lecture from January with the which was dedicated to endometriosis and the luteal phase, now with the topic of adenomyosis and its possible impact on the fertility status of our patient. So you heard a lot from Professor Koenig, so it's a little bit redundant, but I go on with my slides. So if you think that adenomyosis is a new disease, a new entity, this is absolutely not true. So Karl von Rokitansky precisely characterized adenomyosis already in 1860, and this was many years before John Sampson presented the background and the theories on endometriosis. Endometriosis and adenomyosis seems to be combined in any way. So there were a lot of controversial discussion if these are two entities or not or whatever. So, but if you look into the literature and in particular concerning and with regard our own findings, is that there is a coexistence of endometriosis and adenomyosis in up to more than 60% of our patients. So what's behind the scene? To go through this very quickly and comprehensive if possible. So we have 3 theories for adenomyosis. So how does this disease develop? So 1.1 is invasion from the endometrium, from the inner layer, from the endometrium into the myometrium. The second is the invasion from the outside, from the outer layer of the uterus. And this is quite interesting, in particular with regard to the development of endometriosis. Point 3 is the stem cell theory, that mesenchymal or precursor cells of endometrial cells invading the myometrium. So what's really true? Maybe all 3 theories are true. So to get a little bit more clinical, what is the pathophysiology for us clinicians? It is regulation of the myometrial structure, alteration of the myometrium. We find a disturbed uteral tubal transport, obviously alterated endometrial metabolism. The basis is inflammation, and maybe that may be the reason of alteration of implantation with regard to IVF outcome. Maybe there's an overlapping with regard to the endocrine function. What we know from endometriosis may be the same in the uterus, which is a decreased activity of estradiol receptor alpha, an increased activity of the beta receptor, loss of progesterone receptors, progesterone receptor resistance, inhibition of the 17-beta-HSD1, an increased local aromatase activity, which leads to a local estrogen dominance and an imbalance systemically of estrogen and progesterone in the natural cycle. So that may be the same in adenomyosis. Clinically, what are the symptoms? The same as in endometriosis, abnormal bleeding pattern, dysmenorrhea, dyspareunia, dysuria, dyskatia, recurrent miscarriages, and infertility itself, not getting pregnant. So gold standard is what we are doing, laparoscopy, to detect endometriosis as well as adenomyosis. And what we can see is a slightly enlarged uterus with a soft tissue with regard to the findings on an MRI, as you can see here, the irregularities of the junctional zone of the posterior wall of the uterus. So what can we find within the uterine cavity by hysteroscopy, standard classical hysteroscopy? Hypervascularization of the endometrium, strawberry pattern, submucosal hemorrhagic cysts, and some other endometrial defects. As depicted here on this slide, the formation of the strawberry pattern, areas of bizarre hypervascularization, or kind of cysts, likely chocolate cyst with a channel into the myometrium. This is the basis. What is already and nowadays done is MRI. You can see the differences of the junctional zone here in normal uterus and the irregularities and the thickness of the junctional zone in adenomyosis. But we as gynecologists, what can we do else? We can use high resolution ultrasound, and we can detect the same defects and patterns like in, or more or less better than an MRI, which is characterized as the asymmetrical thickening of the uterine walls, globular or asymmetrical. We can see lines and dots, echogenic islands, cysts, fan shaping, shadowing, the interruption of the junctional zone or the thickening of the junctional zone, irregularities of the zone, up to an increased vascularity of translesional effects. So it's depicted here. You see the posterior wall of the uterus with the chaotic hypervascularization of this adenomyotic areas here by power Doppler. These are rare cases. What to do with these cases? What you can see here with MRI is a real giant adenomyotic area of the posterior wall. So that may be an indication for a surgical intervention, as proposed by Osada already in 2011 after a large series of severe adenomyotic uteri, using his so-called triple flap method, which is a big operation via laparoscopy. But sometimes, and for everything, there is an indication for us gynecologists. To go a little bit deeper into the molecular events, there's a nice paper from Harara from 2016, and he compared differences of eutypic endometrium and adenomyotic lesions in adenomyosis patients. And the most striking is, and I think this is relevant and very interesting, that there is a downregulation of LIF, IL-6, and hoxatin. I think these three markers could be relevant, as well as in the adenomyotic lesions, the downregulation of LIF, which is important in concert with the STAT3 for implantation, as we know nowadays. So this is quite interesting and comprehensible. But if you go to other events, what factors are needed of a correct decidualization, so it's much more confusing. So I won't bother you anymore with all these substances and molecules. So we have to wait for further research what might be interesting as marker and as a target for treatment and medication. So, but on the other hand, what is really the genetic makeup and how many genes are relevant for what we need to know in IVF procedures? This is the implantation window. So is the implantation window in patients with adenomyosis displaced or not? This is a paper from 2011 by Martinez Conejero, but they only found 34 genes dysregulated in adenomyosis, and none of them were related to receptivity genes, most interestingly. And this was confirmed by a whole genome analysis in a paper from 2020 by Prasnikar, and he could confirm these findings as just a pretty few genes connected to implantation are overlapping and could be relevant in patients, in healthy patients, in comparison to endometriosis and adenomyosis patients. So is that true, that the window of implantation is impaired in patients with adenomyosis or not? Come to clinical outcome. A paper by Benalia, 2014, pregnancy rates in IVF. And he could clearly show that there was no significant difference between controls and patients with adenomyosis. Seems to be, from the bars here, even better implantation in patients with adenomyosis and consecutive pregnancies. In contrary to this, Mahayan published another paper in 2018, and the group could show that there is a difference with regard to the receptivity in patients with adenomyosis and non-adenomyosis. As you can see here, 47% non-receptive and only 21 in patients without adenomyosis. And that goes further to the fact of repeated implantation failure in the group of patients with adenomyosis, 66% changes in the implantation window in comparison to only 34 in patients without endometriosis. However, we don't know. So what are we doing on a daily basis in our institutes as we use the AirMap? We try to detect the receptivity concerning pre or post, or the correct day of receptivity using 48 genes, especially in patients with repeated implantation failure in adenomyosis patients. Moreover, we do a so-called IMAP, that means immune status mapping, with regard to some subgroups of the lymphocytes, the T lymphocytes, the natural killer cells, some cytokines, Th1, Th2 lymphocytes, B lymphocytes, and the CD4, CD8 ratio, and so on, to get an impression if the immunologic status may be impaired with an impact on implantation or no implantation. So we study that. Maybe we're gonna get a good paper out of this. What, as clinicians and obstetricians and reproductive endocrinologists, what do we have to take into account what we may encounter in patients with adenomyosis in clinic? And this is most relevant. So obviously there is a negative impact of adenomyosis. So what is being claimed is the reactivation of uterine inflammation, an altered contractility based on the increased levels of prostaglandins, altered placentation, miscarriage, as already said. Indeed, up to 40% small for gestational age fetuses, according to the literature, lower rate of term pregnancy, and this is a rare event, but obviously there is a higher incidence of uterine rupture. So this do we have to take into account as clinicians? And on the other hand, so what I could say, to put it in a nutshell, is my conclusion that for me, there are more questions than answers and no clear evidences, but we have to go on with our research, and maybe within the next year, we get clearer with this. Ladies and gentlemen, I thank you very much for your attention, your patience. Thank you. Best regards from my hometown, Baden-Baden, where I'm
Спасибо
sitting right
большое.
now.
Thank you. And thank you for sharing your view on endometriosis, and I very much liked your last slide and your last words. More questions than answers indeed. Adenomyosis nowadays ranks one of the top priorities in treating patients with infertility who has endometriosis, adenomyosis. Please stay with us online and mute your mic, please, so that we could continue. The next speaker, Professor Bishiaki Otto from Gynecology. Professor Otto Kurosaki, Japanese. When we look at pathogenesis of adenomyosis associated with uterine myoma, as by MRI in cinema regime mode, and please stay online and stay with time.
Thank you. I'm very grateful to Leila for giving me such a beautiful, wonderful opportunity. And I will wait for the day when the world becomes one again. I hope to go to Moscow and see you again. And so I will start my lecture. I considering pathogenesis of adenomyosis related submucosal fibroma. So uterine fibroids, adenomyosis are often associated. Each may occur by chance and coexist. There were cases of uterine adenomyosis associated with multiple uterine fibroids, suggesting that there are multiple origins of uterine adenomyosis. These cases should be diagnosed as diffuse uterine adenomyosis with multiple fibroids. However, it is doubtful that the two coexist by chance. Our pathological examination of such cases confirmed that the localization of uterine adenomyosis was almost continuous with UF1 type uterine fibroids. UF1 and UF2 types of uterine fibroids are present in the endometrium and uterine smooth muscle layer. We suspected that the formation of uterine fibroids at the boundary between the endometrium and the smooth muscle layer may have led to the development of adenomyosis. We may experience the fibroid delivery-related adenomyosis. There are cases where uterine adenomyosis is present around the uterine fibroid and causes myoma delivery. These symptoms occurred even after menopause and presented with very severe anemia. Pathological examination of fibroids in these cases revealed that uterine adenomyosis had existed the smooth muscle around the fibroids and even infiltrated into the fibroids. Pathologically, continuous adenomyosis regions were observed from uterine smooth muscle to uterine fibroids, and in all cases, serious deep endometriosis was observed during laparoscopic surgery. Therefore, we pathologically examined uterine smooth muscle, which is continuous with UF1 type uterine fibroids. If you look closely on MRI, you can see that adenomyosis is close to uterine fibroids. These adenomyosis pathologically infiltrated UF1 type uterine fibroids. However, no adenomyosis was found around other types of coexisting fibroid. Similarly, we examined uterine smooth muscle around UF3 and 4 types of fibroids, but no adenomyosis was found. I will show a cinemal MRI of UF1 uterine peristalsis. You can see that the uterine peristalsis is different compared to the normal side. A capsule surrounds the fibroid and it can be considered a different entity. This should capsule consist of compressed myometrium and contain nerves. It is not clear whether increase in should capsule thickness also increases the number of neuroendocrine fibers, but their presence may influence muscle contractility and uterine peristalsis. In particular, UF1 and 2 have a thick capsule and poor deformation acceptability. Therefore, uterine peristalsis may interfere with UF1 and 2 uterine fibroids. So we will suggest a hypothesis. The presence of UF1 or 2 type uterine fibroids affect uterine peristalsis and causes strong uterine contractions. Furthermore, since uterine fibroids are covered with thick capsules, they are less receptive to deformation and have a large effect on surrounding endometrium and muscular layer. In addition, in the background of endometriosis, TIAR occurs for minor damage to the surrounding endometrium and the uterine smooth muscle. Ischemia is also caused by strong contraction and uterine fibroids. These environments cause adenomyosis around the uterine fibroids. Further spread of adenomyosis reduce the strength of uterine smooth muscle around the uterine fibroid. And in addition, uterine contraction becomes stronger due to adenomyosis. Adenomyosis infiltrate the uterine fibroid beyond the capsule. When uterine fibroids grow, they may develop uterine fibroid deliveries. Therefore, we investigated whether the uterine adenomyosis around these UF1 and 2 types of uterine fibroids really has a background of endometriosis. We also investigated whether the pulsatility index of feeding vessel of uterine fibroids changes when uterine adenomyosis is present in the surrounding muscle layer. We pathologically investigated uterine adenomyosis around fibroids and their infiltration in 134 cases of multiple fibroids who performed total laparoscopic hysterectomy. In addition, the presence of or absence of deep endometriosis was investigated by laparoscopic findings. There were no significant difference between age and BMI. the size of uterine fibroids tended to be larger in UF2 and for UF3. There was also no significant difference in the number of coexisting uterine fibroids. These cases were divided into two groups in which deep endometriosis coexisted and a group in which deep endometriosis did not coexist. Then, in no coexisting deep endometriosis group, no cases of adenomyosis around fibroids was observed. On the other hand, in coexisting deep endometriosis group, uterine adenomyosis around uterine fibroids was observed 15% of UF0, 71% of UF1, 67% of UF2, and 29% of UF3. Infiltration of pathological adenomyosis into uterine fibroids was observed in 0% of UF0, 80% of UF1, 75% of UF2, and 50% of UF3. Therefore, it was suggested that adenomyosis-related submucous fibroids had endometriosis as a background. In study using transversal ultrasound, uterine fibroids displayed increased blood velocity, a decreased resistance index, and diminished pulsatility in their uterine arteries. A low uterine artery pulsatility index suggests greater blood flow to fibroids, facilitating growth. We extract the feeding blood arteries of uterine fibroids with color Doppler and measured their pulsatility index. Uterine fibroids, UF0, had the highest vascular resistance, and UF3 had the lowest. Regardless of whether the area around the uterine fibroid was normal smooth muscle or adenomyosis. The group with uterine adenomyosis around the uterine fibroids had a lower PI of the feeding blood artery of uterine fibroid. It has been reported that lower PI of the uterine artery, the more likely it is that the uterine fibroid will expand. Currently, we are also investigating changes in the size of uterine fibroids. So please forgive me that our research was not in time due to pandemic. So this time it was a proposal rather than the research result, but I will summarize it. There is adenomyosis-related UF1 and UF2 uterine fibroids. This requires that there is an endometrial background. The uterine adenomyosis-related submucosal fibroids can reduce the PI of uterine fibroids feeding arteries, leading to the expansion of uterine fibroid. The loss of normal muscle layer around uterine fibroids can also lead to fibroid delivery. If UF1 and UF2 uterine fibroids with deep endometriosis is present, attention should also be paid to the development of uterine adenomyosis. The presence of adenomyosis should also be considered during myomectomy. Thank you for your attention.
Thank you very much. Indeed, you always give us some unique data. I will never forget your video with pulsating uterus in adenomyosis and in without adenomyosis. And in this presentation, you put forward a brilliant thought that endometriosis is something that promotes expansion of uterine fibroids and may also provoke infiltrative processes. Thank you very much. Please stay with us. The next speaker on our list is Dr. Vatrelot. Dr. Vatrelot from Lyon, France. Dr. Vatrelot is an honorary consultant of London Royal Hospital and Hospital of St. Bartholomew in London. The title of his presentation is EndORA, Unique Association in France to Diagnose and Treat Endometriosis. Please, Dr. Vatrelot, it is a pleasure to see you and it is a pleasure to give you the floor. The floor is yours.
Hello, good morning, everybody. Dear Leila, thank you very much for your invitation again. Unfortunately, again, it is virtual. Hope that next time it will be in reality. So I start to share my screen. I hope you can see it, but I have to pull my full screen. So for today, it is not really what I will say scientific paper. It is more an informative paper. I thought it was maybe interesting to demonstrate how we may organize to take in charge endometriosis in my area in France. First of all, to say, so just 1 minute, to say that the fact that everybody knows endometriosis affects 10% of patients in procreative age. Until recently, at least in France, it was estimated that diagnostic was delayed by a margin of 7 years. And as you know, it is a difficult surgery which needs to be performed by skillful surgical teams. So we need a faster diagnosis, a better treatment, excuse me, especially for deep endometriosis. We need also a multidisciplinary approach and probably a therapeutic approach, which could be similar to what we do to cancer organization of care. So in France, the Ministry of Health in March 2018 decided that we have to establish regional network in French territory to take care of endometriosis. And he designed 3 pilot regions, one Paris, of course. The second one was Rhône-Alpes-Auvergne, where there is 8 million of inhabitants. It is my region. And the last one was in the south of France, close to Marseille. So the prerequisite for the network was he has to be regional. He has to associate the public and the private hospitals. And that was something which was in our country very important to consider. And we have to establish a fine territorial grid to be as close as possible to the patient. So the organization, we have, first of all, at the top, a pilot centers. In this case, it was the University Hospital of Lyon, and then we have below the expert, what we call the expert centers. So what is the definition in our mind of an expert centers? It is he has to have a complete team, gynecologic surgeon, of course, colorectal surgeon, urologist, radiologist specialized in US and MRI, ART specialist, endocrinologist, psychologist, pain specialist. And this team should be able to organize a local, what we call the RCP, which is a consultation specialist meeting, like we do what we take care of cancer. And this local RCP has to be done roughly every 2 weeks. It depends on the size of the expert centers. And every member of the centers should be signatory of the EndORA. EndORA, it is ovarian, Rhône-Alpes, endometriosis, EndORA chart. I will show you that in a moment. So the organigram of the network, there is a board of directors at the top with the president, 3 vice presidents. One, it is in private sector, it is myself, a treasurer, and the general secretary. And then we are split in college of gynecologic option for surgery, option medicine, colorectal surgeons, urology, radiology, once again, infertility others. And when it is important, we also have associated the patient associations. In this case, we use the 2 bigger association of patients in endometriosis, which is Endo France and Endomide. And we think that it is something very critical because these patient associations can bring to us some very important information for patients and sometimes because we may be wrong in some aspects. So we consider that to include patient association is really fundamental in this network. Then we have to be signatory of the chart, the Andorra chart, and the signatory agrees to participate to local consultation meeting, as I explained to you, and at least once a year to regional one, because you organize, I will say, big meeting every month or every 2 months, where we discuss the more complex cases. We have to keep, the signatory agree to keep a register of activity, to send back the patient after endometriotic treatment to the physicians or midwife who have referred her. But it is an important part of deontology, not to keep the patient, but to send back to the doctors. It is important to create confidence with all the sector of medicine. And also to participate at least once every 3 years to a specialized congress on endometriosis, like yours, for instance. And then lastly, to promote Andorra nationally and if possible, internationally. And if you are a member, expert member, you receive this kind of documentation every year, which means that you are the signatory of this chart. So what are the Andorra missions? There is 4 Andorra missions. First of all, territorial organizations, comprehensive care mission, thirdly, communication and educations, and 4, research and evaluation. First of all, the territorial organizations. So the reference center, which is at the top, federates the expert centers, produces the directory of members, signatory of the chart, and what it is also important, links with the health authority. In our case, it is the regional health agency, which is, the body we govern all things concerning the health. And also, these reference centers define with the expert centers the patient's care pathway. That also is important to see what is the best pathway for the patient. You see the directory in our area. We have 163 expert members spread in 15 hospitals, 5 university hospitals, 2 general hospitals, and 8 private hospitals or clinics. So you see the repartition is quite homogeneous between public and private sector. Then the comprehensive care mission. So there is the organization of local and regional meeting of experts to discuss all complex cases. And that it is very important to be able to present your cases when you think it is a difficult one to be reviewed by people. And of course, we do that after explicit consent from the patient. We cannot present a file of a patient without agreement and consent from the patient. The regional consultation meeting, we do that on a regular basis. Locations of this meeting change every time to give opportunity for every hospital to organize such events. Now with the pandemic, and I think we will continue probably after, we do that via Zoom, which is very convenient, and we do that also on site. And of course, we review only the complex deep endo cases, because if not, we have too many cases, it is impossible. All MRI are reviewed during these meetings, and decisions taken by the group are recorded, and in fact are only strong recommendations. We cannot impose our view, but we strongly recommend that the doctors who present the case follow what had been said during the consultation. The third mission is the communication and education towards doctors, teaching and e-learning for primary care physicians, meeting organization. It is important because we have some, I will say, junior expert who wants to become more specialized in endometriosis. Then we give them the possibility to have some kind of educations, and we have a lot of e-learning, of MOOC, everything to help them to be better. And also toward patients, that it is important, that it is on the website. First of all, the patient's signatory of the chart are labeled, which means that the patients know that the practitioner that she is going to see is, a member of the network, which is important to be sure of the, I will say, the quality of the treatment, and that it is probably an important role. And then we have the last mission, which is the research and evaluation, which we have organized in 4 levels to allow every structure, even small, to participate. The level A, it is to design and realize some RCT, which is, of course, as you know, important for research. Level B is the production of thesis. Level C, participation to multicentric trials. And level D, participation to database and the registry of activities. So, as you may imagine, the level A and B are more for university hospital, for RCT and thesis. Level C, it is for motivated, either public or private hospital, because we may participate in private to multicentric trials, obviously. And the level D, it's important because it is mandatory for every expert centers to participate at least to the database and the registry of activities, which is important to know how many cases we do and what is the activity of every center. And so lastly, to say that the first results are, I will say, encouraging, because the network starts in 2019 and is in full activity since 2020. It has served as a prototype for other French areas. It means that now on the same basis, more and more we have the other regions of France. We have already in Southwest, we do the same. Probably Paris will follow. And so on the same basis, organization of treatment of endometriosis is now done on this basis. It has been recognized and financially supported by the French Ministry of Health. It is important because when you do this kind of network, we need some help. You need some, administrative things. We have to have an assistant. We have to have a website, everything, which costs some money. And for that, the French Ministry of Health was happy to contribute, which was not the case until recently. So now they recognize the interest of this approach. And already we estimate that the network takes in charge around 70% of deep endo cases, which is good. Of course, the target is very quickly that no endometriosis was not taken in charge by the network. So to finish, I will say that thanks to this network, we hope to avoid in the future the disastrous management of endometriosis, which is still frequent. And I thank you very much. And spasiba.
Thank you very much. Thank you, Professor Waterloo. A very interesting experience. I've been listening very carefully to what you say, because as a true director, you always present such lessons to us that we could take over. You are a wonderful specialist, a surgeon, oncologist, and you also work on endometriosis. And this is a voluntary association community that helps the Ministry of Healthcare France, so that in some extent you could control the cases that your region may see. All the recommendations, they are so very much. Are they recommendations or can you influence them? I mean, when you issue recommendations, do people have to follow like a mandatory? Your recommendations, are they like a recommendation, or do you have the power and authority to like issue mandatory things where people have to listen? It's really good experience. You seem to be identifying difficult to treat patients. You look to which extent they are properly managed or not. You are a figure of authority, but will they be listening to you? What is the mechanism of working for this? Do you understand my question?
Yeah, of course, yes. Thank you, Leila. Yes. In fact, the recommendations are, I will say, strong recommendations. And when we have so many, I will say, prominent doctors saying we should do that or that, we cannot see people not following your recommendations. But we have not, in fact, the authority of the power to impose what we are saying. But probably, if the doctor don't follow, I will say, our rules, I think it will be very difficult to continue to work in this network, and because it is the basis. The basis is the confidence between members and the confidence between the expertise of the management and the management of the whole persons together, coordinated together to discuss the case. So when we have an opinion, it should be probably shared by the doctors and followed.
Thank you very much. I ask you this question because you saved some time. That's a unique experience. Thank you so much, Professor Vatrilo. I think in your region soon there will be no severe endometriosis cases. Thank you so much.
Thank you.
Our next presenter is Michelle Nusol-Leeuwen. Why should we choose shaving in case of abdominal endometriosis? I'd like to introduce Professor Nusol. We've known each other for a long time. When I worked with her in Leuven and she had the chance to work with me. She is in charge of the Citadel Hospital. She is in charge of the Department of Obstetrics and Gynecology, University of Liège, Belgium. And Professor Michelle Nusol is the editor-in-chief of a journal. Please, Professor Nusol, the floor is yours. Why to choose the shaving procedure for bowel endometriosis, please?
Good morning. Firstly, I would like to thank Professor Adamian for inviting me and for organizing this wonderful meeting for many years. So it's not a research, it's more a review of the literature. I have no conflict of interest, and the learning objective are to describe the different techniques of endometriosis surgery and associated complication, and finally to discuss with you or to share with you my preference for the technique for bowel endometriosis. We know that the treatment of colorectal endometriosis is always a challenge because we know that medical treatment could provoke an atrophy, suppression of the symptoms, but it is associated with side effects. And we know also that there is a relative ineffectiveness because there is a high fibrotic reaction. Here you can see a normal bowel biopsy, and here you can see the endometriotic lesion infiltrating the bowel. So medical treatment is unable to remove this lesion. So we know that the lesions are usually multifocal and also associated with other localization. And I will show you some examples. And we know also that it's very important to take this anatomical consideration because it could increase the risk of surgical complication. So when we speak about associated surgical procedure, on the left, you can recognize very well the ureter. And as usual, I will also show you some magnific use of the CO2 laser. You can see that we are very close to the ureter. And in fact, in this patient, we removed the right uterosacral ligaments because the surgery was not complete. And even if we are close to the ureter, we don't mind because we know very well how we can use the CO2 laser. On the right, you can recognize the hypogastric nerve. So it means that sometimes you could have complication due to the lesion that you are treating with the deep lesions. So if we come back to the definition of bowel endometriosis, we know that if the muscularis is infiltrated, superficially, we could speak about superficial bowel endometriosis, and in this case, we will perform a shaving. So in this patient, we will perform a shaving, even we have the impression that the bowel is completely infiltrated by the lesion. Here you can see again that we are using the CO2 laser, the red spot is there. You can see here the fatty tissue of the rectum. And this patient has a nodule of the posterior cul-de-sac of the vagina. So it means that we push with a sponge into the vagina in order to find a good plane of cleavage. And I will show you not completely the surgery, but until the reaching of the posterior wall of the vagina. So you can see that by using the CO2 laser, the surgery is precise. In this case, there is no risk of a bowel lesion because the bowel is not infiltrated, but only the fatty tissue has to be removed. And I think that it's very important to remove, in this case, both uterosacral ligaments because we have seen at the beginning that the uterosacral ligaments were infiltrated by the lesion. Here you can see nearly the vagina. We are pushing and we are continuing the section until reaching the vagina. And in this case, we will remove a part of the vagina because the lesion was located there. And the tissue just up on the trocar, in fact, this is the torus uterinum, which also is infiltrated by endometriosis. Now, if we see that the muscularis is infiltrated by endometriosis, we can speak about deep bowel endometriosis, and for that we will perform either disc resection or a segmental rectal resection. So in fact, the difficulty is to analyze exactly the infiltration of the muscularis of the bowel, because sometimes we could also propose a deep shaving in such patients. So in my department, when we have bowel lesion, we will perform the surgery first, and after the general surgeon will come. So in summary, I will begin by cutting both uterosacral ligaments on the right side here. You can recognize the bowel is enlarged. So we are pushing the bowel, and I am cutting the right uterosacral ligaments. You can see the typical aspects of the lesion, and here we can feel also the left uterosacral ligaments. And the lesion is very in the center, so there is no risk for the ureter in this patient. So we are protecting the rectum with the trocar and the Manès forceps. And by cutting the uterosacral ligaments, later we will have more mobility to perform the dissection. So it's important to push a sponge into the vagina. And here you can see the plane of cleavage between the bowel and the vagina. And we can cut clearly with the CO2 laser without nearly any danger. So we are going very slowly. And at a certain time, we will see the vagina, and it means that we are in the right plane. So in this case, I would say it's not easy shaving, it's a deep shaving. And the risk of a bowel lesion is not zero, so it means that you must be very careful. And in fact, here you can see on the right that it's very important also to cut the uterosacral ligaments. Otherwise, the patient could come back because the pain is coming back. So here you can see the bowel, and we continue the section with the CO2 laser. So normally you can feel the lesion, and you can also see the type of the tissue that you are cutting. And here again, you can see the uterosacral ligament that we are grasping with the forceps in order to know, in order to perform the complete section. So here we can see that we are in the good plane. The tissue is soft, and we can continue the dissection. So the first step is the rectal dissection. In this case, I will remove a part of the vagina, but we know also that if there is an associated vaginal resection, the risk of fistula is also higher. But nevertheless, if there is a nodule into the vagina, you have to remove it. I will pass. So this is important because you can see the uterosacral ligaments, and do not hesitate to remove it because you can see that it is infiltrated by the lesion. And if you don't remove it, the patient for sure will come back for recurrence of pelvic pain. So the vaginal resection is performed by the gynecologist, and after we are calling the general surgeon to perform the colorectal segmental resection, and of course the transanal anastomosis. So this is a classical surgery, but for medical legal reason in Belgium, we are doing that with the general surgeon because in gynecology, we are not so well trained to do that type of surgery, but I think that everybody knows this type of surgery. But I think it's very important to keep in mind that during this step of the surgery, the traction on the rectum and on the bowel must be as slow as possible, because we can have complication and leakage of the anastomosis due to a high tension at the site of the anastomosis. So this step seems to be easy, but nevertheless, we must be sure that the traction is very low. So now if we analyze the results in the literature concerning shaving and the bowel surgery, we know, thanks to the snapshot realized in France, evaluating more than 1,000 patients. It was a multi-center series of more than 1,000 patients. And you can see that the percentage of patients with fistula was higher in the group of patients with segmental resection, because it was elevated and estimated to be nearly 4% of cases. And the most interesting thing in this slide is that you can see that in France at that time, more or less 40% of the patients received a segmental rectal resection, which seems very high. If we would like to speak about complication of colorectal surgery, we could make a distinction between minor and major complication. And of course, the anastomotic leakage is the major complication that we can encounter in that type of surgery. And this is a case of a patient who was operated during live surgery and during a congress, and 2 days after she has a problem, and I was obliged to reoperate the patient, and you can see that there is a fistula on the right side, and it was very complicated to solve the problem. So you can see here the typical aspect of the leakage of the anastomosis. And for the infertile patient, it was a very bad story, because she's not pregnant, and probably she will refuse to be pregnant in the future. So I think that the message of this video is that if you have a patient with a colorectal resection performed, you have to follow the patient, and do not hesitate to perform a laparoscopy, because the patient was not painful. It was because the biologic control was abnormal that I performed the second loop laparoscopy 2 days after the surgery. But if we know very well the severe complication and the major complication, we have also to speak with our patient about the late complication. And I think that the risk of chronic constipation and chronic diarrhea are important to explain to the patient, and also the functional complication related to pelvic denervation. And in fact, if we look in the literature, the team of Michel Canis observed a rate of complication, major complication, and you can see here the details of those complications. But in fact, what is important is to have a rate of complication, and the rate was estimated to be 9.3% concerning the postoperative major complication. And more interestingly, the shaving is associated with less complication than segmental resection. So the first message is that the shaving is associated with less complication. Another review of the literature performed by Meuleman in Leuven, comparing many patients, because they analyzed 49 studies. And in fact, you can see also the rate of postoperative bleeding, the rectovaginal fistula more or less 3%, and the leakage 1.5%. And again, the rate of complication is related to the bowel resection, but also to additional surgery, as I explained at the beginning of my presentation, ureterolysis and dissection of the hypogastric nerves and so on. So now, if we want to speak about the bowel dysfunction, what is better, radical versus conservative surgical technique? And to answer to this question, we have many papers of Horace Roman from France. And in fact, you can see here the paper that he published a long time ago. But if you he compare patients with colorectal resection and shaving, and in fact, you can see that the rectal conservation, so it means the shaving, seems to improve delayed digestive function and seems also to reduce the risk of postoperative constipation. Because sometimes when we decide to perform a bowel resection, the patient will come back many years later for chronic constipation and disease for life. Concerning also a study of Roman, who analyzed the quality of life concerning the bowel symptoms, he demonstrated that the rectal shaving is also associated with a good improvement of digestive function. This is also the same conclusion and also the same author. And in fact, I think that this one also published by Horace Roman for me is the most important one of my presentation. If you analyze the postoperative complication according to the type of surgery, you can see directly that the segmental colorectal resection is associated to the highest risk of complication when compared to the shaving and the disc resection. So for us, for many gynecologists, I think, we have to propose the shaving whenever it is possible. Again, here, a study performed in the UK by Dominic Byrne. And also you can see here in the second line, the patient who receive a shaving technique has the lowest rate of complications. I published 2 years ago with my team a proposal to choose the right technique for deep endometriosis management. And in fact, in cases of bowel endometriosis, we need to perform the diagnosis, the transvaginal sonography. In Belgium, we are using also the barium enema and also the MRI. According to the results of the preoperative management, we classify the bowel endometriosis as superficial, and of course, we will perform a shaving. But in many cases, we will discover deep infiltrating endometriosis, and we will decide to perform the surgery according to the symptoms of the patient and according to the consent of the patient. Indeed, there is no need to perform a bowel resection if the patient has no pain. And I think it's very important to tell to the patient. And according to the patient consent, we will perform the bowel surgery with explaining the type of complication. And sometimes, if the patient refuses the bowel surgery and the risk of stoma and so on, we will perform a shaving. It means that we will perform an incomplete removal of endometriosis. This year, the father and the son Donnet published a paper concerning the shaving and the place of the laparoscopic shaving. And I would like to share with you some points interesting. So the shaving technique is feasible in the majority of cases, is associated with low complication, and more importantly, is the shaving does not induce long-term bladder dysfunction and preserves pelvic nerves, and the recurrence rates are comparable after shaving and bowel resection. So as a conclusion, I would say that the decision has to be taken according to the extension of the disease. The final decision has to be taken by the patient, and the aim of the surgery is for sure to decrease the symptoms and usually pain symptoms, and for sure to avoid major complication. But we have also to take in mind that complication can also occur in cases of shaving. I thank you for your attention.
Thank you, Professor Nissol. We know you as a brilliant surgeon for many years. And just a brief 3 questions and the quick answers. Could you tell me, please, after this procedure that you have demonstrated, do you use hormonal treatment, post-operative hormonal treatment, yes or no? If yes, what kind of hormonal treatment?
Okay, usually yes, Professor Adamian, because the patient are consulting for pain, and my preference is progestin continuously.
Thank you very much. Second question, you've shown that you use the laser. Is it the standard CO2 laser or is it the fibro laser that we also like? What kind of laser is it?
Okay, it was the CO2 laser articulated arm because the fiber is very expensive and fragile. So the articulated arm is connected to the laparoscope and it's very easy to use.
Thank you very much for the brilliant presentation. Dear colleagues, Professor Bergener, Vitaly Bergener from St. Petersburg, the chief obstetrician gynecologist of St. Petersburg, head of the Department of Obstetrics and Gynecology, treatment personalization in the long-term management of patients with endometriosis. Vitaly, the floor is yours. Well, good afternoon, dear Professor Damian, distinguished colleagues. Unfortunately, we are online, but hopefully we are connected through the genuine interest to our specialty, our profession, our love of surgery, and the queen of Russian gynecology, Professor Adamian, brought us all together today. Leila, thank you for this opportunity to participate in this wonderful Congress. And I would like to present the data personalization of therapy in the long-term management of patients with endometriosis. It was a pleasure for me to listen to Professor Nisol, and many things that she showed, they're very close to me, especially when she prefers long-term therapy with progesterone. That's today's trend. And this trend is not just because of I have the same opinion, not because we have monographs and publications, but also it is written into clinical guidelines published by the Russian Society of Obstetrics and Gynecologists. And we pay attention to the fact that endometriosis, first of all, requires long-term treatment of patients, despite the fact that we love surgery, despite the fact that we know the importance of surgery. Nevertheless, the long-term remission of the disease depends on this long-term approach as far as treatment is concerned. And this is also important from the legal point of view, because as for the clinical guidelines, and of course, Leila participated in the development of Russian guidelines, as well as the members of your team. Their role is very important because these guidelines contain the data of randomized clinical trials, as well as a routine clinical practice data, plus the publications by world experts, global experts that are taken into account as well. Well, what can we do to achieve a long-term remission? The surgery and the medical treatment, two components of this strategy. Most experts believe that well, the surgical treatment must be very well balanced. And in our clinic, when we're talking about ovaries, we try to stop using any energy. Right now, I can have the opportunity to use the CO2 laser. That's very interesting energy, but nevertheless, that's warmth, that's temperature, and you can see the ASHRAE recommendations, ESGE and World Endometriosis Society. Well, the key is bipolar coagulation or any other coagulation, but pointy coagulation, and that's identification of the dissection layer. If we're talking about the cystectomy from the point of view how it can help the patient require motherhood and not just have the premature ovarian failure. In this case, we must avoid the portal blood flow and the flow from the portal vein. In talking about the recommendations for the surgical treatment of endometriosis, and Michelle Nisol is also one of the co-authors of these ASHRAE guidelines, and the conclusions that were made here are very important concerning this type of endometriosis, which is the most difficult in terms of surgical intervention. well, this is an important surgery, is an important component of treatment. It is not successful in some cases because it's a complex surgery. There are clinical risks due to the fact that endometriosis is not a homogeneous disease. A patient with the disease erectocervical endometriosis, well, that means different patients, and we're trying to pay more attention to preoperative staging from the point of view of the use of evidence-based medicine. When we use a 3D ultrasound, MRI, CT tomography, we pay a lot of attention to imaging, but nevertheless, such factors as the skills of a surgeon, the localization of the disease, not just from the point of view of autonomy, but also from the point of view of damage to adjacent structures such as nerves are very important. Here is our experience, more than 3,000 surgeries, a lot of severe patients. Well, you can see 75% of patients, well, that's endometriosis, extended endometriosis, and 27% are severe patients. Well, retrovaginal, infiltrating endometriosis. You can see these are traditional cases for oncological surgery, and the only difference is that our surgery is not the surgery performed on the cancer patient. Usually our patients have chronic pain, more than 40% of women, and every fourth woman who comes to us for infiltrating endometriosis has problems with the reproductive function. So we should find a balance here, radicality and precision. There should be a balance. What is happening in reality? Here you can see the data we obtained recently. Well, you can see a lot of patients who have 1, 2, 3, and more surgical interventions. So this worsens the situation. The second trend, or the second feature, is that 37% hospitalized at our university clinic, and we've been dealing with endometriosis for a long time. We have a multidisciplinary team, so these are patients who did not get any treatment at all before. And you can see these are infiltrating endometriosis. We have to work on the bowel, on the rectum. We do shaving. We have adhesions. We have myoma and adenomyosis at the same time. And only 34% of patients get pathogenetically justified therapy. That's not an excuse. Well, 37% get nothing, 12% recommend that they get pregnant on their own, 4% are sent to reproductive medicine specialists, and well, you can see that more than 60% of patients, which is shown in blue, those who get the COCs, do not control the condition of endometriosis during the first year. There will be 63% of relapses. So the questions of long-term remission and long-term therapy become very important. As of today, in ASHRAE recommendations and Russian recommendations, progestogens are first-line drugs. In principle, we, unlike our Canadian colleagues, have a large spectrum: dydrogesterone, dinogesterone, noreltesterone. All these histogens are effective, but they have different safety profile. Dihydrogesterone is the only one we have which can be used for pathogenetic treatment of endometriosis that doesn't block ovulation. And that's very important, especially if a woman wants to plan pregnancy. Progestogen effect is very good, anti-estrogen effect is excellent, but if we're talking about anti-androgen effect, of course, dydrogesterone has advantages, especially when we take into effect that the therapeutic dose of the drug doesn't block ovulation.
So what the Russian group of experts did, led by Leila Adamian and academician Sukhir, we have demonstrated that this effect of ovulation blocking for patients with endometriosis who are getting ready for long-term therapy is a matter of principle. Patients in the Orchid or Orchidea trial were suggested participation in extension study preferred some cyclical options. First of all, it was a stumbling block to us how much effective would be unlike the continuous regimen, but it was shown that both regimens for over the 350 patients, they are both effective. Their efficacy compares well in terms of chronic pelvic pain. But that cyclical regimen has a more favorable safety profile, given that we need to leave in place menstrual-like reaction and ovulation. We continued it among the patients who were in the orchard, didn't want to fall pregnant. Please note, we carried on for another 12 months. We would call it Orchard Plus. Of course, it has unofficial name. And we saw that the intensity of dysmenorrhea, dyspareunia, and chronic pelvic pain after 12 months of therapy, something pretty interesting. It has even further improved the situation, both in terms of intensity of pain. For example, dyspareunia, we didn't basically see it after a year of therapy, as well as in terms of improving their quality of life. Please note the emotional, physical well-being, general activity levels have gone considerably up in such patients. And against the backdrop of the dihydrotestosterone, we would see the intensity of dysmenorrhea both in NRS as well as in VAS has improved, and it had significance. Please note, these 6 months in post-op demonstrating you the quality of life survey, FSFI, we could customize and individualize our approach depending on the endometriosis associated pain, depending on the reproductive plans, age, and clinical and morphological special features of endometriosis. I was showing previously which are variants we identified. We suggested patients would go either of the 3 ways: 20 milligrams per day from day 5 to 25, then 5, 25, 20 milligrams, 2 cyclical regimens, and 20 milligrams just continuous. This is the most difficult to treat patients would get this on a continuous basis. Please note, when the patients could, together of course with the physician, to somehow explain their choice, they would much rather have 20 milligrams from day 16 to 25 in a cyclical, uninterrupted manner another 6 months after prescribed therapy. Not only did we see improvement in terms of pain and quality of life, but in terms of further reproductive plans. Those patients who have patent fallopian tubes and the presence of a fertile partner, 62% would spontaneously fall pregnant. Please note here, this percentage, we didn't discontinue therapy. We just went to support of luteinic phase with LP, with dihydrotestosterone, and we improved the optimum condition of endometrium for embryo implantation. 90%, as you see, was IVF successful, and 90% failed IVF, and we continue to work there. May I note the data that we got back in 2015, we are fully supporting them, Orchard and Orchard 15, for patients with severe endometriosis, combined therapy, both surgery and further drug therapy with progestogens, is a way to pregnancy. Of course, it is important, but the patient has to carry the pregnancy to term and have a baby, deliver a baby. So the patients in the presence of this adequate approach to therapy would carry their pregnancy much better, and so much this myth or reality. Pregnancy endometriosis is something that certainly deserves a very close attention. So, dear colleagues, the findings. What we have shown you shows how effective it is to use dihydrotestosterone 12 months post-surgery. We saw statistically significant decline in endometriosis-associated pain, better quality of life, satisfaction with sexual life, and high reproductive function. And for the first time, probably, when we use progesterone drug, we can customize approach to treating endometriosis depending on clinical situations, which may vary so greatly, as you can imagine, in such a severe disease as endometriosis is. May highlight that in absence of further reproductive plans, we continue the patients should carry on therapy, and they're still on therapy. If they want pregnancy, we changed the regimen to support only the LP, only up to 25 weeks of pregnancy, so that this long-awaited pregnancy should end in delivering a healthy baby. So dear colleagues, please join us in St. Petersburg in October so that we could continue to discuss endometriosis on the website, on the sites of the northern capital of Russia. Thank you very much, Vitaly Fedorovich. I suppose you would save us time and I would ask you questions, but unfortunately, well, one question for you. You're a surgeon, a brilliant surgeon. You have worked a lot in endometriosis at every country and in your clinic too. Endometriosis, is it a surgical disease or is it just something to be treated only by hormones? Surgical, surgery, I see. Why is it surgical? Because morphological substrate of endometriosis under no other therapy would go away. Unless and before you cut it out, excise it, or whatever, with burnt iron, I would put it. Exactly, I fully support you. Hormonal therapy indeed helps to recover different parameters, including removes pain syndrome, improves and relapses. Thank you so much. It is my great pleasure now to give the floor to Professor of RAN, Russian Academy of Science, brilliant surgeon, leading fellow of my department, Andrei Vladimirovich Kozachenko, who would discuss the results of multi-center study of efficacy of dydrogesterone in endometriosis, ORCHID. Time, please. Distinguished chair, distinguished colleagues, first of all, I would like to thank you for the opportunity to present the findings of our study. It was an open, multi-center observational study on the efficacy of dydrogesterone to endometriosis. I shall carry on what the previous speaker said. I would just discuss it in greater detail. What was the rationale for this study? It is well known that in the last 6 to 7 years, we have seen a change in the paradigm of care. We are now relying upon novel guidelines to improve the quality of life, decrease pain syndrome, decrease repeat operations in this. The gestogens are considered to be as frontline therapy to treat endometriosis. By the start of this study, they analyzed literature findings on what were the trials on dydrogesterone for endometriosis. And they identified 17. Two of them were double-blind, placebo-controlled, one blind with placebo control, 2 randomized in parallel open groups. Dydrogesterone is a drug that is approved to treat endometriosis in over 100 countries of the world. And it's so important that it is easily accessible and affordable drug too. For the first time, the fundamental discussion of the concept of the study was done on the 27th of June of 2018 in Yaroslavl at the Regional Forum Mother and Child. We sought to get supplemental data to come up with personalized therapy depending on the current needs of a patient. From the very start, we came up to study both continuous intake of the drug as well as prolonged cyclical. So it was registered at clinicaltrials.gov. This protocol was approved by the experts back in 2018, and the resolution on this trial was published in Russian specialist journal on problems of reproduction, and it was named ORCHID, Orchidea in Russian. So baseline, it all started January 2018, where we started to work on the protocol. As we said, 2018, June, approved, so the approval at the meeting, the expert meeting, and by September 2018, they started to accrue patients. Patients were recruited, all in all, 355 patients. Last patient in October 2018, and analysis of the data was started in September 2020. First publication came out of preliminary findings. 18 months ago, we reported first findings of the study at an international congress held by Leila Damian led, and it found the interest of our audience. In our specialist Russian journal, we published key findings of the ORCHID trial. This is a list of researchers and investigators. The investigation covered basically all the regions of Russia. This slide shows not only Central European Russia, but southern regions, as well as something beyond the Urals. Siberia took most active part. We include not only departments of OBNG, but we just worked with plain clinical units. This is the design of the trial. Number of patients recruited 350. All of them had histologically verified diagnosis of endometriosis after operation. At any times, stage 1 was surgery. The patient had 3 visits. Why? What was the purpose? To evaluate efficacy and effect of dydrogesterone on chronic pelvic pain. And secondary endpoints were quality of life, length and regularity of menstrual cycle, dysmenorrheic syndromes, marked chronic pelvic pain, and impact on sexual behavior as well as pregnancy rate. What I want to say that this group included only women in childbearing potential who complained of pelvic pain in the last 2 months. Those who had marked chronic pelvic pain syndrome and histologically confirmed endometriosis. We, of course, criterion of exclusion was chronic disease that required long-term parity, pregnancy, patients in menopause, and you name it. Vitaly Fyodorovich had demonstrated to you these pictures from OBNG, Russian specialist journal, where we published our data. Indeed, we are postulating, based upon the findings that we saw, that prolonged cyclical and continuous regimen are both right to remove syndromes for patients with external endometriosis. So we did reach primary endpoint. Both regimens showed equal efficacy, of course, in absence of side effects. This slide shows both regimens, either regimen, were perfectly efficacious. And we saw marked decline in pain 6 months after the start of the drug. And it had statistical significance. We would see symptoms of chronic pelvic pain go away together, dysmenorrhea, and sexual well-being was improving. That certainly went to do with less pain. This data speaks in favor of the number of days that were needed when the patient needed to take painkiller. They are young women with endometriosis. Besides, as we studied EAPRO's patient-reported outcomes, health-related, we saw improvements both in terms of mental health as well as declining pain, social, household and motor functioning have improved. May I point out that both prolonged and continuous regimens showed comparable positive results. All this proves that dydrogesterone in different regimens is something that helps personalize our therapy for patients, which has become the buzzword. The same is true for the dydrogesterone that showed a very good effect in depending on the severity of endometriosis. We can see that even in grade 4 of external genital endometriosis, we would see efficacy in different variants of function, including functional, social, as well as removing pain. So women have different age groups. Early or late reproductive age also have shown comparable effect. What I want to point out is that we showed efficacy of this drug, which had marked decline of dysmenorrhea, better quality of life, better sexual well-being, fewer days on painkillers, and no influence or no impact on menstrual cycles. This drug was truly safe. We had a highly insignificant number of side effects. And as I was saying, the dihydrogesterone is the only gestogen to treat endometriosis that allows doctor to choose either regimen of therapy, depending on the patient's needs. In conclusion, I'd like to say that this trial that was conducted on a representative sample of patients across all Russia almost, we proved the efficacy of dihydrogesterone to treat endometriosis, both for continuous and prolonged cyclical regimens too. This drug was effective in decreasing chronic pelvic pain. But to confirm favorable safety profile, that was also something we did. On behalf of the team of researchers and investigators, thank you for your attention. Andrei Vladimirovich, thank you very much. You covered the, it just supports the view that we really can profess this comprehensive approach using a drug that is prescribed both to prevent relapse as well as to treat pain, to work against the inflammation. And the value is, if a patient falls pregnant, the drug doesn't have to be discontinued and it begins to work as frontline drug. Apologies for my coughing. Dear colleagues, the floor goes to Elena Nikolaevna Andreeva, Doctor of Medical Science, Professor, Director of Institute of Reproductive Medicine of Russian National Center of Endocrinology, and Professor of Department of Reproductive Medicine and Surgery of Moscow State Medical and Dentistry University, that is Medical University number 3 in Moscow. Her presentation is titled, Endometriosis is a chronic disease that requires follow-up during the life. What if the patient fell pregnant and has a baby? Do you mean we continue to follow up? Yes, even if she has. As we know today, this is not a way to cure. We need to continue to follow up. For many years, we've been saying that endometriosis is when the intrauterine we see benign growth of the tissue. In its morphological and other properties that is similar to endometrium. We have more and more data on the infiltrative forms of endometriosis, including unilateral or bilateral endometrioid cysts. The theory of endometrioid disease that Philip Connings came forward to back in 1992 is gaining more ground. Today, we're discussing, including this event which we're attending today, the role of genetic and epigenetic factors. We realize that the presence of infiltrative deep endometriosis may provoke infertility and accounts for 90%, although the general reasons is like a general rate of infertility is 33%. This is modern understanding of pathogenesis, which is caused by inflammation, immune dysregulation, lower progestogen, inflation, activation of adhesion, invasion factors, neoangiogenesis, and growth of innervation of foci that provoke pain. More and more data is becoming available about the link between malignancy and endometriosis. This data of the 2016 and 2017 about the importance of infiltrative forms of endometriosis and cancers. Most recent data of 2021 show a major trial on 800 women where identified that 13% during 10-year follow-up would present some malignancies. Some cancers such as ovarian cancer, breast cancer, endometrioma and cyst and endometrium cancer, and 5-year and larger size of the ovarian masses is a prognostic factor here. Identifying endometrial stem cells in ectopic endometrium is a novel theory when we talk about pathogenesis and possible therapeutical options. We know that 5 out of 28 polymorphisms are surely related to endometriosis. No clear data that impaired microbiome may provoke endometriosis, but as the main reason at least. But I'm sure that microbiome in women with or without endometriosis differ substantially. We do know that this is a systemic chronic inflammatory disease, which may lead to serious impact on other organs and systems. And Nurses' Health studies showed endometriosis in 12,000 of women. They had a large number of cardiovascular disease, including operations on CV that required further follow-up. As Professor Bergenet put it is one of those diseases where we have a even as many as 4 guidelines. But the thrust of these, to remove the focus of endometriosis, to decrease the intensity of pain, treat infertility, prevent progression, prevent relapses, so that we could keep the reproductive function in place. Regrettably, most recent publications keep telling us that each type of endometriosis has its own development background. So they differ. There is no such thing as one theory that would explain clinical manifestations and pathology in endometriosis. Every time we come up with personalized therapy approach, depending on the extent, family history, personal history, and you name it, comorbidities. This slide shows you a number of diverse pathologies that go hand in hand with endometriosis. It may have both external and internal and myomas and paraovarial masses, and you name it. This is ICD-10, which is now being revised, although we got so accustomed to it. But this is ICD-11, which will be guided by since January 2022, which should be interested at the number of the plethora of diagnoses we shall work with. We have identified peritoneal pouches and deep endometriosis of ovaries, infiltrative form salpingitis, you name it. Our women are not really well given this chronic disease. They complain of migraine, almost twice the number compared to women without endometriosis. The most recent data about impaired quality of life that has to do with pain, dyspareunia, dysmenorrhea, we're seen in almost 98% of women. Dysuria is not seen that often, and dysgeusia in over 80%, which surely impairs the quality of life, including sexual life. We do know that young women under 30 avoid sexual life because they have pain. So we have large cohorts of women that may be infertile, but still haven't addressed this issue of late diagnosis. Diagnosis may take up from 3 to 11 years. In UK, they recognize that in the last 20 years, no matter what they do, delayed diagnosis is as late as 8 years. Special attention should be paid to clinical manifestations of endometriosis in puberty. When the patient complains of dysmenorrhea, we necessarily look at family history of endometriosis. We saw family disease. A vast number of generations for generations would have family endometriosis. Our clinical guidelines of 2020 say, where is the niche for surgery? When do we operate on a patient with infertility? When do we talk that the patient would be operated, and what do we do post-op setting? It says we don't recommend that patients with this infertility should require hormonal care after operation in case of radical removal of foci. Regrettably, we don't always can remove all the foci, much as we surgeons would want it. They begin at cellular level and the surgeon may just not notice them. So recurrences, unless you treat it and the patient doesn't fall pregnant at that, is pretty high recurrence rate, pretty large figures. Every one patient out of 2 would have repeat disease return in 7 years. So drug therapy as frontline therapy could be chosen after surgery to decrease the relapse rate. Beginning with 2019, Professor Chapron keeps publishing this algorithm of care, and we support him. Patients who don't want to fall pregnant in the near future, in presence or in absence of chronic pelvic pain, in presence of absence of comorbidities that may interfere with the processes, may contribute to this. If the patient complains of pain, and before we diagnose her, we can use brief courses of NSAIDs, but so much for pathogenesis. You see elevated impact of estrogen, lower progestogen, and resistance to progesterone. Many physicians still use COCs, even in women who do not require contraception. However, you see evidence-based of 2018, where it clearly showed that efficacy of COCs to treat endometriosis, including endometriosis-associated pain, unfortunately was never supported. There is no convincing evidence that this is the case. Moreover, we should continue our studies. We have approved indications to treat endometriosis in Russia, as well as US and EU, only for gonadotropin-releasing hormone agonists and progesterone. Monotherapy with progestogen, this is what our guidelines say of 2020, is indicated to patients with endometriosis as frontline therapy. You can see that these foci are secreting estrogens and monotherapy, but chemotoxic protein, MCP, and pro-inflammatory cytokines, and you name it. So women with endometriosis have quite considerable activity of P450, which enhance the role of estrogens and are impacting follicular genesis, which leads to stronger non-genomic signaling pathway. And this provokes progression of disease, including when we use estrogens or when we provoke recurrence of endometriosis. So we can officially use gonadotropin agonists and a number of gestogens here in this slide. Well, basically, recently we've been using Dienogest or lipodestrone. Its symptoms come and go away, but all of example, we are seeing we are more and more prone to use digestogens that can be used at long-term perspective, not just for 6 months, but several years when needed or longer, because they have very high therapeutical effect. We see the inhibition of estrogen synthesis, inhibiting of local and general immunogenesis and immune inflammatory response. This is the data on main molecular mechanisms of gestogens in endometriosis. However, Dienogest alone can overcome this resistance to progesterone, which in majority of cases usually shows up in 6 to 12 months after the start of intake of and Dienogest seems to be overcoming this stromal cell. So the only gestogen that could be used over 6 or 12 months today, we confirmed long-term therapy on the originator drug for over 7 years. 2 milligrams of Dienogest. We now have Zafrila and generics, and is being used wisely in the Russian pharmaceutical market, have shown high indications both after the patient was operated and if the patient was not operated. And you know, the best operation is the one that was never performed. More and more data is becoming available about efficacy for prevention of care, prevention of recurrences in endometrioid cysts, especially small. We may not even operate on patients. This is the data by...
You can have Kazachenko's data. COCs are not good for prevention of relapses, they should be administered only as contraceptions, but GN RGA can be used here. You can also see the number of relapses, 23%. With the adjust, it's 0. Well, we can also predict the fertility, surgical fertility index, whether the patient can get pregnant or not. It is important to assess the patient not only in terms her quality of life, but also her children. You can see cases when children had low birth index, was quite typical for women with a family history of endometriosis. 42% of women had stress. They needed the social rehabilitation and psychosocial rehabilitation in particular. We work with clinical psychologists and psychotherapists. We're talking about the need to rehabilitate such women, to administer hormonal treatment as well as physiotherapy. We also must remember that we can have asymptomatic endometriosis, and especially when endometriosis comes together with infertility, everything starts in the adolescent age. Gynecologic can be used for adolescents. We have clinical guidelines and protocols for that. And well, there should be an individual approach to get according to the existing guidelines. Also, when there is pelvic pain. So today we have drugs that contain estrogens, and even as for this presentation, I'd like to show you the algorithm of treatment of patients with endometriosis. We can have a surgery, or, well, we can also give GnRH agonists, or we can start with laparoscopy, then Gynecologic, or we can just administer Gynecologic 2 milligrams to avoid unnecessary surgeries and not to traumatize the ovarian reserve. In conclusion, I would like to say that endometriosis is a chronic systemic disease requiring long-term therapy even before the menopause. Thank you very much. Dear colleagues, distinguished Yelena Nikolaevna, well, I do not think that endometriosis is a chronic systemic disease. It might require systemic treatment and rehabilitation, but, well, a systemic disease is a different thing. Endometriosis is an important disease. We must treat it seriously so that patients of childbearing age would not suffer from infertility, the pain syndrome, dyspareunia, and severe forms of the disease. And we're lagging behind the diagnosis of such severe forms. We're lagging at least 7 years behind in terms of diagnosis. Colleagues, we have 10 minutes for discussion. We are not overrunning our time. So who is here today with us? Do you have any questions? Could you show me the speakers who is still with us? Well, Leila, yes, Galina, hello again. Hi. Well, as for treatment of endometriosis, well, we usually start treating when there are symptoms. It's a must, but what should we do when the endometrioid cyst is being removed? Well, there are two forms, endometriosis, in fact, endometrioid cyst, which is a cyst, and there is endometrioma. When we have the proliferative process clearly manifested, well, should Gynecologic be administered in such cases, yes or no? Well, Galina, my dear, I know that you've been studying this question extensively, and I've been studying this question for 49 years. Ovarian endometrioid cysts require removal unless they are of small size. And what should we do later with this patient? We must clarify it with the patient. What are her plans regarding her reproductive health? If the removal was done properly, if there is no disease, that's one thing. But unfortunately, we don't do it all the time. And in such cases, there is a relapse, a recurrence of endometriosis. If the patient wants to preserve her reproductive function and she wants to get pregnant in the near future, and the surgeon knows that there was the organ sparing technique used, I usually tell such a patient at our clinic, well, you can do this or you can do that. If you wait for a long time, there might be recurrence. So let's have some treatment, maybe dihydrogesterone or Dynagest. If it's severe endometriosis but asymptomatic, you can use GnRH agonists. Well, we can preserve her childbearing function. It's up to the patient to make such a decision, but she must be aware of recurrences. Hormonal therapy will give us a lesser percentage of recurrences. If the patient is young and she wants to get pregnant, that's fine. Galina, did I satisfy you with my answer? Yes, your answer was quite precise. Well, it's better to have this kind of therapy, right? And Galina, we should be in alliance with the patient, metaphorically speaking. If the patient doesn't want to get hormonal therapy, if she has some prejudices, well, if she's not going to get pregnant, that's a different story. And during the first 6 months, such women usually get pregnant, at least 30% of them. What to do next? That's a different subject. Yes, that's a different subject. Thank you so much. Dear colleagues, do you have questions for one another? Well, I'd like to ask our Japanese colleague, what's the situation in Japan? You made a wonderful presentation. You saved the time for us. You allowed us to have a discussion. Dr. Otter, what's the situation in Japan? Do you administer Dynagest for life or what? Dr. Otter, can you hear us? How do you manage patients in Japan if they have endometrioid cyst and they do not have any symptoms? They are asymptomatic. 1 or 2 minutes for answer. What's the tactic of treatment in Japan? Professor Otter, can you hear us?
We administered Dynagest 2 milligrams per day. And this is the first choice. And second choice is oral contraceptions.
Until the menopause, Dynagest, okay, oral contraceptives. Thank you very much. Professor Michel Nizol, what drug do you prefer? Histogens, what kind of histogens do you prefer?
Okay, so we are using nomegestrol acetate. But due to the problem observed in France with high dose of progestin, now we are switching to Dynagest also. And if progestin are not well tolerated, we will administer estrogen and progestin combined pill, not until the menopause, but certainly until 40 years, I would say.
Thank you, dear colleagues. Allow me to finish our plenary session. I think that we are satisfied with all the answers obtained. Professor Konings also gave us a full picture. We got complete information about the factors impacting the development of endometriosis, inflammation, ecology, hormonal aspects, genetic aspects. You are a true philosopher in this question. You've been studying endometriosis your whole life long. And unfortunately, we still realize the true reasons for the development of endometriosis. It can develop in children, in adults, sometimes in perimenopausal period. Well, in some cases, we can have a family form of endometriosis. We have families where the mother, the sister, and 7 children all have endometriosis, although everything is okay in terms of ecology and other factors. Also, there are questions related to new pathogenetic factors, such as the role of stem cells, or the Sampson's theory, implantation theory by Sampson. Well, we can see that there might be endometriosis even if there is a uterine aplasia or vaginal aplasia, when it looks like there is no reason for the development of endometriosis. Thank you, Professor Konings, for your presentation. Professor Kupke also talked about endometriosis. The farther we go, the more unclear things there are for us. And adenomyosis is one of the major problems of fertility, although we're talking about windows of implantation. But even when we have a wonderful egg and the embryo, in some cases, implantation doesn't yield any results. So we should monitor adenomyosis strictly. Otto Kurashiki made a wonderful presentation. Endometriosis and uterine myoma are interrelated, interconnected, not because they're interconnected locally, not because they are hormonal dependent diseases, but because endometriosis or adenomyosis leads to infiltrating process and leads to the growth of uterine myoma. Wonderful pictures shown us from Japan, MRI. Well, Japan has wonderful MRI technique, video MRI, well, how the uterine contracts, in what direction, what's the blood flow. At our Kolokov Center, we also do a lot of fundamental studies on women with endometriosis. Signaling pathways are being studied, mass spectrometry, and the functional MRI is being done. We determine the blood flow in the sections of adenomyosis. We study patients with recurrence, the peculiarities related to hormonal traits, genetic traits. Professor Trofimov and his team made a significant contribution here. Galina, I think we've had enough to study endometriosis, and maybe it would be nicer to set up a foundation to support women with endometriosis. But which way should we go? At this point, I don't know. I think the most important thing here is to preserve health from the young age. Well, because unfavorable pre-morbid background leads to negative situations such as abortions, well, also pelvic organ diseases, and genetic aspects can also be involved here that might lead to family endometriosis. Professor Waterloo also surprised me. They have a wonderful association in France and Aura on diagnosis and detection of endometriosis in a specific area, in a specific town or village. And I've known Professor Waterloo for like 30 years. So voluntarily, they decided to test the competency of those doctors who treat endometriosis. And as he said, well, we cannot just deprive a license of a particular doctor, but if they wouldn't listen to us, it would be difficult for them to work in this region. That's an interesting idea, Professor Nisol. talked about the CO2 laser, the Leuven University, where Professor Konings worked and is still working. Well, it's famous for new technologies, the study of the CO2 laser, other lasers, and they always conducted studies regarding hormonal changes, poor receptivity. This team is for surgical treatment of endometriosis in Leuven, Belgium. And if you ask other people present here, of course, endometriosis is a surgical disease first and foremost, because, well, you should remove the morphological substrate. Do you need some energy here? Well, of course, there might be an impact of NSAIDs such as Voltaren and others, or drugs related to hormonal changes. They subdue the estrogen activity. Progestins are number one here. Those women who prefer COCs, well, COCs can also be used. Well, Dynagest as progestin, dihydrogesterone. We have lots of different drugs. The most severe forms, in this case, I prefer, if the surgery was not successful or if there is a recurrence, I prefer GnRH agonists, but they require add-back therapy. They can cause osteoporosis and many other complications. But since right now, globally, we are saying that endometriosis is a chronic disease and it requires prolonged treatment. In this case, progestins should be taken into account, the dihydrogesterone, Dynagest, and all other progestins. Well, a few words about this ORCID project. It's a powerful project, and partially I also participated in it, as well as Andrei Kozachenko, our leading specialist, as a principal investigator. And as for dihydrogesterone, I used it 30 years ago, but at the time we called it differently. The drug is good because it does treat women. It is a depot drug, especially in the second phase of the cycle. We reduce the pain syndrome. We reduce the size of the foci. We normalize the menstrual cycle. If a woman gets pregnant, dihydrogesterone cannot be canceled. It's just the drug that can be administered even during pregnancy. Yelena Andreeva has been involved in endometriosis for a long time. She knows all the drugs that can be administered here. So her opinion was also very interesting. But nevertheless, I do not think that endometriosis is a systemic disease. Galina, would you like to say something about it, please? Galina? Well, I listened to all presentations with great pleasure. And of course, I liked Professor Konings' presentation very much, but at the same time, this presentation gave us more questions than answers. Well, it looks like it's an inflammatory process. It's open. It is important. But on the other hand, genetics is involved here. And third, immunology also contributes to the development of endometriosis. What comes first, immunology, genetics, or inflammatory process? But as for Russia, I would like to say that here, well, how would I say, we've had a lot of studies, but we need multi-center studies, and maybe, sorry, the connection is lost and the picture is frozen. Maybe we can say that there are different projects like this ORCID project, and we develop guidelines, recommendations on different questions, and usually we ask our foreign colleagues to conduct multi-center studies, but we did not have a lot of multi-center studies. Well, I suggest you do such multi-center studies in Russia, because that's one of our drawbacks. That's one of our problems. So I would like to ask you, as the chief specialist in obstetrics gynecology in Russia, Professor Adamian, please have more multi-center studies in Russia on this subject to have enough evidence. Because, well, everything was interesting today. We discussed the different issues, different frequency rates of exacerbations, of recurrence, but what to do next? Well, and as it has been mentioned before, the more questions we have, the less answers we get, unfortunately. But this problem is very important, and it is an interesting one. Well, Galina, when I look at you, I'm very happy, because I consider every word you say is kind of coming from me, like we be of one blood, as Kipling once wrote in the Book of Jungle. Well, I agree, we have a lot of centers, but we do not have a lot of multi-center studies in Russia, unfortunately. But this year we did a lot to developing those clinical guidelines. All of Russia participated in it, Galina. Well, I also don't blame me for that. I participated in those in the development of those recommendations, but we ask for evidence from our foreign colleagues. And Professor Adamian, there are differences in between the Russian regions. Russia is a vast country. Things which are good for one region may not be good for another region. Well, it looks like the planet Earth is very small when we have the pandemic of COVID-19, but when there is no pandemic, well, the world is large. So the same is true of Russia. What is typical of one region is not typical of another region. And I'm sorry that Anton Sergeyevich has left, but at least we could have some studies in Moscow and get some reliable data on the most important issues. But we must make our own conclusions on the basis of our data. Well, dear Galina, you're right, but I wanted to say that this year we have already started to treat this topic differently as true adults, not some kind of childish behavior anymore. Now we have a powerful alliance with the regions. We're working with Anton. We'll keep working on this topic. But as Professor Konings has said, and he's been dealing with endometriosis longer than I am, that's a Pandora's box. That's a Pandora's box. There are lots of different ingredients inside. Well, the ovaries are working fine, uterine aplasia, well, and no Sampson theory can be applied here. Well, maybe that's the embryonic theory, maybe genetic factors are impacting here. We started working on this from this angle. And of course, the study of stem cells and the signaling pathways shows that we should move into this direction. Thank you very much. Our plenary meeting is over. We'll keep working during these 4 days. Galina, stay with us. All the best and goodbye, dear colleagues. Right now, we must have a technical break for 10 minutes. And before we have this technical break, we're going to have an advertisement right now. But I'd like to thank our presenters first. I should also say that we have one of the pharmaceutical companies here in Russia. That's the Tyumen pharmaceutical company. They will be manufacturing different hormonal drugs, COCs, drugs for replacement hormonal therapy, drugs to treat gynecological diseases. I'm not going to give you any brand names. You will see a video right now, but this is a Russian manufacturing company. Well, this company also participating in the third phase of the studies of Serograd. This drug is used to prevent adhesions. That's a clinical trial that will allow us to assess efficacy and safety of the drug. So we are expecting for the third phase results. If you want to participate, you are welcome. Today, adhesions are a serious problem for us, as well as hormonal changes. I believe that we finished the first part of this Congress with flying colors. Well, I was concerned about my presentation related to artificial intelligence, but a doctor is a doctor. Well, a doctor has special intellect to choose the best technologies. All the best, and soon in 2:15 Moscow time, we are starting another conference, another part devoted to up-to-date digest. Professor Frank Chervenak from New York will be talking on the topic recommending COVID-19 vaccination for pregnant and breastfeeding women is ethically obligatory. And also Assistant Professor Konesheva, who will be talking on birth outcomes in COVID-19, the analysis of 891 cases according to clinical hospital number 15 data. Okay, stay with us. Let's have a technical break for 10 minutes. Thank you so much.
Start video.
She's still muted.
Why is she muted?
Shall we begin, dear colleagues? Time has come where we are so privileged and so lucky to listen to a presentation and meet Professor Frank Chervenak. Professor Frank Chervenak is professor of New York University. Where is my agenda? Sorry. Clears her throat. Professor and head of Department of Obgyn of the Hospital of Lenox Hill, head of the Department of Gynecology and Obstetrics, Deputy Dean of the School of Medicine named after Donald and Barbara Zucker in New York City, New York. Professor Chervenak is a unique figure of authority in obstetrics and gynecology. Professor has always been a best decoration of any forum, any congress, any meeting, any word of his is perceived to be as a result of a huge, long-standing church search and experience. We invited in person Professor to share with us how things stand today about COVID and pregnancy, COVID and delivery, and COVID and vaccination. Why? We have never witnessed a pandemic like this. It already killed over 174 million people who fell ill. It took over 3 million human lives and 700,000 lives. I do not wish to take away the time from our speaker. He visited us many times in our center, in our country, anywhere in the world. Give the name Frank Chervenak and everyone says, yes. Professor Chervenak, yes, the floor is yours. Where do we recommend vaccination against COVID-19 to pregnant and lactating women? This is a sine qua non from the ethical perspective. The floor is yours, Professor.
Leila, thank you. It is a true pleasure and privilege to be with you today. I wish I could be there in person to embrace you. I give you a virtual embrace from New York City, and we're going to talk to you today about the most important topic that's taken over New York City, Moscow, all the United States, and all of Russia, the COVID-19 pandemic. So much has happened since I last visited your beautiful center 2 years ago. And can we, Shoshana, can you help me? Can we start with the slides? I know this is a wonderful program and time is limited. I work together with two of my professors who we have no conflicts. And as Leila said, I'm now chairman at Lenox Hill Hospital, which is based in Manhattan, but also of a consortium of hospitals throughout Long Island, about 20 different hospitals. And this is at the epicenter, one of the epicenters, the first epicenter of COVID-19 pandemic. Let me emphasize, 2020 started off very happy for me. Very happy. Academically, our department was doing well. Our services were growing. Here we are, was at a nice meeting in Jeddah, Saudi Arabia, and I fulfilled a lifetime ambition. I actually was able to go to Mecca, something that was very precious. Little did I know that when I returned home, I believe it was March 2nd, 2020, my home in New York City, the city that never sleeps, became dormant. And it was a culture shock for me. And the COVID-19 pandemic was upon me. I had to wear a mask, something that I was not used to. This was indeed a culture shock. There's a beautiful church across the street from my hospital. And this was on Sunday. I was very surprised to see it was empty. No one would go to church. This was a big shock. I issued this memo and I spoke to my department because everything was in chaos. This is a quote from Thomas Paine, the great American patriot who issued this at the darkest moment in our war for independence. I love history. These are the times that try men's souls, and I can tell you our souls were tried during March of 2020. This was indeed a shock for us. It was a difficult time. I lost one of my doctors. Several others got sick, but they recovered. Fortunately, I didn't lose any of my pregnant patients, but at some of my hospitals in Long Island, we did lose 2 of our pregnant patients. This was one mean virus. Our time is limited. I don't want to go into the past. I want to use the precious time I have with you to focus on the light at the end of the tunnel, the vaccine, the current challenge. Maternal immunization gives us protection against infectious disease. It induces high levels of antibodies that can be transferred to the fetus. It helps produce antibodies to the newborn. Pregnant women and newborns are vulnerable to infectious disease. This is one study that said that maternal mortality was 22 times higher. We know that mothers are a vulnerable population. Now, as Leila emphasized, I'm an ethicist, and we need to know the difference between a recommendation and an offer, something that gets confused. Our professional societies not uncommonly make recommendations. I don't have time to go into the details here. This is our American College, and I'm sure your group often makes recommendations. And these are not unusual either in national organizations, in FIGO that I work with, and international organizations, our World Association of Perinatal Medicine. Our own CDC gives examples how you give a strong recommendation. I strongly recommend you get the COVID-19 vaccination. The shot is especially important for you. I believe in this vaccine so strongly that I plan to get it as soon as possible. However, this is not the case in pregnancy. There's a lot of vacillation that's gone on in this country. Let's look at the facts. COVID-19 infection is bad. There's a higher infection rate than non-pregnancy, a higher death rate. As I said, I lost 2 of my patients. More ICU admissions, more ventilation, long-term sequelae. The fetal patient is hurt by this. More preterm births, more pregnancy losses, infection of others, infecting fetal patient, infecting the newborn. Vaccination is a great benefit. It prevents infection, it prevents infection to others, it prevents severe disease, prevents preterm births, prevents fetal infection, prevents needle infection. There are antibodies in the breast milk, and most important, prevents long-term sequelae. We know there are long-term problems such as brain fog that can result. There are some risks to COVID-19 vaccination. You can get anaphylactic reactions, so you need to watch. There can be some pain. When I had my vaccine, there was a little bit of pain. You get some headache, tiredness, muscle aches, a little fever. We know that pregnant women were not included in vaccine trials. This is because the companies didn't want to get sued. But it's so important that vaccines have not been shown to have adverse pregnancy outcomes. There are no proven theoretical fetal risk, no proven theoretical maternal risk. Anthony Fauci has been a voice of sanity in our country. There's been a lot of false information, and he's emphasized there's been no ill effect of the vaccine. Originally, some information has come out, well over 100,000 women, pregnant women, have gotten the vaccine with no ill effect. And I can tell you, vaccines in pregnancy are very common, from influenza and other agents, no ill effect. I don't have time to go through the different recommendations, but they waffle. They say it should be offered, not recommended. Israel has been the most progressive country. Some countries, like Austria, actually said the vaccine is not recommended. I'm delighted that most recently they softened their stand. I don't have time to go through all the editorials that talk about shared decision-making and offering it. Our paper is the only one that said recommend it. This is a leading bioethicist in our country, Ruth Faden, and she said it so well. I don't like the fact that the burden of decision-making will fall to individual women. I wish we had an absolutely unambiguous recommendation. That's what we need here, clear recommendation. There's too much talk about, is it safe in pregnancy? What is absolutely safe in pregnancy? In my field in ultrasound, this was never proven by randomized clinical trials. The point is, precious little has been proven by randomized clinical trials in pregnancy. This was a beautiful paper in the New England Journal discussing different strategies, but they omit the most important thing, the doctor's recommendation. This is a recent paper that occurred in JAMA, a leading publication in the United States. And it shows we're getting better with patients refusing less. But look, about 30% in our country still won't take the vaccine. I knew we had a serious problem when about a month ago I was making rounds on labor and delivery, and I talked to one of the nurses, and she told me that she was giving the vaccine at one of our sites. And I said, oh, that's great. And I said, when did you get your vaccine? And she said, oh, I'm not going to take the vaccine. I'm going to wait. This is a problem. This paper has all the references that, forgive me, I don't have time to present the details today. And we give the evidence and the references for what I'm going to speak about today. There's a limited evidence base, the documented increased risk of severe disease among pregnant women, conflicting guidance from government agencies, false information about COVID-19 information, and maternal mistrust. This is a very nice paper that's recently been published in PLOS ONE that shows that there are too many papers out there with vaccine rumors and conspiracy theories. Look at this, 637 COVID-19 vaccine-related items. 91% were rumors, 9% were conspiracy theories from 52 countries. All this fake news that's out there. I'm ashamed to say that the United States is a leading perpetrator of this garbage. You should be proud. Russia's not so bad. India's a leader and Brazil is a leader, but Russia's not so bad. This is our American Society of Reproductive Medicine. There's absolutely no link to the loss of fertility. This is fake news. This is garbage. And I show this over and over. We need to recommend this vaccination. This is our leader, Michael Dowling. And at our site, this was a nurse who received the first vaccine in the United States. And I don't have time to repeat this over and over, that the medical evidence is clear. Now, vaccination, the benefits are very clear. I'm going to stay on time, Layla. There's no evidence of any harm to the fetus. It doesn't enter the DNA, and all this theoretical risk is just not there. We know that COVID-19 is deadly, and it does harm the fetus by causing prematurity and loss of pregnancy. It's so important that we shouldn't just say, what would you like to do, and accept refusal. This is where the ethics comes in. The obstetrician has the professional responsibility to respond proactively when patients refuse recommended vaccination. You must not accept this. We have to be alert to vaccine hesitancy, ask patients to express their hesitation and the reasons for it, and respectfully address them. A particular problem we have in the United States, much less so for you in Russia, is for patients in color. We have a very ugly history in the United States where Black patients were experimented upon with the infamous Tuskegee experiment. This is many years ago, but this memory is not forgotten. I'm delighted that at Northwell we have a three-pronged approach. Back in December, access was permitted for everyone in all our sites at all levels, not just doctors and nurses, all of our employees to the vaccine. Two is education. I'm embarked in many education efforts. I go to parts of the hospital I've never been before, like the kitchen, to make it clear. And recognition and pride. We try to emphasize everyone should be proud to take the vaccine, and I'll have more to say about this in a moment. Pregnant doctors need to show that they should be proud to take the vaccine. I was one of the first to take the vaccine back in December. And this is not just at our hospital. These are publications that show that all doctors and nurses need to be proud of taking the vaccine. And I emphasize it doesn't matter which vaccine. This is ridiculous. It doesn't matter which brand of vaccine. All the vaccines are good. Take whichever vaccine is available. And I emphasize it said, when in pregnancy, take it whenever it's available. A big discussion, should it be first, second, or third trimester? Take it as soon as you can get it. COVID-19 is deadly to the pregnant woman and to the fetal patient. I was delighted to see this on the left. Our National Academy of Medicine is an important group, and 60 Black physicians got together to urge Black Americans to get vaccinated because this group is particularly resistant to take the vaccine. And look on the right side of this. Michael Dowling, our leader. I was happy to get this back in December. An acknowledgement is a sign of pride that I'm a COVID crusher, because everyone who gets vaccinated, it's not just good for ourselves, but it helps the whole community so we stop spreading the virus. We empower the autonomy by making our recommendations. And I can't emphasize this enough, and we document this in our paper. Patients have reported that their physician's recommendation of vaccination was the single most important factor in their decision-making process. And there are many, many references to support it. Look at our paper. I don't have time to give these to you now. Now, shared decision-making, where we offer things, is an important part in some aspects, but not in everything we do in medicine. When one of my young doctors presents a case to me and says, I offered a cesarean for acute fetal distress. No, you recommend cesarean for acute fetal distress. When the medical evidence is clear, you give a recommendation. Shared decision-making offering is not universal. So I emphasize this should not be the ethical standard. You make a recommendation. I want to present an individual case. As I mentioned before, Israel is the most progressive country in the world, in getting its citizens vaccinated, and it's most important in the most progressive country in giving pregnant women priority. But there was a woman whose brother told her, don't take the COVID-19 vaccine. This was someone who was an anti-vaxxer. The woman, being a good sister, didn't take the vaccine, and sure enough, she died. I'm not going to get sentimental with you and show the video of her children who were crying over her casket at the wake because she died unnecessarily because she listened to her brother. The point I'm trying to make, it's very tough when we have unnecessary deaths, and this is not an isolated case. We, in our medical center and throughout the country, are actually debating whether we should mandate vaccines, and I am an advocate for this policy. In contrast to conflicting guidance from some agencies and some professional organization, each one of you has the professional responsibility to recommend COVID-19 vaccination to patients who are pregnant, planning to become pregnant, and breastfeeding, or planning to breastfeed. You're fortunate to be in a country as Russia, a country that's plentiful, where the vaccine is available. Many countries are dying to get the vaccine. Layla, there's so much more I could say, but I want to stay on time and stay within my time limit. If there are comments or questions, I'll be happy to answer them. A sincere thank you to you for permitting me this time and be in your wonderful course. Spasiba. Thank you.
Thank you very much, Professor Chervenak. Indeed, we have some time left. And may I ask for your opinion, because it matters to us so much. Firstly, because indeed, some people voice this opinion, well, maybe the vaccine may lead to some problems. In person, I talked to all the stakeholders, to all who work on this, both with immunologists and virologists, obstetricians. We do not fear, we are not afraid. But since most publications, Frank, follow this line, CDC may conflict with NIH, ACOG, your presentation has shown about vaccination, your article in the journal, I personally read it on ACOG. So that is why we wanted to hear from your mouth, for you to just explain to us what is the right answer. First of all, COVID does influence reproduction and the pregnancy. Why? Because we've seen how many complications and pregnancy loss, COVID per se, right? If we prevent prophylaxis of COVID, this per se is good. It's good. All those women will not get COVID, right? If they want to fall pregnant, then they need to be vaccinated so that they should not contract COVID at the early stages of their pregnancy and should not lose their pregnancy. I want you to give an answer yes to all my questions or no, whatever you think. So it is crucial that women who want to fall pregnant, they are getting ready for IVF, I don't know, they are infertile, they have had therapy, and they fear vaccination of all things. Why? Because this may impact their reproduction and their pregnancy. Our answer to this is quite the opposite. It will protect you beyond pregnancy and within pregnancy. Get ready for pregnancy as pre-gravid preparation and during pregnancy so that you shouldn't lose it. Our data would be on 891 cases. Clinical outcomes in pregnancy and delivery in women with COVID, they show that the need for C-section rises. Need for women who cannot carry to term and pregnancy termination because of mother's poor condition is rising. Preterm delivery rises. The child may be born with distress syndrome. Mother has distress syndrome, especially in women who have high risk in terms of complication and morbidity, hypertension, diabetes mellitus, gestational, metabolic syndrome, obesity, lung disease, poor immunity. Well, I don't have any question about this. I've been saying it, I've been repeating. Please, Frank, could you once again get this message across? Does vaccination against COVID influence or impact reproductive function? Yes or no? Yes or no? Yes or no?
Leila, you've said everything so eloquently. I totally agree with everything you've said. Vaccination will only help reproduction. It'll be protective to women who want to get pregnant. There is absolutely no scientific evidence, zero, none, that this will hurt reproduction. Absolutely none. Leila, it's so sad. It's so sad that this fake news and rumors, I went through this in pediatrics. I've worked with my mentor, a pediatrician, Robert Brent, a few years ago. With autism, there was a rumor out there, this started from Great Britain, that childhood vaccination would cause autism. And so much harm was done to children not getting vaccines. This is what's going on now with this COVID-19 vaccine with women. This is horrible. And we as professionals, as leaders in our different countries, need to do the right thing and tell women to do the right thing. So Leila, I'm so happy that you as a leader in your country and all your doctors will do the right thing.
Thank you so much. Question number 2, the vaccine, through very fact that it gives you protective effect for the woman and for her baby, it seems to be producing antibodies, these antibodies that also are a protection for a baby. This was proven, right? And because we see it in maternal milk and breast milk, and the baby born to a vaccinated woman has these antibodies from birth because they protect him. Is that so or not, Frank? What is your take on this?
Absolutely
about the baby?
Correct. Definitely correct. Yes. Yes.
Well, question number 3. Look, if a woman wants to have IVF, in vitro fertilization, or any ART technologies, and this woman wants to, well, they are preparing her for the cycle of vaccination, we are saying that post-vaccination, well, just in case we say, what if you may give adverse response to vaccination? First vaccinate as pre-gravida preparation, but please wait, because because we have 2 rounds of vaccination. You have to wait 21 days for the boost, for another 21 days, and then why? After 2 or 3 months post first dose, you can even start doing IVF attempts. Do you agree with this recommendation? Please say us, do you personally, Frank Chervenak, what is your personal take?
I wholeheartedly agree, Leila. This is a short period of time. Anyone attempting in vitro fertilization must get vaccinated first. Absolutely agree with you.
Well, you know, there are quite a lot of women in this world who, not knowing whether they might be pregnant and they're not aware of this, and they got vaccinated. I suppose there are more than 100,000 women, maybe even more now. They got vaccinated with not aware that they were pregnant. And the women during their pregnancy and delivery had no morbidity, no complication. Not one single case was reported when pregnant women were vaccinated. But that is not really formal data, it is observational data. These women were not aware they were pregnant at the time of vaccination. Not one single case in terms of adverse event from the fetus or the pregnancy course or delivery, not one single vaccination. Please, could we hear it from you? There are over 100,000 women, am I right?
You are correct. And Leila, it's more than that. Flu vaccine has been very commonly practiced in America and throughout the world in pregnant women. We recommend flu vaccine in pregnant women. So not just 100,000 with the COVID vaccine, but another similar vaccine from influenza, hundreds of thousands, and again, no ill effect, no ill effect.
I can only say thank you, Professor Chervenek. I invited you to participate in this plenary session on purpose. I am the chief gynecologist of the Ministry of Health. I am the mother, the grandmom, and I vaccinated all my friends because I don't want to lose them. First, second, I don't want to die earlier than planned, and I don't want to be dangerous to people around me, because a person who is not vaccinated is a danger to others, to people around him. That is why, from the point of view of ethics, from the point of view of my civic position, an unvaccinated person is a threat to people around him, especially when we're talking about risk groups, people over 65 and older. Well, people in other risk groups, such as medics and those people who provide care for the sick and people with comorbid conditions. Our experience in Hospital 15 showed that the COVID-19 disease is severe when there are risk factors: hypertension, obesity, the metabolic syndrome, diabetes mellitus, respiratory problems, heart and lung diseases. I think these people also must be vaccinated. Thank you so much. If you want to add something in conclusion, I'd be glad to listen to you. Professor Chervenek.
Leila, I strongly agree with you, and you bring up an important point. Vaccination helps not only the individual, but society at large. Look at the great success we've had against measles and against smallpox with widespread vaccination. I dream of the day when we have the same thing with COVID-19, but everyone needs to be vaccinated. And we're not close to that. We're not close to that in America, not in Russia, not anywhere. And all of us need to fight this battle in our respective countries. Leila, I'm so proud to be with you today. Thank you for the opportunity to be with you. Thank you, Pasiba. Thank you so much.
Thank you once again. Vaccination has saved the world. Russian scientists have always been on the forefront of vaccination. Smallpox, polio, cholera. If it were not for vaccines, the situation would be much worse. Thank you, Professor Chervenek. Stay healthy. Thank you very much. Bye-bye.
Thank you. Thank you.
Dear colleagues,
And
let's move on. And now I'd like to give the floor to Olga Konisheva. She is an assistant professor, deputy chief physician on obstetricians and gynecology, the clinical hospital number 15, the Filatov Children's Hospital. She is the senior lecturer at the Department of Pediatrics, and he's an OB/GYN, a surgeon, and she knows different methods of treatment. And she will be talking on behalf of Leila Adamian, on behalf of Professor Vichorkin, on issues of birth outcomes in COVID-19, the analysis of 891 cases in the city hospital number 15. That's a unique material. Olga, the floor is yours. Please. Well, good afternoon, dear colleagues. Thank you, Leila, for letting me speak on the analysis of our work. That's what has been done at our department under the auspices of Leila Adamian. And after Dr. Chervenek's presentation and our presentation, will manage to convince the medical community in the need to vaccinate. Vaccination will save us from COVID-19. COVID-19 and birth outcomes. Well, starting from March last year, we've been in a situation of COVID-19. More than 2.5 thousand patients have been treated. We had 891 births. And right now, actually, we are close to 1,000 births who were born during the COVID-19 pandemic. The age, well, you can see it here, about 30.2 years, plus minus 2.3 years. Well, some patients had concomitant pathology, anemia, also metabolic syndromes. The key problems are shown here. First and foremost, the peculiarities of diagnosis of COVID-19 infection in pregnant women, the possibility of medical therapy during pregnancy and COVID-19, well, issues related to oxygen provided to such women, that's oxygen support. Well, of course, the issue of rehabilitation is of great importance. As for diagnosis of COVID-19 infection, well, we do the physical examination, but of course, we also detect the specific antibodies. As for diagnostic methods, I think that CT tomography is the best method, but we should have a clear understanding here. We should see that the patient gives her consent. Changes on CT can persist for a long time. As for MRI, well, it does not always detect COVID-19. It can be used as a screening. Well, ultrasound, long ultrasound cannot be used independently and cannot be a diagnostic criteria. We use it together with other methods. Well, any imaging modality does not give you the entire picture, especially when there are specific changes, such as the ground glass opacity, as you can see it here, plus other changes that can occur in the lung tissue. As for the tests conducted on our patients, well, we can see that 39% of patients had the light form of the disease, while intermediary lesions in 38%, severe and heavy forms of COVID-19 in 4.5%, without involvement of lungs, 15%. Well, you can see these data are self-explanatory. As for the medical treatment of pregnant women with COVID-19, well, we try to limit the administration of specific drugs, especially biologics, until we do the complete test of a woman. Then this happens when the risk of complications from COVID-19 is less than the risk of complications from such drugs, and vice versa. Such drugs can be administered when the risk of complications from COVID-19 is higher. Well, as for May 24th, we had 891 births. That's the same as the number of births from women with COVID-19 in the United Kingdom. And as for antenatal death, it's less than 1%. And also neonatal deaths is basically the same in Russia and in the UK, 1.1% and 1%. As you can see it here, well, as for other indicators, they are basically the same. We also analyzed women who had the COVID-19 and compared them to women without COVID-19. Preterm births occurred more in women with COVID-19, 3 times as much. A cesarean section was done in 40% in women with COVID-19 as compared to 30% in women without COVID-19. As for obstetrics tactic, we used the recommendations of the Ministry of Health. Cesarean section is indicated for patients with respiratory failure, 18% of cases like this, or when there is a fetal distress, asphyxia, or other fetal-related problems. As for newly born children, as I have already said, there are more preterm births in case of COVID-19, but every 4th child was discharged home, and 16.9% of newly born children were referred to children's ICU. We also analyzed the number of patients who were born from women with COVID-19 and without COVID-19. The percentage of children who were born preterm is much higher. Also, the number of stillbirths is higher, and twice as many children needed respiratory support in children's ICU. We studied the levels of IgM and IgG from women who had COVID-19. We did not identify the vertical transmission of infection. COVID-positive mothers had did not transfer the disease to their children and did not see the penetration IgM through the placenta. Also, we studied the condition of the placental tissue in patients with COVID-positive results. And as for COVID-19, pathomorphological signs were not detected in such cases. In 75% of cases, we saw changes typical of viral lesions, such as fibrin depositions, vasculitis, infarction, but they're not specific for COVID-19. What is important is to provide the proper respiratory support. Well, oxygenation is very important. And here, of course, we should talk about reasonable opportunities. If possible, we should avoid putting women on a ventilator. We just prefer the oxygen support without putting women on a ventilator. And of course, then we make a decision on the further management of such patients. As for anesthesiology, the element related to a reasonable intervention is of great importance. We can use regional anesthesia unless women have multi-organ failure, and if we can do it en masse. All patients who had respiratory support were in ICU, while most of them, 78%, could breathe on their own, but they also needed the CPAP. That's 14% of patients. 4% of patients were put on a mechanical ventilator. Lung involvement in pregnant women due to COVID-19 results in a higher risk of pulmonary complications, hydrothorax, pneumothorax, spontaneous pneumothorax, as you can see it here, as a result of being on a ventilator. And we also saw lung abscesses. Here you can see some of the imaging when women had COVID-19 during pregnancy. Well, the progression of disease was very fast when patients were on therapy according to recommendations. Well, you can see the respiratory insufficiency increased from stage 1 to stage 4, microscopic changes in lungs, as you can see it here. Well, there were a lot of cases of thrombosis. Well, the lumen was not quite wide, and thrombotic reactions were very severe. You can also see changes in myocardium. You can see the microscopic picture of the myocardium. Well, you can see that there is some kind of clay-like consistency and the stromal changes, which are quite typical for such women. It is also important to look at possible complications when there is a second infection involved, or secondary infection involved. Microbiologic monitoring is of great importance here for testing inflammatory markers. We can, for example, do the C-reactive protein level measurement. You can see an abscess here when there is a secondary infection involved. Another important and difficult question is how to manage patients with intermediate level of COVID-19 when there is a high risk of thrombosis, when platelet level is more than 100,000, unfractionated heparin and infusion into the central vein is done. And also we use low molecular weight heparin, and as you can see it here, twice a day. And we also use unfractionated heparin or low weight molecular heparin once a day. Here you can see the patient who had a standard dose, 0.8 milligrams enoxaparin, but we couldn't reach target indicators. And when we increased the dose of enoxaparin to 1.2 milligrams twice a day, we managed to achieve the proper indicators. So we managed to achieve our target. Thus, complications caused by COVID-19 that can lead to changes in lungs, in the cardiovascular system, well, poor coagulation and respiratory insufficiency, renal insufficiency. All these cases require rehabilitation. That's a long-term process. What are the consequences after COVID-19 in such women? First of all, pathologic changes in internal organs as a result of the infection, such as pancreas is involved, the heart muscle is involved, and of course, we should use a pathogenetic approach to treating such patients, as well as to administer individual administration of drugs for women with such pathologies. Well, sometimes there is unjustified intubation. That's another problem. So again, there should be the principle of reasonable sufficiency involved. The exacerbation of chronic diseases is another serious problem. Often such women have psychological problems such as anxiety, panic attacks, depression, cognitive problems. It is very important to treat the patients properly, the dynamic control with the proper counseling by psychologists. Well, we use the entire arsenal of rehabilitation methods, breathing gymnastics, well, proper methods of breathing, psychotherapeutic methods. Thus, we have been working with women with COVID-19 for more than a year, and we would like to make specific conclusions. COVID-19 is a serious medical and social problem, especially among pregnant women and women in high-risk groups. Those patients who have concomitant diseases deserve or merit specific consideration due to possible complications. The presence of infection is not an indication for preterm labor, except those cases when there is a need for respiratory support. During delivery, there is a need to monitor the state of the mother and the fetus. In terms of specific complications, we did not get any data regarding the vertical transmission of COVID-19 from mother to child. We did not detect any specific changes in placental tissue in patients with COVID-19. Increased indicators of preterm births and higher mortality rates are due to hypoxemia of women. There is a need to improve the mechanism and algorithm of monitoring patients with COVID-19. In case of severe COVID-19 cases, it is feasible to prolong pregnancy and to preserve all the legal aspects. The treatment of severe patients with cytokine storm and sepsis due to COVID-19 must be comprehensive, and we can also use extracorporeal humor correction methods, but when women are not pregnant. Thank you very much for your attention. Thank you, Leila Adamian. Thank you for the data that you presented to us. And thank you for this concerted effort. So this year was really very dramatic for us. Thank you, Olga, for this wonderful presentation. You are a wonderful person. Say thank you to Professor Valery Vichorkin. And dear colleagues, I should say that we compared indicators that were obtained at City Hospital number 15 that was a COVID-19 hospital with data published in the United Kingdom. And we see that our indicators are better than those in the UK. Thank you very much, Olga, for your wonderful contribution. Dear colleagues, we are starting the school on laparoscopic prolapse surgery. We're slightly behind the schedule because we need a technical break right now, and we were supposed to have Professor Chervinak's presentation a bit earlier. Well, but let me just see all the people in the Zoom, all the participants in the Zoom. Also, we have Arnova Tiers with us. Are you here? Okay, there will be also other participants, such as Professor Bacharishvili, Professor Lee, Professor Sheligin, Professor Pushkar, and Professor Tikhamirov. Well, I'd like to see who is participating in the Zoom. We're starting our school on laparoscopic prolapse surgery.
Hello, hello. Hello, hello. Does someone hear me?
Professor, but yes, that's the interpreter. Yes, we can hear you.
Yeah, you have an idea about when we will start because
I think we should start right now, but I have no idea. Some people are not connected and we can't see Layla. That's the problem. Can you wait for a while?
yeah, I wait, but I don't
Okay.
see no one. I don't
Thank
see
you. I
Leila.
don't see anyone except I cannot see you. I can just hear you, but we're ready. The translators are ready. As soon as we get go ahead from Layla, we will start. Just wait for a while. Thank you. in order to fully control the anatomic space and anatomic dissection. Well, if there is no perforation noticed, like in this situation, and we make a diagnosis after the clinical symptoms, why I showed you this video, because on the one hand, we need to treat peritonitis, and what is important is to remove the mesh, because when we have this strong infection in the abdominal cavity, a foreign body should be removed. That's one of the major conditions. And that is why we keep repeating that the operator himself must remove the mesh that had been placed before. That is why the operator should have the ability to place the mesh and also the skills to remove the mesh in difficult, complex situations. Naturally, the mesh should be removed fully. The perforation of the bladder is also accompanied by different complications. It doesn't happen all too often. 2.3% is when we have bladder perforations, especially when we're talking about the situation after extirpation, when we need to identify anatomical layers correctly. That is why in case of any suspicion, we need to feel in the bladder to check if there is perforation persistent. And at the very start, we entered the bladder, and only then we could see that we had a big perforation done. But with any suspicion, we need to feel in the bladder with methylene blue and identify the perforation site, and of course a suture this place. And of course you need to have a specific suturing skills and the knowledge how to suture the bladder. Another important aspect is erosion. That's the so-called natural erosion, but unfortunately it's also called mesh erosion. That's the situation sometimes we encounter in patients' vaginas. Well, up to 10% of erosions occur according to literary data, but the question is not just figures or statistics. We must realize that it's a dynamic process. For example, if we just stop and publish the article 2 years after the surgery, well, the exposure percentage is 4%. If we continue to monitor the same cohort of patients, this percentage will go up to 10%. So we must realize that these complications can occur in time. So after 10, 15, and 20 years, there is no complete guarantee that the mesh isn't going to get into the vagina. We must realize where risk factors are. Sometimes there is a need to understand why this complication occurs. As for meshes, right now, the situation is more or less clear. This is our old study where the exposure percentage was 5.3, but the most percentage of exposures when we analyzed the situation in detail was 25% in a group of patients with extirpation of the uterus. When we placed the mesh after the uterus was removed and the vagina was opened, and after the chancy perforation of the vagina. Here is another publication in the United States. They published the similar percentage, 23% of exposure after the uterine extirpation. So that's the law. The extirpation of the uterus and opening of the vagina, they are contraindications for mesh placing. Yes, there is a complication. Mesh should be taken out. That's not a simple question, how to remove the mesh. I should say at the outset that not all meshes should be removed. Everything depends on the clinical manifestation of the problem of exposure, but all publications, including our data, have shown that in more than 50% of cases, more than 50% of meshes in the vagina after the surgery lead to complications and should be removed?
So there is an algorithm in place which we developed. It depends on this erosion, whether it is asymptomatic, whether it may provoke bleeding, dyspareunia, or infection. If it's asymptomatic, just wait and see. Local therapy with antiseptics and estrogens, when it provokes bleeding, dyspareunia, we need to remove, but only the part they may be provoking this clinical manifestation, only the vaginal mesh. When it has to do with infections, it's important to know which sort of mesh was used. If they used a mesh from polypropylene, PP mesh, sometimes it suffices to change away the visible part of it. Usually PP is infected in only one visible site in the vagina, and you don't have to remove it all. But if the mesh is made of polyester, PE, then usually you have to remove it, the whole of it. This is both literature and personal experience all stand for it. So you need to first look at what sort of mesh it is. Several examples, when you have this small exposition, which is quite comfortable for vaginal approach, we can do it. But several years ago, we described endoscopic, we called it vaginoscopy. What is it? We put in place for monoport surgery into the vagina. Then we create the so-called pneuma vagina. We are insufflating the vagina with endoscopic control, and we remove the mesh. What is interesting about this session, this approach, about those who are positioned high in depth, but they can still produce the symptoms, they can produce purulent discharge, so they had better been removed. If they're not infected, they are very easy to remove. It's enough to remove them from the vaginal part. Sometimes you need to do it laparoscopically because major defect is there. You cannot get it all out from across the vagina, especially if you have to cut out the mesh from the promontory. But the most difficult to treat group are infected meshes. This is a well-known law in surgery, sort of, when infected alien body is infected, then unless you remove this, it would be impossible to achieve complete control over the infection. Antibiotics will not be very helpful. You need to remove the mesh, and it's not easy. There is a portion of the mesh that is easy to remove, but there are some that prosecutely are adhered to the bladder or to the bowel. This is difficult. When you need to remove this infected mesh, you may see perforations when, like here, where the perforation of the bladder, sometimes of the rectum, sometimes of the ureter. So the rule at all times is to check, could we have done a perforation of these essential organs? What is also important is to remove the whole mesh, not just pieces of it. The patient where we removed the mesh with some 10 years after that, after promontory fixation, we had thought that we had removed it all, but complete mesh removal. But the patient reported 2 years later for MRI, and we could see abscess, 1 centimeter, but it was giving very nasty discharge. Exactly, because the source of this discharge was exactly that tiny piece, 1 centimeter piece of mesh. So it's crucial to know, and every time, even when you have severe situations, we do all it takes to completely remove the mesh. This is where we see the difficulty. Usually we see a lot of inflammation. The risks are that we could provoke bleeding, that we could injure the blood vessels because the anatomy cannot be clearly seen. We are working like in the promontory without visible vessels. So that is why we need to be very much on the lookout. And a lot of experience would be helpful. Another example, another case, there's functional, good quality surgery Belmonte fixation may result in a severe operation, such as resection of the bowel, where the mesh has gone beyond, has sort of invaded the rectum, was giving strong symptoms and discharge to the patient. So we had to remove this infected mesh completely. Do you see how bad it is? Look at the bleeding. We're not clear about the anatomy as we operate. And even after this important surgery, such as resection of the bowel, regrettably, unfortunately, the patient still developed the morbidity that is usually seen after intestinal bleeding, such as anastomotic leakage, rectovaginal fistula, and the patient in the long run was operated 7 times to correct her fistula. So one has to be very precise about indications, one has to be on the lookout, and one must be fully well-versed in the technique of operating properly. Rare complications such as expansion of the ureter. Here, the exposition of the mesh, exposure of the mesh to the left is the small intestine. To your right, we see enlarged ureter. The patient had impaired function of the right kidney, and it's difficult to expose the intestine, but we did it. So, but it was hard. And the chapter that would be interesting would be pain. Pain because of overcorrection, or sometimes because of retraction of the mesh. At times, the patient may report pain. And this is the question is whether it is an infection, but this infected mesh has to be removed or it has to be elongated. This option is also available. We have a series of patients where we elongated, where we had to remove the mesh just because, in parts or completely, because it would provoke dyspareunia, because the patient had dyspareunia, because very much like endometriosis, you had a deep nodule behind the cervix in the rectovaginal knot made up of the mesh that would be provoking strong pain. And it's not easy to remove this mesh completely. This is a post-overs video where they're trying to remove it all at the level of promontory. It was fixed with metal clips that were also provoking pain. These clips may also provoke the so-called spondylodiscitis in less than 1% of cases, but it's there. And the morbidity may be life-threatening, maybe when the patient would not be able to stand. And when you see clinical manifestations such as pain in walking, pain when standing, and strong back pain, one has to completely remove this mesh. So as we're wrapping up, we can say sometimes a mesh could be compared to the so-called Russian roulette, but I don't suppose it is justified in any way. One has to choose the right indications. And lastly, the last point I wish to make, one has to know how to position the meshes in place. One has to know how to remove them. One has to take care of one's own complications. Today, the technique of promontory fixation has been developed laparoscopically, so one has to be well trained, one has to be well versed in the technique, one has to be very knowledgeable about anatomy, one has to find the right patients for the surgery with the mesh. Mesh is not mandatory for all the patients with prolapse. One has to use polypropylene mesh, maybe aseptics, and it could be sound banal, but so one has to comply with aseptics rules. One has to avoid vaginal opening. And if you see infection, one has to remove the mesh completely. And one has to never underestimate long-term outcomes that have to do with the use of the mesh. Well, regrettably today, this question is not completely decided. We cannot say that, yes, things are all good about mesh, so we should remain on the lookout. should be vigilant, and we should have full command of all possible methods and techniques and skills of how to treat prolapse, be it mesh or mesh-free technique. Thank you for your attention. Well, dear colleagues, right now you will hear a presentation by the person who is in charge of this course, of this master class, Arnaud Bathiers, professor, a well-known teacher. Unfortunately, we made him wait. We apologize for that, dear Arnaud. You now have the floor, and we begin the school on laparoscopic surgery of the prolapse masterclass, which will be chaired by Arnaud. His lecture is titled Modern Perspective on Surgical Removal of Prolapse. The floor is yours.
Thank you, Leila. So do not worry too much. I was worried because I thought I did something wrong, but now that we are on together, so I feel better. So let me share my screen and voila, and just talk about the modern perspective on the surgical treatment of prolapse. And obviously, as you know, being, let's say, an aficionado of laparoscopy, I will speak mainly about the place of laparoscopy in that perspective. And so it comes like this, looking at the line of laparoscopy. And if you just look that we start to shift from laparotomy to laparoscopy in 1991, when we started to do the first sacrocolpopexy by laparoscopy. It just came just after the Birch, and it was just before the avènement of the TVT, as you know. On that slide, and I think I present this slide once in Moscow already, you see that from the 50s to the end of the last century, everything happened, from the organization of the technique of sacrocolpopexy to the shift of laparoscopy to the advent of TVT and TOT and the start of vaginal mesh placement. And obviously, when we do things new and we do not pay attention too much to evaluate clearly what we do, we have warnings. And so I put you the warnings we got since 2008. First warning on mesh. And the mesh was the warning on vaginal mesh. And this warning, beside morcellation, the LAG study in 2018, you have the ban of all vaginal mesh placement almost worldwide since now 2 years. Why I put the COVID is because all this put a pressure on laparoscopic approach of anything. So obviously on oncology, but even, the vaginal mesh ban put a lot of pressure on laparoscopy, as for the patient, they do not understand the root, they just understand the mesh. And so now we see every day coming patient in your office with prolapse say, no, I don't want to have any mesh. And you may explain what you want that you do by laparoscopy, but no one will accept it. And then the COVID came, and all these publications that you should not do laparoscopy during COVID time for the risk of contamination of the personnel, etc. So we laparoscopists, we are just, very worried actually and trying to understand what happened. So the question is that the return of the native tissue repair? And we have data that shows that this is not the solution. Is that the return of the site-specific repair? And we know also that exposes our patient to iterative surgery. And you know that we have done a lot of improvement in the last 15, 20 years. And if you look what we have done a lot. And specifically, remember what I said this morning, everything is driven by anatomy. We did a lot of improvement in anatomy, with a lot of improvement on the concept, a lot of improvement by shifting from laparotomy to laparoscopy, a lot of improvement in the knowledge of meshes and the way to fix them, We have simplified the laparoscopic technique, and as Reva has just demonstrated us, we have understood the etiology of our complication, and we know better how to prevent them and treat them if they occur. And so it means that it starts by the anatomy. We have a much better knowledge of the physiology of the suspension and orientation of the pelvic organ. We have much better knowledge on the cause of the prolapse now. And so, for example, we know since the new work of the Lancy 3-4 years ago that there is no rectocell or cystocell without an apical prolapse. And that brings us a lot of argument for a full pelvic reconstruction. We learn a lot about the aging of tissue. And so that gives you an idea why the native tissue repair do not work always. And if you look, for example, on the right side of my slide, that the comparison with a young uterosacral ligament, if I can say like this, versus an old uterosacral ligament, and you see that the rigidity of the ligament is much higher when it's old than when it's young. And so when you do a native tissue repair, obviously you repair with native tissue that have become old and have posed problem. And so you cannot expect to have a good result with this. I don't say you should not do it, but you have to understand that this is a quite, let's say, a reduced longevity of your repair, and you may expose your patient to reoperation. So we have new classification divided the 3 compartments. So now we know that those 3 compartments are linked. And so the principle of an anatomical reconstruction should include all global reattachment of all fascial components around the cervical ring. And so now you can do it by laparoscopy, you can do it vaginally, but the importance of laparoscopy is using a mesh is a little bit less dangerous. So we have the concept, and then we have the technique. So we have the concept, and the concept oppose global to site-specific and palliative to reconstructive. And what we have done the last 15 years is this. We moved from global palliative to global reconstructive. And that's why what I propose, and I will propose, that we should stop to call sacrocolpopexy we do today as like sacrocolpopexy we did in the past, because we don't do the same at all. So global versus site-specific is a conceptual debate. Global, you repair all compartment. Site-specific, you repair only the prolapse compartment. Obviously, after the work of the Lancy, you see you are not updated. And so if we know now that there is no cystocele and no rectocele without apical prolapse, it means that probably the concept of global should be reconsidered. And then if you look palliative versus reconstructive, palliative is a technical debate, and palliative, the technique treats the symptom, as reconstructive, the technique treats the cause. And you understand why the change we have done to move from global palliative to global reconstructive is exactly what we should have done. And so, I mean, before, at the time of laparotomy, we are doing laparotomy, we are placing only a mesh anteriorly. We were mostly always doing birch by not know the lack of knowledge of the technique, and most of the time by too much tension. And we were doing a posterior myography to treat the posterior compartment, and this could have been done at the same time or delayed in the time to protect the mesh. Look what we do now. We do laparoscopy, so we have an objective reconstruction. We reconstruct the fascia by replacing them in their anatomical position. We spare the nerve, we shape the mesh, we fix the mesh properly in anatomical position, limiting the risk of mesh erosion, restoring the normal fascial anatomy, eliminating the risk of hypercorrection, and limiting the risk of recurrence. So look what we have changed. And that's why my proposal is to use meshes by laparoscopy, because we have excellent results. I pass about the shifting of the laparoscopy because it seems that it's evident to move to the wide acceptance of primary repair using mesh. That is very interesting because this is what I say. We know that the pelvic floor defects are due to fascial alteration, and repairing with alterated fascia is not good. So we know that we have long-term good results with reparation with meshes, but the condition is to place it in the right way. So what is the right way is probably the root, but it's probably to understand that using the good mesh, we have this. So the mesh tissue ingrowth is very important because this is what gives the solidity and the persistence of the montage. And so we know that the first phase when you place a mesh is a call of macrophage, is a lot of inflammation. And what you should do in your technique, you should reduce the intensity and the time of the inflammatory period in order to avoid the complication that has been shown by Revaz. And so what have happened the last decade, they have accepted to place the vaginal mesh, and they place a lot of meshes vaginally. And you know all those different models we have seen in the market, and we have paid the price. We have paid the price by infection. You have seen the complication shows by Revaz, but we have a lot of complication by vaginal mesh placement. We have fistula, abscesses, fasciitis up to this. And so, I mean, this is not rare to have seen this, and that's why they banned the mesh after the warning of the FDA in 2008. Nevertheless, it has been few concepts that has been good, like the tension-free concept that avoid probably in the long term some complication, and the transtissular fixation that give a new way of fixing meshes without fixed point. And so I think that this is very interesting for the future of development of repair by laparoscopy. So the simplification of the technique has been important, and we have to follow the reparation of the double axis of the vagina, knowing that the anterior axis is more acute than the posterior axis, and so that we have to respect this functional anatomy when we do that. So to move and to give you some videos, so I start with this. So it means that just to show you that we have to respect a lot of recommendation. So this is a classical so-called sacrocolpopexy we do today. So we start by the coagulation of the promontorium. We understand now that in the promontorium is the start of the 3 spaces that will be behind the rectum. So what we do, we just insert only the peritoneum. We don't want to go under the presacral fascia, so we stay above the presacral fascia, and we are going to progress between mainly the ureter on the right side and the insertion of the mesosigmoid and mesorectum. And you see here what I said this morning, the importance of the work of the assistant, the importance of the exposure to understand, and the importance of following very simple things like this, which are the bubbles. And crossing here, you will see passing the different structure that we are now saving, and you will see at this time the passage of the right hypogastric nerve right here. You see the right hypogastric nerve is preserved and safe, and we stay at the level. And even at the level of the rectum, as I told you this morning, follow the bubbles. The fat belongs to the rectum, and so you have to respect that. Again, when you do this, it's very important to have a good vision and exposure.
They tell me that the recording has stopped. What has to be done? What do we have to do? Who is finding out what from whom? What is going on? Спасибо. Good. Проблемы могут быть. Unfortunately, Professor Adamian's mic is off. Unfortunately, the mic at Professor Adamian, the chair's mic is off. We're still waiting for Professor Vattiers to log back in. Apologies for the glitch.
English tunnel. Voilà. So I have to share again. Sorry for all this. It's too complex today. What happened? Keynote here. Voilà. So you see that we can do. What I want to show you in this where I'm not. What I want to show you in this video is that the dissection we do, for example, on the anterior compartment are totally changed. And you know that there are some publication, and probably I'm sure that Trevas talked to it, that shows that the lower you dissect the anterior compartment, more you reduce the risk of recurrence of the cystocele. So every millimeter you earn makes you having a better result. That's why now we dissect much more. And here you see, for example, we go on this Yabuki space that drive you under the ureter that you see appearing now, and so give you the upper part of the trigone. And doing so on both sides, you may dissect the bladder as low as necessary until the trigone. And I think that this is the good place to stop, even if you can, same side on the left, you can go lower than the trigone, but I think I will not recommend it. So you can dissect this Yabuki space, which is normally used for oncology, but here you see that you will pass under the ureter and identify very precisely the prolapse. And so then you place your posterior mesh, your anterior mesh, and you fix it to the promontorium. And doing so, you have a full global repair. That's why we cannot call that colpopexy. We do not fix the cervix area to the promontorium. We do a pelvic floor reconstruction with or without mesh. And coming to point, because my time is limited, I will move to, if no mesh, alternatively, you can use a native tissue. So you start like this. You start by the fact that when you do an hysterectomy, look, you have to repair anatomically the vaginal cuff. And here you see very clearly the pubocervical fascia, and you see very clearly that the closure of the vagina is done by closing the vagina itself separately from the fascia. And so we do it systematically for every case of hysterectomy with the goal to prevent the prolapse in the future. And so here you see that now we have done the first row, taking all the vaginal wall, and then now we take the fascia. And here you see this is the pubocervical fascia, and posteriorly we are going to get the uterosacral ligament and the cardinal ligament. And so you see that doing so, we do not hyper correct the patient. We just replace the tissue in an anatomical position, and we go back to the origin. And doing so, we realize a second layer. Look the fascia, how big it is, how good it is, and we do realize the two-layer closure, as you see here, as well as the suspension. And what happens if you have a prolapse? If you have a prolapse, you do exactly the same. You close first the vagina, but then you do a kind of McCall. So you take a strong bite on the anterior fascia, and that's why you have dissected the bladder, and you take a strong bite posteriorly to the uterosacral cardinal complex, and then you will suspend. And you can do one suture, two suture, and it's better in that case to do separate knot. And as you see, we make great bite of tissue and great bite of the uterosacral complex. And we tie the knot, and we are going to repair all the things. And you can do 1, 2, or 3 sutures to suspend higher in case of need. Alors, we have spoke about the mesh rapidly, and I give you the principle. We have speak about native tissue. There are a lot of techniques available and you can even do some suspension of the vaginal wall to the promontorium with suture. I don't like it, so that's why I don't promote it. But here, this technique, providing that you have dissected well, you know exactly where are the ureters, these are very efficient. And this is very efficient in such a way that this patient that we do here, we did a native tissue repair because she had a fully exteriorized prolapse, and I will show you the picture. She had a fully exteriorized prolapse with an hypertrophic cervix that need us to remove it. And I don't like to do trachelectomy at the time of mesh, so that's why I decided to do a full repair with native tissue. And so now that you have understood, so look, this was on the left side, the prolapse of this lady. This has in the center the hysterectomy done with the hypertrophic cervix, and you have the result seen directly. And you see that the hymen itself is restored inside, and the hymen is, you know, that the referral point for the Baden-Walker classification. And you see that the vagina goes without cystocele and rectocele. So we are also efficient with native tissue, probably more, in my opinion, by laparoscopy compared to laparotomy, but still, we know that the tissue are a little bit weak. To summarize my lecture, because my time is over, I think that what we do today by laparoscopy is absolutely not a sacrocolpopexy. We do a pelvic floor reconstruction using mesh or using native tissue. And the door is really open for new techniques, new dissection to repair much more specifically the anatomy to improve the result of native tissue, which are by definition a little bit less than the mesh technique. But coming back to the mesh, using a good technique, a good knowledge, using the anatomy and good dissection, you have excellent result in the time without too much complication. And I want to thank you for your attention. And I apologize for the disconnection, which is totally out of my wish. And I hope that my message has been clear. Thank you, Leila.
Arno, thank you so much. We are sorry for this technical problem. Well, we had poor connection on your side and poor connection on our side. I have one question for you. Could you tell me, please, during all your life, you are a master in terms of plastic surgery, and what did we discard? What are we going to take into the future? What things did we discard? We gave up on maybe some meshes or some sutures or some techniques. We decided not to use them anymore. And what are we going to take with us into the future, please?
Thank you, Leila, and no problem on that.
And also your attitude toward the fact that we use mesh less and less. Using mesh less and less, is it bad or what?
I think it's bad. Honestly speaking, I think that the use of mesh abdominally is associated with excellent result and a little number of complications, providing that you know exactly what you do. I think also that the warning and the ban of the vaginal mesh made us to improve our technique of dissection, to improve our technique to recognize the important structure that sustain the organ, and a better reconstruction, even with native tissue. So I think that the future is with two axes. In my opinion, one axis where we should talk again about the mesh by laparoscopy in good hands with all the principles that we know and expose to much less complication. And the second arm would be to develop much more technique without mesh and by a better knowledge of the anatomy and the better knowledge of the technique of dissection. And I think we are here.
Thank you. One more question and we'll continue with other presentations. Arno, well, right now, there are no measures that can be absorbed, right? Absorbable measures. No more, right?
But I think
all are non-absorbable measures, right? Do we have any new class, a new type of measures that can absorb later and cause no problems?
But in fact, we have tested everything from the fully absorbable, semi-absorbable, synthetic, non-synthetic, origin from animal, collagen, whatever. We have so far tried everything. What we know from the absorbable is that mostly the absorbable create a very, very high inflammatory reaction. And this inflammatory reaction is against the good result of the use of mesh. So I think that the bad idea is to have a mesh which is partially absorbable. So either you make it fully absorbable or you make it fully non-absorbable, and I prefer the fully non-absorbable. And so in that case, the result will be better. But I think the work we have done about reducing the grammage and the weight and the porosity of those meshes makes that I think that really a light mesh, well placed, without tension, with a limited surface is the future.
Thank you so much, Professor Batiès. Let's continue with other presentations and would like to wish you good luck. Dear colleagues, right now, would like to give the floor to academician Shaligin and Dr. Birikov, pelvic floor prolapse correction by laparoscopic rectocolposacropexy. Well, good afternoon, Leila. Can you hear me? Yes. Please do not overrun your time. All right, please, I'd like to share the screen so that you could see my presentation. Dr. Kashan, be prepared. Your presentation will be next. Just a minute, we have some technical problem here again. Sorry, Leila, we have some technical problems. We'll try to share the screen. All right, is it a serious problem? Well, looks like we're almost ready. We've managed to open the presentation. All right, here we go. Yes, sorry about that. Sorry for this delay. All right, the theme of my presentation is pelvic floor prolapse correction by laparoscopic rectocolposacropexy. The state of the pelvic floor of a woman is very important, but there is a situation in a woman's life when the pelvic floor is weakened, and there might be such conditions as you can see here, like intussusception and urine incontinence and the sexual dysfunction, which worsens the quality of life of a woman. Well, As for pelvic floor prolapse, you can see that they occur from 30 to 93% in women. The reason can be different. Well, you can see that every third woman after delivery before 50 can have this condition. After 50 years, every second woman has pelvic floor prolapse syndrome. However, as for pelvic floor prolapse, it can occur also in young women who are nulliparous women. And I should say that this is due to genetic predisposition. And this hypothesis can be confirmed by the family forms of pelvic floor prolapse. At our center, we conducted a morphological study of the fascia of the pelvic floor, and we identified a lot of problems related to erosion of the connective tissue, such as hyperelastosis, lymphostasis, and cellular dystrophy. That's the thing we paid special attention to, and this led to apoptosis of cells. Thus, we managed to make a conclusion that elderly women with pelvic floor prolapse have irreversible changes in pelvis. What is important is that the pelvic floor prolapse symptoms can lead to intussusception or other conditions such as rectal seal. In 68% of cases, a prospective study with rectal seal and intussusception were included, and there were a lot of concomitant conditions that these women had that led to poor functions of the rectum. That's the reduction in erectile sensibility, also depression and anxiety. In order to diagnose all concomitant pathological conditions that may have an impact on pelvic floor organs and rectum in particular, we do the functional examination aimed at this synergy of pelvic floor muscles, and 65% of patients have different functional problems with defecation. Naturally, correction must be done here by using the conservative methods, not surgery. And then we can see that in 70% of cases, we can improve the functions of the rectum. Conservative treatment also includes such things as the production of reflex for defecation, and also we administer laxatives to such patients. Usually we do this for all patients who have a pelvic floor organs prolapse, and we achieve good results in 50% of cases. Also, there are cases when there is no effect of the conservative therapy, and we can see the clinical picture of obstructive defecation syndrome. And in this case, there is a need of manual help, and also there are logical signs such as rectal seal or internal intussusception. In this case, we may administer surgery. Well, surgical treatment is shown here, especially when we strengthen the anterior wall. These are patients with rectal seal, and in case of internal intussusception when it goes into the rectum and obstructs defecation. When we have a rectal seal or internal intussusception, we use the transvaginal, transperineal, transrectal approach. But in case of combination of these conditions, we use a transabdominal access, allowing us to deal with all these changes quite successfully. It is interesting to note that only 1/4 of patients had the isolated rectal seal. Others have rectal seal plus internal intussusception, also rectal seal plus internal intussusception and sigma seal, as well as enteroseal. And of course, while examining women, we detect such conditions. Here you can see a rectal seal with the internal intussusception into the rectum. When you can see part of the rectum is in the anal canal. And this slide shows other combinations, rectal seal with internal intussusception and enteroseal. Well, again, you can see the sigmoid, which is very low, and there is intussusception here, and obviously the loops of the intestine can be part of enteroseal. To treat such conditions, we use such method as sacrocolpopexy or rectocolposacropexy to be more precise. And in this case, we go all the way up. Here we place a mesh. At the bottom, again, we fix the mesh to strengthen the pelvic floor, and we also fix it to the promontorium. Well, this method allows us to do the restoration, the repair of this problem. We fixate the rectum. We basically restore the situation related to hypermobility, and this gives us quite good results. Well, we also preserve lateral ligaments, and this is a very important factor, and also we reduce the risk of functional disorders after the procedure. These pictures show the anatomical results of the treatment of a patient who had a rectal seal and internal intussusception into the rectum and the sigma seal. Well, you can see the voiding of rectum encountered problems after the procedure. The situation improved. Here you can see the situation before the procedure on the left and 12 months after the procedure. So here you can see quite a significant part of rectum intussuscepting into the vagina 12 months later. As you can see it here, we have no major problems. Again, you can see the situation before the procedure and 6 months after the operation. You can see 6 months later, the problem has been tackled. Again, you can see the situation before the operation and 15 months after on the right. That's enteroseal, a patient with enteroseal, and you can see 15 months after the operation, the situation has improved. Well, as for the functional state of the rectum, we used our own scale. The intensity scale, the maximum points 22, and you can see that the disorders that the woman had were related to the voiding of the rectum. After the operation, there is the improvement of the voiding of the rectum by 48%, by 81.4%. And you can see that in 18% of cases, there were no improvements. And those patients who had no improvements are shown at the bottom. And again, their number of points was basically the same on our scale, from 9.2 to 12.2 points. And you can see that when we were monitoring our patients in the post-operative period, long-term post-operative period, we could see that there were improvements, but it went down during the first 2 years after the procedure in 37% of cases. However, all these patients, as compared to pre-operative period, had the improvement of the colon. Well, here you can see the improvement of symptoms, and there are manifested improvements for the better, because these patients had the changes in the connective tissue, which I have already mentioned. And of course, this is a very dynamic process. It can lead to progression. And in this case, the problems might occur again. And plus, there might be concomitant psychological and physiological disorders in such patients. They also have an impact on the functional outcomes, and this leads to a lesser number of positive outcomes in long-term period. In conclusion, I'd like to say that in 75% of cases, patients had combined manifestations of the pelvic floor organ prolapse and other conditions. Well, laparoscopic procedures allow us not only to deal with the disorders, but also to improve the function of the rectum in 81% of cases. Thank you very much.
Thank you very much. This has really inspired us. I'm sorry for the delay. Well, I know what can be done. This is technical glitch. We're talking about artificial intelligence, but so far we still have some difficulties. Thank you for this interesting section. So best regards to Yuri Anatolievich. Now, Professor Kasyan has Pakatimishin Pushkar, Professor Pasisyan, how to explain how we manage our patients. Please, Professor Kasyan. A very good afternoon. Yes, management of prolapse. Yes, you know, good afternoon once again. Allow me please to introduce our presentation. We've been speaking at length about which methods are being used. What about surgery? Whereas I'd like to show you the aspects that help us as we seek to explain and give rationale for each specific decision that we take. We'll discuss anatomy of prolapse, differential diagnosis, dynamic 3D scans, and so on. Ultrasound for prolapse helps us clarify, confirm, or exclude the diagnosis, whether we need hysterectomy if there is elongation of the cervical neck, what happens with the bladder. But traditionally, we've been saying that when we do ultrasound, we talk either about injury of levator ani, as well as prolapse. But as it turned out, this injury, this avulsion of levator ani, does not necessarily correlate with the severity of symptoms. It is the grade of prolapse that is immediately correlating with the complaints and symptoms that the patient seems to be complaining of, but trauma and injury in prolapse, as we can see an ultrasound, including 3D ultrasound, does not necessarily go hand in hand with the severity. What comes more prominent today is MRI. We may see so-called hidden defects we were not aware of. We can do diagnostic scans to exclude some pathologies and build dynamic models. Well, simple situation, it looks like descent, but it is not. MRI shows it's not cystocele. This is a fibromyoma or leiomyoma of the vagina, or this patient who came us because of the difficulty urinating. MRI showed it is cartilage cyst that rises from the symphysis, pubic symphysis, that seems like rare, but all the rest, but this seems to be like supra approach where we had to remove this sort of bulky mass in the vagina. MRI is irrepressible here. This rectus coeli, the posterior wall, looks very much like rectus coeli. Do we do repair? No, let's refer the patient to MRI. Very rare vaginal cyst of the posterior wall, and MRI helps us diagnose the patient in pre-op setting. We use to a great extent, but now because of COVID, we are not really using it that extensively. We've been using, our colleagues still continue to use it. This is so-called dynamic MRI, where we can visualize prolapse and the patient pushes because and exerts herself, because all other methods are static. Look how clearly we can see both the bladder and how its mobility, the mobility of the rectum. Well, the rectum is filled with ultrasound gel. There it is. Very much like vagina may be filled with a gel, pre-filled with gel. These dynamic scans give us a lot of information. It helps us understand how we see where the bladder is, if we have elongation of the cervical net, is there a uterine prolapse? This patient in physical examination, and to the left is her dynamic MRI, and it becomes clear that what this prolapse involves is both the bladder and the cervical neck, and the descent of the pelvis, of the uterus, sorry. Surely, any additional information can help us take a different look at surgical repair of the prolapse and maybe take a very different decision, because this knowledge changes our plan of repair. Do we need resection of the cervix? Of course. Do we need to support the uterus? Of course. Hysterectomy, but you see, cystocele, it will not go away even if we remove the uterus. We studied at length, and we still continue to do so, a so-called mobility of urethra. Urethra is changing its axis in prolapse, and this may explain the incontinence which may strike the patient after surgical repair. And this is something highly important in terms of the function. The thing is that all modern classifications of prolapse of the genitals are 2D. We're looking in one plane, but prolapse, in point of fact, is a 3D defect, 3D descent. And of course, one can only judge about it in 3D only. Based upon this, we came up with attempts to, first of all, we looked at dynamic MRI, and then we went into 3D models of the pelvic floor. There they are, these models. This is a 3D scanner where we looked at the prolapse in statics when a patient pushes, and we see this dynamic increment of the volume of prolapse. We can see how the volume may change of the tissue. Based upon this, we may look at the mobility of the tissue, whether we should use or not use synthetic materials. Very exciting data, which we are still analyzing, we see asymmetric defect. Almost 10% of defects are asymmetrical. Does it matter for our reconstructions? Well, if you use mesh, maybe not. But if we discuss what Professor Vattiers was saying, sooner or later we shall have to do native tissue reconstruction. It's important for us to see where this defect arose and how we can repair it. Lateral defects are fewer to come by on average in prolapse, but reconstruction is quite special here, and classical colporrhaphy will not be much use. You should do other interventions such as Richardson's and other laparoscopic operations. Surely, what matters here is we are studying the urethra, we are studying mobility, and in the context of whether we can predict how urine incontinence, will it affect the patient or not? In conclusion, may I say that this new data on anatomy helps us reassess and reevaluate the situation. It helps us take a very different perspective on the problem. It helps us create 3D models. Their novel 3D approach to treating genital prolapse is something truly important for better understanding of their reconstruction, in order to understand what is it that we do, and so that we could understand what would happen next. In my view, what is very important are dynamic studies, because prolapse is not about static situation. We perfectly know in our clinical practice that a patient may be examined in the morning and in the late afternoon, and we would see something very different. So based upon it, we can hope that at some time we may be able to provide precision repair for prolapse exactly affecting these zones that were subject to overexertion, where the effect is there. Many people say that much wisdom gives you much sadness, and that knowledge may multiply. It is Solomon who is believed to say so, but it is true, because wisdom, well, it's something very basic, very much basic. But as to prolapse, the more knowledge, the less sad we will be, in a sense of we will better understand and we will have few things to concern us. Well, thank you very much. Thank you, Professor Kassian. Well, you did very well by wrapping up this group of operations on a very clear-cut, highest level, using very good language. Your clinic is a leader here where we cannot cope. We as gynecologists, we provide comprehensive care for his. So thank you very much. Thank you, Leila Vladimirna, Dmitry Yurich. Thank you so much. We appreciate your contribution. Goodbye. Thank you. So let's announce the next speaker, Bogdan Bekar. Shailesh, do you read us? Do you hear us, Shailesh? Okay. So we need a technical break. What do we say? Dear colleagues, we announce a technical break, 5 minutes. In right now, it will be followed by expert school on typographic anatomy, navigation in the surgical field. Bogdan Bekar, Shailesh, India, long-awaited school. Please get ready. It is a fantastic school that is well worth maybe even make a video. Now we can see Professor Pundambekar. We can see you. Please unmute yourself.
Hey, tell him hi. Hello. Hello. Seema. Hello. Hello, Leila.
So ते त्यांच्या language
Shailesh, hello, hello.
Hi. Good to see you.
Which?
I am ready with the presentation. You tell me.
We are all set. Please begin, Professor Pundambekar. Please begin.
Okay. Good evening, everybody. This is hello from India, and this is the importance of surgical anatomy, which is what I'm going to discuss with you today. It is the anatomy not from the books, but by simple dissections that we do. For the surgeon, it is very important to know about the entire anatomy, because it is anatomy, and nothing else but anatomy. So knowledge of anatomy is very important, and especially the power of predictive anatomy, because you need to predict what is the next structure. So preliminary considerations are sacral promontory, vessels, spaces, and nerves of pelvis. This is the sacral promontory, and from the sacral promontory the pelvis starts. At this level you have the superior hypogastric plexus and the common iliac artery, which remains at this level. It also, at this level, the superior hypogastric plexus lies right in the center, and therefore you have a very high chance of damaging it when you do sacrocolpoplexy. This is another picture to show you how at the level of the sacral promontory you have the superior hypogastric plexus and how the two nerves go on the either side. At the sacral promontory, the ureter crosses from the lateral to the medial side over the bifurcation and continues to remain as the most medial structure. So the knowledge of anatomy, if you remain medial to the ureter, then there is no way you can damage any of the major structures which are there in the body. So this is the knowledge of anatomy, which is very, very important for all of us to understand. What about the vessels? We have the various vessels, and the ureter crosses these vessels right in the beginning, and therefore it is important to know about the vessels. The most important thing is, except for the ovarian and rectal vessels, all the vessels come from the lateral side, as you can see. So what does it indicate? That there is a long length of the vessels available for ligation before they reach the organ. Therefore, if there is any bleeding which is very close to the uterus or very close to the bladder, you still have a long length, and that long length you can use to dissect and then clip the ureters, clip the vessels. Now, this is the common iliac artery and the superior hypogastric plexus. You can see at the aortic bifurcation how the superior hypogastric plexus lies over there. What about the external iliac vessels? You can see that the external iliac vessels and the artery as well as the vein has no branches as well as no tributaries, as a result of which you can understand that the entire lymph node dissection can only be done by doing just remaining parallel to the vessels. If there were tributaries, if there were vessels, you would not be able to do this dissection. So knowledge of anatomy helping you to do the dissection, just remain parallel to the big vessels. This is how the external iliac artery looks, the external iliac vein looks, and then of course you have the only branch of the external iliac artery is the inferior epigastric artery and the inferior epigastric vein. For the gynecologist, the internal iliac artery is the most important thing. The internal iliac artery divides into two, the anterior and the posterior division. The posterior division immediately dips down to supply the muscles of the gluteus. What about the anterior division? the anterior division traverses for 6 centimeters before the first branch, which is uterine artery, which is given. So there is a long length of the vessel which is available. This is a picture to show you the bifurcation of the common iliac artery, and you can see the common iliac artery bifurcation. Look at the anterior division of the internal iliac. You have a long length of the anterior division available for ligation before the first branch, which is the uterine artery, which is given. The only artery which is the lateral branch of the internal iliac artery is the obturator artery. And you can see that the obturator artery always lies below the obturator nerve. So how do you use this knowledge of anatomy? When you want to do node dissection, remain anterior to the obturator nerve. You should never go below the obturator nerve. What is a corona mortis? There are only 2 tributaries of the external iliac vein, the deep external iliac vein and the inferior epigastric vein. They form the corona mortis, and this is more important for the surgeon. It is called corona mortis because there is a communication between the external iliac vein and the internal and the obturator vein, which is a tributary of the internal iliac vein. Another picture to show you that there is a long length of the internal iliac artery available for ligation before the first branch, which is the uterine artery, which is given, the second branch, which is the superior vesical artery, which is given. Thus, you have a long length of the internal iliac for ligation, long length of uterine artery for ligation, and therefore, whenever you want to ligate the internal iliac artery, do not ligate close to the bifurcation, but go just below that. What about the uterine artery? It traverses for 7 centimeters before it reaches the uterus. And the uterine veins, they lie below the ureter. So the ureter lies in the fork between the uterine artery on the top, which you can see, and the veins which are coming from below. How do you use this knowledge of anatomy? If there is bleeding, you have to understand from where the bleeding is taking place. If it is the arterial bleeding, just dip down the ureter. If it is a venous bleeding, just lift up the ureter because the veins come from below. Another pictures to show you how the artery goes anterior to the ureter and vein goes below the ureter. This is how you can very clearly see that. There is always a feeding vessel from the uterine artery which supplies the ureter. Again, few pictures to show you long length of the uterine artery. This is the only artery or the only structure that crosses the pararectal space transversely. Again, you can see the pararectal and the paravesical space. The only vessel which crosses this transversely is the uterine artery. Again, you can see what about the uterine vein? As you go close to the uterus, you have multiple veins. But if you go lateral and if you go below the ureter, you will find there are only 1 or 2 uterine veins. So these are the landmarks. This is the most important thing is the ureter. Ureter carries its own mesentery, and therefore you can strip the ureter right from the sacral promontory up to the pelvic brim, which is lower down. Again, a few pictures to show you how the ureter is carrying its own mesentery and how you can dissect it from the internal iliac vessels very nicely. The artery going above and the vein going below. There are fallacies of the old anatomy schools, and that is the reason we have to go in and look at the distance of the ureter. The ureter lies at more than 2.5 centimeters from the uterosacral, and it always lies at the base of the uterosacral. How do you use this knowledge of anatomy? When you want to do a total laparoscopic hysterectomy, remain at the apex of the uterosacral because the ureter lies at the base of the uterosacral. So this is how you use the knowledge of anatomy to do good dissection. The ureter is like a hamburger. You can see it carries its own mesentery. It has the artery which is going from the top and the uterine vein which is going from below. This is how, again, this is the fork in which the artery lies. What about the avascular spaces? There are 2 kinds of spaces, which are the Ladsko space and the Ukabayashi space. And these spaces are only seen when you dissect the peritoneum. So they are potential spaces. They are not the spaces which are immediately seen. You need to make efforts to do the dissection. So we are going to talk about these spaces, the prevesical space, the paravesical space, the lateral paravesical rectal space, and the medial pararectal space. These are the four spaces. The paravesical space is the lateral paravesical space, which you can see lies parallel to the bladder. The pararectal space lies parallel to the rectum. The rectovaginal space lies between the two uterosacral, and the prevesical space lies in the anterior compartment. The prevesical space is the space which is dissected to do Birch-Colpo suspension. It is done with the technique of fat belongs to the bladder. So you remain above the fat and take down the bladder as much as possible. So this is how you can do and enter the prevesical space. You can see that this is the uretrovesical junction, and then you can do a Birch-Colpo suspension based on this area very, very clearly. This is the left pararectal space and the paravesical space. The pararectal space is the space which is lateral to the ureter, medial to the internal iliac artery, and the only structure that crosses it laterally or transversely is the uterine artery, as you can very, very clearly see. Again, a picture to show you the paravesical space and the pararectal space. The only vessels that crosses it transversely is the uterine artery. This is the anatomy of the paravesical space, which you can see. You can see that this is the uterine artery. If you want to dissect the paravesical space, just remain parallel to the uterine artery and push everything towards the entire, this is the uterine artery, push everything towards the uterus, and this opens up the paravesical space. So the paravesical space lies medial to the internal iliac artery or the obliterated hypogastric artery, and the base of which is formed by the levator ani muscle. So this is the anatomy of the paravesical space, which is important for everybody to understand. The pararectal space, as I said, is divided into the lateral space, which is the Ladsgo space, and the Okabayashi space. The lateral space, the only structure that crosses it is the uterine artery. There are two ways you can approach. One from the medial side by dividing the peritoneum medial to the infundibulopelvic ligament, and then you can see the ureter. And the other way is to divide the peritoneum lateral to the infundibulopelvic ligament and completely divide this entire area. So this is the lateral approach. And now you can see on the left side is the medial pararectal space, which has the hypogastric nerve, and the lateral pararectal space, which has got the uterine artery and the vein. So these are the pararectal and the paravesical spaces. The last space is the Yabuki space, which is medial to the ureter, and it is characterized by the presence of the hypogastric nerve as it enters into the bladder. So this is the Yabuki space, which is medial to the ureter. You can see the ureter near the scissors, and it is medial to the ureter, and from where the nerve enters into the bladder. This is the anatomy. You can see the Yabuki space here. You can see the ureter, and you can see the nerve, which is in the medial area. So this is the Yabuki space. You can see a very nice picture of the Yabuki space with the nerve going towards the bladder. What about the retrorectal and the prerectal, that is the presacral area? The presacral space is the space which lies beneath the rectum. This is open when you want to do endometriotic surgery, and it is characterized by the presence of Walder's fascia. So you can see the presacral veins which lie near the Walder's fascia. This is important that you should remain above the fascia. Again, the pictures to show the retrorectal space and the buttocks of the infant. The most important space that we have to use is called as the pouch of Douglas, or the rectovaginal space. This is the rectovaginal space which is here. You can see this. I will show you. You can do this dissection by saying fat belongs to the rectum. You remain above the fat, and you can go into the two layers of Denon-Villers fascia. So nicely you can go there, and you can see between the two layers of Denon-Villers fascia. You can go between the two layers of Denon-Villers fascia, and then this is the rectovaginal space. Fat belongs to the rectum. This is the most important dictum. You can see the pouch of Douglas. This is called as the anatomy of the fascias. There is a Denon-Villers fascia you can see posteriorly, and this is characterized by the area fat belongs to the rectum. So you can do this dissection. If you go in the fat, it's a wrong plane, remain above the fat, and it is the correct plane. These are the two layers. You can see the denonvillous fascia. This is the rectovaginal space. This is the space which is very important for endometriosis. Similarly, we have a cervicovesical fascia. This is characterized by the presence of fat. If you remain below the fat and then push the bladder, you can push the bladder completely, and this is the dissection of the moment. You can see the cervicovesical fascia. The fat belongs to the bladder, so remain below the fat. This is how the cervicovesical fascia surrounds this the vagina anteriorly. Fat belongs to the bladder, remain below the flat plane. And this is a video to show how you can go below the fat, just remain below the fat, and you can see how nicely you can dissect the entire bladder completely. So this is the way in which you can divide and dissect the entire bladder completely. This is the way you can do. Fat belongs to the bladder, remain above the cervicovesical fascia, and you can do this dissection. So navigation through the pelvis is best understood when you try and understand the anatomy very, very well. This is the cervicovesical fascia. Again, the pictures to show the cervicovesical fascia, and all these fascias are connected to the endopelvic fascia, which is very, very important. This is the endopelvic fascia, which covers the levator ani muscle. All the veins lie below this fascia. This is the obturator internus on either side, and you can see the endopelvic fascia on the either side. So these are the fascias of the entire pelvis, which is very important to understand that all these fascias are interconnected, and therefore this is a complex of lateral parametrium, cervical vesical fascia, gastric plexus. The genitofemoral nerve can be very nicely seen lateral to the external iliac artery, and the obturator nerve can be seen between the external iliac vein and the internal iliac vein, while you can again see the obturator nerve, and all the vessels should go below the obturator nerve. So it is very important to understand that. This is the obturator nerve. When you want to do pelvic node dissection, remain anterior to the obturator nerve, never go below the obturator nerve. What about the sacral plexus? This is the superior hypogastric plexus. You can see that it starts at the level of the bifurcation of the aorta, and then the nerves go on the either side. They are called as the inferior hypogastric or hypogastric nerves. These are joined by S2, 3, 4 fibers at the level of the uterine vein, and then it is called as the pelvic splanchnic nerve. So again, on the left side, you can see the nerves, and then the three nerves which are joining that area to form the inferior hypogastric plexus, which is at the level of the uterine vein. So genitofemoral nerve can be damaged during the para-aortic dissection. The obturator nerve can be damaged when you do a nerve sparing or the lymph node dissection, and the hypogastric nerve during nerve sparing radical hysterectomy or for endometriosis. So finally, ladies and gentlemen, these are the 10 dictums. The uterine or cervical pathologies do not reach up to the sacral promontory. So whenever you have difficult situation, start the dissection at the level of the sacral promontory. Dissection should be always done parallel to the tubular structure. Remaining medial to the ureter will avoid damage to the internal iliac artery. Remaining medial to the hypogastric artery will avoid damage to the obturator and the external iliac artery. Fat belongs to the rectum. Fat belongs to the bladder. Ureter lies in the fork between the artery and the vein. It always carries its own mesentery, and therefore the ureter can be dissected from the pelvic brim right up to its insertion into the bladder. There are no variations in the pelvic anatomy. So there is no reason for us to say that there is a different anatomy in Russia and different anatomy in India. The anatomy remains the same, and we have to learn this anatomy and master it. So this is my publication, Surgical Pelvic Anatomy in Gynecology, and this is in the FIGO Cancer Report 2018 International Journal of Obstetrics and Gynecology, and also in the Journal of Minimally Invasive Gynecology, which is the Understanding the Pelvic Anatomy. These are the books that I have written: the Laparoscopic Pelvic Anatomy in Female, Applied Surgical Principle. This is 1,200 pages. So you can go through all these anatomical pictures and understand how this anatomy is very important to do good surgery. So again, I take this opportunity to thank Leila and the entire Moscow Gynecologist and Obstetrician Society for giving me this opportunity. It's a pleasure to talk to you on a Tuesday evening. Thank you so much, Leila. Leila?
Shailish, thank you very much. How many years have you been prepared to do such a fantastic surgery? How many years does it take to prepare for such a surgery?
Usually, it took me almost about 7 to 8 years to understand the anatomy and another 7 to 8 years to master it.
Well, that takes a lot of time. Well, as for uterine transplantation, you are a fantastic surgery. The first uterus transplantation using laparoscopy in Untambikar, the cause of anatomy, and when you're taking stretch, well, I forgot what you say when you do stretch. Well, push and what?
No, it is pull, parallel and push.
Pull and push, right?
Yes.
Okay. Thank you very much, Professor Pandembekar. That was a fantastic presentation. Thank you very much and good luck to you.
Bye-bye. Keep healthy, keep safe, Leila. See you soon.
Thank you. Goodbye. All right. Now we have the next presentation. Professor Ted Lee, Pittsburgh, the United States. He is Vice President, AHL. A tutorial on sacrocolpopexy, please. Professor Lee, the
Good
floor is yours.
afternoon. My name is Ted Lee. I'm the current president of AAGL. I want to thank Dr. Laila Mayan for inviting me again to give this presentation on another great virtual conference. I'm going to go ahead and share my screen. And the topic of my talk today is a surgical tutorial, a systematic approach to laparoscopic sacrocolpopexy. I have no financial disclosure. The objective is this is not intended to be an evidence-based lecture, and basically it will provide you with tips and tricks on optimizing exposure, facilitating safe dissection, suturing, and minimizing complication. The following are the key steps to the procedure. Exposure is definitely key to any surgery. Specific to sacrocolpopexy is the rectal vaginal dissection, vascular vaginal dissection, and pre-sacral dissections. After you finish your dissection, obviously you need to suture the mesh to the vagina, either suture or tack the mesh to the anterior sacral ligament. And finally, you need to peritonealize the mesh in the end of the procedure. When it comes to providing exposure, bowel retraction is key to get the rectal smear colon out of the cul-de-sac and give you better exposure of the sacropalmatory as well. So use a epiploica of the sigmoid colon as a nice. They serve as a nice appendages for you to retract the rectal sigmoid colon out of the cul-de-sac and then away from the sacropalmatory. Once you can use a suture that can be retracted through the left lower quadrant trocar site. Alternatively, you can retract the suture to the left upper quadrant using a Carter-Thompson needle closure device. But if you use it through the trocar, so using the left lower quadrant trocar site as your retraction site, it's important to remove the suture out of the trocar. So when you put instrument through the trocar, you will not hit the sigmoid colon. You minimize the risk of the instrument hitting the sigmoid colon every time you insert instrument through there. Once it's retracted, you can have a great exposure to the cul-de-sac, and then as well as to the presacral space. You can see the suture is outside of the trocar, and that's very important. Great exposure, cul-de-sac, exposure to the sacropalmatory that allow you to do the dissection and suturing. And next thing is the rectovaginal dissection. The key is to keep the dissection close to the vagina and leave all the fatty tissues on the rectum. And the unique things I do for my dissection is with the use of breast narrative retractor. And this will help me to develop the perirectal space very, very quickly. And this is very, very reproducible. And how deep the dissection goes depending on the presence of posterior defect. If any portion of the posterior vagina protrude beyond the hymen, then patients should have the dissection carried down all the way down to the levator ani muscles. Otherwise, you are keep your dissection to the mid-posterior vagina. So here are two situations where that you would need to have a sacral perineopexy, or you need to have a much deeper rectovaginal dissections. In patient with low posterior defect, as well as patient with mid-high posterior defect. In essence, any patient with any posterior vagina beyond the hymen should have the dissection all the way down to the pubococcygeus muscle. You can see the pubococcygeus muscles, and you can see the medial bundle, which is the puborectalis muscle on either side of the rectum. Here's the vagina anteriorly, and here's the dissection that you need to do if you want to provide good posterior support. So we use the rectal probe to help us move the rectum to one side or the other to provide better exposure to the one side of the levator muscle to the other side. Breast narrative retractor is used. We anti-flex the vagina with a retractor, and this will create extra space for us to do the dissections. So do the dissection, we'll make a U-shaped incision from the vaginal apex and down to the uterosacral ligaments or remnant uterosacral ligament. On either side, we'll keep the incision parallel but medial to the uterosacral ligament. And this incision will allow us to open the entire rectovaginal space. We'll keep the adipose tissues of the posterior vagina. And again, the key is to keep the fat off the posterior vagina. So that way, when you finish the dissection, there will not be fat on the vagina, and which will make your suturing much more precise. And also, the key is if you keep the fat on the rectum, you're less likely to injure the rectum. And this is done all pretty much without edit. That's the left uterosacral ligament. Again, we'll make our incision parallel to the uterosacral ligament, but medial to the uterosacral ligament, and this provides a good access to the perirectal fossa. Following the lateral edge of the breast narrative retractor, our instrument plunge into the perirectal fossa. So if you palpate for the lateral edge of the breast narrative retractor and follow the edge of the retractor, you get into the perirectal fossa and expose the pubococcygeus muscles very, very quickly. We'll skeletonize the pubococcygeus muscle, get all the adipose tissues of the pubococcygeus muscle. And this is on the left side. And here's a rectum, which is not completely dissected. On the right side, we'll just follow the lateral edge of the retractor. We'll plunge in to the perirectal fossa, and it will give us direct access to the pubic muscle. And we'll use the rectal probe. We'll get the rectum off the posterior vagina. And this would, when we put the rectal probe and deviate towards the left side, that gives us a much more space on the right side. And this allows us to dissect the coccygeus muscle on the right side much more efficiently and much more effectively as well. So there's extra space by putting the rectum towards the opposite side, the contralateral side. Allows great exposure for the dissection of the pubococcygeus muscle. And this is dissection, this is a pubococcygeus muscle on the right side completely dissected off. And this is the kind of things that you like to see. Muscles on either side, vagina anteriorly and rectum posteriorly. So what happens if you put your suture on and the mesh on the either side of the rectum on the pubococcygeus muscles? That this is what you would like to see. So when you put the mesh on either side of the both sides of the levator ani muscles, you pull on the mesh, and you see what happened externally. You will look like the patient is performing Kegel exercise. You can see passive contractions of the levator ani muscle. So when you pull on the mesh, that's what you see on the outside. And that's really how deep that you need to go. So you can see that when the mesh is attaching to the muscle, will keep the vaginal opening smaller as well. The next we'll talk about vascular vaginal dissection. The key is is to get the bladder off the anterior vagina. Tissue plane can be difficult, especially in patients with prior hysterectomy. I use the Foley catheter guide as a bladder probe. It's important to distend the vagina to provide a differential tension between the bladder and vagina. A deeper dissection allows for better anterior support. And as you go deeper, ureter can be at risk as you get closer to the trigone. Here's a bladder probe. Foley catheter guide we use as a bladder probe. So when attached to the Foley catheter, you can move the tip of the catheter any directions you like to, and then serve as a probe. You can see that right here. And this will help with the dissection in the event that you don't know exactly where the bladder is. The distension on the vagina help with dissection and make it easier for you to get the bladder off the anterior vagina. When you go deeper dissections, you sometimes will see the ureter. So it's important to keep that in mind so you don't injure the ureter during the dissection. And here is a clip of the anterior dissection, vascular vaginal dissections. And this is when it's done in patients who had hysterectomy already. And then so we get a bladder, we retract the bladder anteriorly away from the vagina. Just like with a rectal vaginal dissection, you want to keep the fat on the bladder and leave the vagina without any fat. And so right now I'm only using the retractor, and we'll go ahead and insert a probe on top of the vaginal retractor to give that extra distension. And that would make it easier to get the bladder off the anterior vagina. And then we'll go ahead and put a probe in here. Put a probe in there, and this will allow the dissection, make the dissection a lot easier since the bladder is even further distended now compared to before. And this allows you to do much deeper dissections. Again, traction of the bladder anteriorly is key. And then any intervening tissues will seal and cut and push away. And so I can do very deep dissection this way. When it comes to presacral dissections, that you basically palpate the sacropromontory and make incision of the promontory. You must skeletonize all the fatty tissues of the sacropromontory, and then you try the dissection from right to left so that you can preserve the hypogastric nerve if possible. If your dissection is too low, you get the bleeding from the sacral hollow. Too high, you may get bleeding from the left coming iliac vein. After finish the dissection, I typically would desiccate the middle sacral vessels to prevent bleeding. So if you start your dissection towards the right side, starting from the right side, you can preserve the superior hypogastric nerve during your dissection. And this will minimize constipation in the patient we are performing sacropexy. Middle sacral vessel can be quite large in some patients, just to keep that in mind, and so that you would seal the vessels or desiccate the vessels prior to placement of any suture or any tackers. The left coming iliac vein can be low in some patients, so give very little space for you to use to place your mesh, just to keep in mind that the location of the vein during your dissection. And here is a clip of the presacral dissection, field promontory, elevated peritoneum, make the incision. We'll continue our incision towards the little higher, and then we'll continue the incision towards our previous rectovaginal dissection. And this is I'm trying to make this as a video as least unedited as possible. We'll connect the dots towards our previous rectovaginal dissections. And so we have made that U-shaped incision on the posterior vagina. And that's basically completed the peritoneal incision. Next, we need to skeletonize the sacropromontory and get all the adipose tissues off. So we start off towards the right side, and this allows us to preserve the presacral nerve or the superior hypogastric plexus. So we reflect the peritoneum as well as the nerve towards the left side. You can begin to see the middle sacral vessels right there, and get all that off the midline. Make our incision a little bit bigger, extend it so we have better exposure. And here is our sacropromontory, and here is our middle sacral vessels. We'll go ahead and desiccate. That's the right common iliac vein, or branchial common iliac vein, right there. Middle sacral vessels. We'll go ahead and then desiccate the middle sacral vessels. Again, we'll keep our dissection off towards the right side. The nerve is preserved over here off the left side, and we'll go ahead and desiccate the middle sacral vessels. And then this will allow us to place the mesh without getting the bleeding. When come to suturing, it can account for a significant portion of your operative time. You just need a lot of practice to practice your suturing to improve your speed. It's important to distend the vagina to avoid bunching up the mesh. Do not suture or tag the sacrum if you don't see the bone. Okay, don't tag a suture through the fat. You need to know exactly where everything is. So if you don't see the bone, you're not going to see the blood vessels underneath. So, because the fatty tissue can be covering some of the blood vessels. So it's important to get everything skeletonized. For the vagina, we used delay absorbable sutures to suture the mesh to the vagina. We believe that it decrease the risk of mesh erosion. I use a zero Nova field, which is a permanent monofilament suture, to suture the mesh to the sacrum. To increase the speed, we use titanium tackers pretty much every time nowadays to adjust the tension of the mesh to be able, and also increase the speed of the procedure. So it's important to distend the vagina so that when you lay the mesh spread out nicely. Again, anteriorly also use a probe to distend the vagina, and this allow mesh to spread out evenly. Same here. So that it's important to get the vagina distended and the mesh will lie nicely on the vagina. When it comes to mesh tensioning, you want to leave the probe or vagina retractor in the vagina, allow the gravity from transdermal to work. You pull the mesh until you feel tension, and it slowly release until tension is no longer felt. In patient with a larger posterior anterior defect, it might increase the tension on the anterior mesh. For patient with significant anterior prolapse, and then it's in essence perivaginal defect repair become unnecessary in many situations. Here is basically securing the mesh using suturing. And then just tie it with a interrupted suture with extracorporeal knot tying or intracorporeal knot tying. Or can use tackers, which is much faster. You can apply all the tackers in literally seconds. And here is example of applying the mesh to the tackers. So we basically will adjust, put the posterior mesh on first, and then we can then tack it with a tacker. And once you put your first tacker on, so adjust the tissue, the mesh tension until then when you feel tension, then you give a little bit, and then you apply your tacker, and the anterior mesh is then pull over the posterior mesh. And in patient with a big anterior defect, anterior prolapse, you can tension it a little bit more tension on the anterior mesh, separate from the posterior mesh. So that way you can correct a lot of the anterior prolapse. And then you can just place all your tackers, probably 6 or 7 tackers, against the anterior longitudinal sacral ligaments. And this can be done very, very quickly, and secure the mesh on both sides to make sure that you know, when you place your attackers, make sure everything is secure, as you're not tacking into structures that you don't want to tag. So that is your tacking of the mesh to the sacral promontory. And then so we would also peritonealize the mesh, and we use like a purse string suture and followed by one continuous running suture. This is all video. Nowadays, I pretty much close all my peritoneum incision with V-lock sutures, 3/0 V-lock sutures. So first of all, we kind of make a purse string suture. This is a very old video, but it just shows a different technique. And so with the purse string suture to cover up the lower part of the mesh, and we'll leave one of the tag end long, and just cover up the lower portion of the mesh. So this would be like a single interrupted purse string suture. We'll leave the long, and then we can close the rest of the mesh with a running suture. And then this is all pre-tie, so it's making it easier. You don't have to tie any suture. And then we'll kind of run towards our post that we made earlier, just to speed it up. So then we'll basically tie it with what I call a helicopter knot here. So we use a needle as a way to kind of wrap around it. We can wrap it. And that's how close to the mesh. But nowadays I use the 3/0 V-lock for most patients. And that's the end of my talk. Thank you for your attention. I hope my videos provide some tips and tricks for your next procedure. Thank you very much. Thank Dr. Lila Maya again for this invitation, and I hope great success to this virtual conference. Thank you.
Thank you very much. A wonderful demonstration. He's indeed a great teacher, and today he's holding a huge position of vice president. So, dear colleagues, now we give the floor for the presentation by Professor Tikhomirov. Please, Professor Tikhomirov. Novel opportunities for prophylaxis, prevention, and treating surgical complications in gynecology. Professor Tikhomirov now has the floor. A very good afternoon, distinguished colleagues. My presentation will discuss novel opportunities to prevent and treat surgical complications in gynecology. May I remind you that recently a well-known pundit of obstetrics and gynecologist, Vladimir Fedorovich Snegiryov, at the end of his life was writing that the best operation for a woman is an operation that was never performed. So what he meant by this is probably indeed that she may see some complications. The matter might be about post-op setting, probably post-op morbidity, but in modern conditions when this truly is needed for mini and micro-invasive approaches in surgery, in gynecology, when this is thorough preparation of the patients for the operation, when it is in line with the pretty safe anesthesiology and work of the anesthetist, when during this operation we may use modern suture material, where we use modern, let me put it this way, energies such as laser energies. When we use radio knife, we could use anti-adhesive barriers, and in general, this is a pretty rapid discharge of patients from a clinic, and surely a broad spectrum of antiseptics and antibacterials to make sure we prevent and correct possible complications in post-op setting after gynecological interventions. But I, in this sense, must tell you that when we are talking about gynecological operations, the thing is that a woman should be given enough information about potential adverse outcomes. And this is a requirement that is based upon the code of interaction between patient and physician, and we should fully comply with that in our country. So when we talk about potential adverse outcomes, you can see that this may be infections, this may be pretty high blood loss, all sorts of perforations. We may see adhesions that may lead to pain and impaired reproductive function, and recurrences when they would see the need for further surgical interventions. But you will later see, when I talk about potential adverse outcomes, I still highlighted infections in red. Why? Because today, of course, these operations are micro-invasive, less invasive, using all aseptic rules and antibiotics, but these gynecological operations, nevertheless, are operated in greater numbers than was ever the case. So modern gynecology, one could be even called aggressive gynecology in this sense, because we operate more often. But they are the main reasons that do not allow us to decrease the level of morbidity, post-op infectious complications. You can see that this may have to do with higher patients' age that we operate upon, although I told you we see also growing number of patients, greater patient flow. We may use drugs with immune suppressive activity. we may see more sophisticated and complicated interventions. This may lead to antibiotic resistance flora. This is a global problem about the superbugs. And again, the main reason that I highlighted in red is the growing role of mixed microflora. What I want to tell you that what we did, large-scale study, showed that 45 to 86% of patients in operative gynecology, look at the huge range, 45 to 86%. It depends on whether it is elective surgery or emergency operation. But still, they have underestimated or something that is being formed immediately after the operation. Even when we first looked at the smears, at Pap smears and other studies about microbiome, but we see a microflora impairment which may give rise to infectious complications in post-op setting. One should highlight that about 80% of all post-op complications have to do with, are considered to be purulent and inflammatory. So our American colleagues quite rightly show the risk of infectious complications in all kinds of operative interventions and the feasibility to do prophylaxis. They would made up this table based upon the large number of material that they studied, where they divided operations into the so-called conventionally clean, contaminated operations, and dirty operations. I suppose this is what quite clear to the audience what we are telling about. Risk of post-op infectious complications and morbidity, depending on their grade. As you can see, beginning with clean and ending in dirty, we see the risk of these infectious complications rising. May I highlight that even when we have so-called clean operations, where we can see micro-invasive interventions, there is no reason to expect that it would be some substrate that we left in place that would be posing risk of post-op setting complications. Still, this risk may be anything between 2 to 5%. So the authors highlight that even in case of clean situations where we are doing clean operations, it's still viable to do prophylaxis. So, may I give you several case studies of what we use right now, how we optimized approach to this micro-invasive and very clean operation, such as embolization of the myoma, uterine myoma, which recently, as this slide shows, we're doing via radial artery. Of course, this cuts down the risk of thrombotic complications, because as you can see further on, there is no need to apply bandages of the right unguinal femoral area where we used to puncture the femoral artery. And this dressing will stay only here, where the radial artery is, which in 2 hours would be completely removed. And this woman will be absolutely mobile, can move, can go around. This certainly cuts down the risk of ascending infection of the urinary tract. Why? Because there's no need whatsoever to put in place a catheter for urine evacuation. The woman will not be lying in bed, confined to bed for 12 hours, which was the case when we did the puncture of the femoral artery. But nevertheless, if the patient was not properly prepared and a septic necrosis that we count upon in the case of operation, we may see cystic cavities forming, something what we see in this picture with purulent content. And may I say that this is happening even after such a clean microinvasive operation. when we do embolization of uterine arteries via radial artery. So surely we should have quite a robust and reliable technique to ensure we will have aseptic necrosis of the fibroids, which would lead both to favorable post-embolization, post-op setting, as well as for more rapid regression of these nodules. May I highlight it that the patient after this procedure, in point of fact, after this sort of intervention, microinvasive operation, will be discharged home within 16, 18 hours after the intervention. Indeed. Today, I'm giving you examples about embolization, but may highlight the same early discharge is typical, well, literally within 24 hours, is given after modern laparoscopic interventions, as well as after operations in the pelvis, which maybe this is what we do in gynecology. And this is, may I highlight it, it's very important to do this. It's known that the precondition for post-op infection are first 3 hours from the time when a bug probably got into the wound. So if we use antibiotics after these 3 hours expire, is a bit too late. But it's not justified to administer antibiotics well ahead of the operation. Why? Because it will never ensure pre-op sterilization of the patient, and it will promote the risk of antibiotic-resistant bugs, and this risk rises rapidly. That is why, as a rule, intra-op use of antibiotics, broad spectrum, this is something that you see in our clinics for most part. They are ceftriaxone, that is indeed a drug, a third-generation drug, and the clinical observations have determined that the total length of post-op antibiotic therapy should be for some 10 to 14 days. But of course, the patient has to use per-os oral tablets. So this is intra-op, we use ceftriaxone, but given that we discharge our patients early now, the patient would switch to pills, antibiotics and pills. So this oral tablet could be used a combined antimicrobial antiprotozoa drug with a broad spectrum of activity, which may include ornidazole 500 milligrams and ciprofloxacin 500 milligrams. It belongs to pharmacotherapeutic drug of antimicrobial combined drug. And this is where I want to highlight it, because indeed, basically all microorganisms, including those that belong to opportunistic flora, they may be involved in pathological infectious process post-op setting. The importance of using combined antimicrobials may be determined as exactly by this. More often than not, we are seeing mixed infection that is provoked by several pathogens and may have a more manifest clinical presentation. It increases resistance to antimicrobials and poses greater danger, of course, for women who undergo gynecological interventions. Broad of activity of ciprofloxacin is well studied. You see their gram negatives. Bacteria where we see E. coli, Klebsiella, Cytobacterium, as well as Neisseria. They're also gram-positive bacteria. Of them, the most prevalent are exactly the ones that may provoke purulent and septic complications, among them Staphylococcus species, Streptococcus species, as well as intracellular pathogens such as Chlamydia trachomatis, They are mycobacterium, so mycoplasmic infections are certainly relevant here too. If we speak about ornidazole is active against Trichomonas gardnerella and Mobia histolytica lambli, as well as obligate anaerobic bacteroides, including other gram-positive microorganisms. And this is where I would like to show you excerpts from the patent of this combined drug, or Cepol VM, where it highlights in yellow that pilled form, solid form, which we're discussing in this invention, seeks to treat and for prophylaxis of the infectious and inflammatory diseases of the pelvis, and may be used as prophylaxis in post-abortion setting and post-operative setting. Once again, may I highlight that the both components of these drugs are part of both European and Russian recommendations and guidelines, both in urology and gynecology. In terms of inflammatory disease, this drug was patented in 2016, as you can see by the Eurasian Patent Agency. And what is important here is that the combination of ciprofloxacin and ornidazole, with at least two excipients in the pill form, is stable and has a very potent antimicrobial mechanism of action. So, mode of action. So when we seek to prevent post-operation infections, what I saw, this is the only combined drug in Russia, fixed drug combination, FDC, where these components with proven stability, with high efficacy against the pathogens, well-recognized combination when we could use both components in clinical guidelines with true bactericidal, which is not dose-dependent effect, and additive nature of both components that covers a very broad spectrum of gram-positive as well as gram-negative aerobic pathogens and all anaerobic, as well as protozoa. In conclusion, may I say that the new era of combined prophylaxis and therapy of post-op infectious complications in gynecology is with one drug, one pill twice a day, and fixed dose combination. This indeed stands for moving ahead, which on top of that would ensure better compliance by the patients as well as pharmacoeconomic savings. Thank you very much for your attention. Thank you. Well, dear Professor, thank you very much, Alexander Leonidovich. That was something very useful for us to listen to about novel trends and novel drugs and new ways to treat and prevent complications that have to do with infectious complications. So, dear colleagues, we only need to have an in-house organizational event. It will be seen as review of novel clinical guidelines. This work on novel clinical guidelines, I've done it as I talked to all chief specialists of Russia. And I'd like to say that indeed, the Ministry of Healthcare, chief specialists of the federal districts, chief specialists in major big cities, they all were involved. Trust me, every line in clinical guidelines was literally considered by us line by line. And for that matter, in a number of cases, we had heated discussions. Some people would go for more, for less aggressive care. Others say we are now looking at onco-risks. We should consider more globally. So I would like to see my colleagues, Galina Evgenievna Chernucha, who's in charge of our endocrinology center, Natalia Vladimirovna Artemuk. We now see that she's with us, Victoria Alexandrovna Krutova from South Federal District, Maria Igorevna Yermolinskaya. And honestly, there's a lot of work that was done Well, it is not AI, it is natural intelligence. The most serious and responsible persons in this country. Our country has this network of chief specialists of the federal districts, and with them, they have chief specialists of the regions. So clinical guidelines should be considered with the view of the legislation we have in place. There's major guidelines and recommendations that are given abroad by ECHO, by E-Royal, Royal guidelines, as well as CDC, as well as WHO recommendations, as well as FIGO. So as we looked at each clinical guideline, we would really put on the table whatever we have. And we were reluctant to miss some even minor detail. As of today, we succeeded in what we did. 10 guidelines, 10 recommendations, dear colleagues, are offered to your attention. They were adopted by the Council. What does it mean, the Board for Research and Practical Research? It means that the task force has finalized them. We discussed it both online and offline. We further referred them to, it was all built and was all posted online on the website of ROAC. Everyone who was keen and thought it necessary would make their own amendments, and we considered them all, reviewed them all, and this document in the long run was then referred to the Ministry of Healthcare of Russia. Should I say that unprecedented support and help was given to us by Oleg Semyonovich Filipov. You do know, when needed, Oleg Semyonovich, he becomes so tough, so much principle-oriented. He realistically is a connoisseur. And this is the least I can say of all these fine points and nuances. He combines both a government official of top record who knows all the laws as well as a clinician. I've known him for many, many years. He, for that matter, was a brilliant surgeon. He is perfectly aware of Aubergine. So this document, or rather these 10 recommendations, are what we drafted. Well, good afternoon. I'm sorry, we lost him. Vitaly Fudge. I just saw him, Vitaly Fudge. Hello, please don't stay with us. Every recommendation was drafted in line with these legislative documents, methodological guidelines to evaluate the rationale, scientific rationale, including guidelines, glossary of clinical guidelines, all sorts of executive orders, they each have their numbers, the template for the guidelines, and immediately they were drafted with providing for the medical services that were in line, a list of medical services. Clinical guidelines necessarily used the names of DSGs and pharmacotherapeutical drug classes that are recommended by the WHO, or we would use INNs or chemical names of the drugs.
And in case of the lack of the trade name will be used of any drug for medical use. We did not violate any laws existing in Russia because today's clinical recommendations are what we use to protect our patients. That's a good security for us doctors. Long is gone the time when in one hospital such methods as developed by one professor could be used. In the other hospital, the methods would be different. Clinical recommendations are the document that will provide unified help for our patients and will be acting within the framework within the legal framework which unified the care for our patients. Well, as for recommendations, or clinical recommendations are accompanied by references. When we say the word recommended, there will be references to the source of literature, as well as the level of evidence or the level of proof of the recommendations in accordance with the unified scales of assessments of these most important criteria. We never had a situation except 2 cases when we used the 2-3 times, and I will tell you about this later. And we used a pound key when there are no drugs alternative to those indicated here. That's under the pound key paragraphs. Clinical recommendations of uterine myoma. I talked to my colleagues, our specialists, and they gave me carte blanche here not to consider all these issues in detail, because these recommendations are already stored in the cloud of the Ministry of Health. You can look through them. As for uterine myoma, the recommendations were quite fresh. They have conservative and surgical treatment. As for surgical treatment, tranexamic acid, NSAIDs, progestogens to treat abnormal uterine bleedings, levonorgestrel in the form of intrauterine device, COCs for those patients who would like to continue to take contraceptives, GnRH agonists. Surgical methods of treatment are also included here, organ sparing techniques, and you can see hysterectomy and vascular embolization of uterine arteries and superselective ablation by focused ultrasound, MRI controlled, as well as different approaches such as laparoscopic approach, a laparotomic vaginal approach, and of course hysteroscopy when we talked about submucous uterine myoma. Clinical recommendations on endometriosis, we discussed them many times. Here we don't have any doubts. We have reached full consensus as far as chief specialists are concerned, as well as the members of the working group. Conservative treatment will be done by NSAIDs, neuromodulators in case of neuropathic pain, progestogens, COCs, which are not a treatment, but on the other hand, they can be used for contraception and to reduce the pain syndrome and to plan a family in the future. GnRH agonists, levonorgestrel in the form of intrauterine device, and donazole. Donazole is not being used, and now it was used way back in the 1980s. There was a time when I put it on this list, but since we still use it from time to time, well, it says here the use is limited. Well, endometriosis and fertility, endometriosis in adolescence, another section, endometriosis in the postmenopausal period, endometriosis and cancer, clinical recommendations on cervical intraepithelial neoplasia, erosion of the uterine cervix. Dear colleagues, we considered all these issues many times together with oncologists and without oncologists, with endocrinologists, with primary care physicians, and that was a very extended working group. So the result is we recommend a cytological exam and administer such drugs to all women from 21 to 65 years of age with the interval of 3 years in order to, and also to conduct the cytological examination on patients younger than 21 years of age if she has sexual life for 3 years. Well, liquid pathology can also be used, and so we made a major step forward here. we recommend you do molecular biological tests of the cervical canal for HPV in order to identify the risks of cervical cancer. This is a screening method. It is recommended for all women over 30 every 5 years, and in HPV negative women, and every year in HPV positive women. We recommend we do extended colposcopy to identify changes of the cervix, if there are visual changes of the cervix, and if there are abnormal smears, or in case of positive tests for HPV, and also to identify the site of the biopsy of the cervix to verify the diagnosis. Some foreign guidelines, well, is not mentioning extended colposcopy, but we do not want women to suffer from cervical cancer, especially when we're talking about young women. And we also had some other additions. Well, differential diagnosis is recommended depending on the severity of the lesions of the cervix, especially when we have a proliferative expression of P16, Ki67, when we use immunohistochemistry, if there is such a possibility, because sometimes immunohistochemistry may not be performed there, but that means if there is the opportunity, every specialist should do immunohistochemistry. And prevention of cervical cancer, as it was mentioned after 2014, primary prevention vaccination against the human papillomavirus is aimed at girls ages 9 to 13 and up to the onset of sexual life. We have presented the detailed screening strategies of cervical cancer. Well, again, liquid cytology, tests for HPV and vaccination are mentioned here. Should be managed to do it will be remembered by all Russian women. Clinical recommendations on benign dysplasia of mammary gland. Well, again, you can see some clinical recommendations, and you can see that we've done a great deal of work here. As for diagnostics, well, X-ray mammography is recommended for patients with nodes of mammary gland, as well as the screening from 40 to 75 years of age. Ultrasound for young patients is recommended, and for pregnant women and lactating women, it is recommended in the BRADS system. Non-medical treatment, medical treatment and surgical treatment are recommended depending on the situation. Prevention, methods of common prevention, prevention of breast cancer in patients with benign breast mammary gland dysplasia, also monitoring of patients with the dysplasia of mammary gland, and screening for breast cancer. Dear colleagues, I must finish this, although all these things are stored in the cloud, but I think everyone should hear this online from the chief gynecologist. And well, we did our best for you. The clinical recommendations of ectopic pregnancy, conservative treatment includes methotrexate, because there is no alternative. Methotrexate is used off-label here, but we were allowed to put it on the list here. We provided our justifications in according with COG and ASRM recommendations, and human immunoglobulin can be used here in case of RH0 in order to prevent, well, ectopic pregnancy. And we should not ignore those principles which are used abroad. Operative treatment of rare forms of ectopic pregnancy should be done in tertiary hospitals. We're talking about cervical pregnancy, pregnancy in niches, in scars. These young women often cannot get proper assistance, and they can lose their uterus. We did have cases like this. Anesthetics and intensive therapy are indicated for this special group of women. Clinical recommendations in terms of female organs prolapse. These recommendations were developed together with the Association of Urologists, because we think that in this case, as for pelvic organ prolapse, and a lot has been mentioned about it today, and pelvic organ prolapse is not just the uterus prolapse, it's the problems with the ureter, with the bladder, with the assessment of all these compartments. And that is why we decided to use the specific classifications. Treatment can be conservative or surgical, depending on what indications we have for this or that type of treatment. Clinical recommendations regarding abnormal uterine bleedings. Well, in most cases, as for conservative treatment, tranexamic acid and NSAIDs, also iron-containing drugs, levonorgestrel in the form of intrauterine device, combined oral contraceptives, COCs, which already showed good results in terms of stopping bleeding, progestogens, GnRH agonists. Nothing is left behind. As for surgical treatment of abnormal uterine bleedings, well, there are sections related to adolescence in the period of post-menopause, while treating with the tamoxifen, and together with the menopausal hormonal therapy. Here I'd like to thank all endocrinologists, all chief specialists. Galina Chernukka is over there, and her department did a lot to contribute to this, as well as my favorite specialists from St. Petersburg, Marina Renmalinskaya, Vitaly Bezhiner, Natalia Artemuk, Professor Bialo-Krenitskaya. We all fight for making this document more specific, more concrete, and we even talked about all of these aspects in detail regarding abnormal uterine bleedings. Well, clinical recommendations on treating endometrial hyperplasia. Well, endometrial hyperplasia is the process that can be accompanied by cancer. That is why I try to increase the volume of examination. My colleagues tried to stop me, saying, well, no, pipe pill is quite enough, but we took a special stand here. And as of today, well, binary classification of the WHO should be used of 2014. So it's the same in an updated version of 2020. According to this classification, there are endometrial hyperplasia without atopy and endometrial hyperplasia with atopy without any other additional names that can be confused, or someone might not properly assess them. Well, the management of patients with hyperplasia without ATP or with atypical hyperplasia of endometrium. Vitaly Fedorovich from helped me a lot, but the Kolokov Center, of course, was actively involved, and thanks to that, we developed those recommendations. I'm also including myself because I tried to be the major cop in this issue. I'd like also to thank Galina Chernuka clinical recommendations concerning such issues as inflammatory bowel disease, and we looked at all options that can be used here. Dr. Pripyatnevich helped us a lot, as well as Dr. Shabanova, as far as pelvic inflammatory diseases are concerned, and virtually every day they try to fight for expanding the methods of examination, including the use of modern antibiotics for treatment, but we reached a consensus. Our women should be treated properly, taking into account the flora, sensitivity to antibiotics or resistance to antibiotics, and the use of all possibly existing drugs with the opinion of a clinical pharmacologist. Polycystic ovarian syndrome, well, and clinical recommendations to treat it, well, that was a very difficult situation, especially from the point of view of a surgeon, and especially when we are dealing with complications of the sclera. Professor Saturina helped us a lot, as well as Natalia Vladimirovna. And of course, the Kolokov Center was actively involved here. It goes beyond any saying, as well as Marina Igorovna and Yelena Andreeva, practically together with her staff, made a significant contribution to the development of those clinical guidelines. As a result, we can say that women who weigh 150 kilos, it's difficult to treat her, but nevertheless, we should modify, change her lifestyle COCs. Also, we can achieve a good cosmetic results, normalize the cycle, COCs and anti-androgens, metformin. And there is a pound key here because there is no indication to use metformin directly, but it is included as a second line of therapy in patients with polycystic ovarian syndrome and irregular menstruation. Clomiphene as a first line therapy to treat anovulatory infertility in patients with polycystic ovarian syndrome, stimulation of ovulation by letrozole. We don't have a direct indications for the use of letrozole, but we looked at different global recommendations and guidelines, and we said why our women should get a drug which is twice as inferior as compared to letrozole. So we put letrozole behind the pound key. So stimulation of ovulation by letrozole is done with a dose of 2.5 milligrams from day 3 to 7 or from day 5 to 9 of the menstrual cycle. In case of lack of ovulation in the next cycle, stimulation, the dose can be increased by 5 or to 7.5 milligrams per day. That's the maximum concentration, but not more. Surgical treatment as the last option. It's a cry from the soul, ovarian drilling, and bariatric surgery in patients with obesity when nothing else helps. Well, believe that these recommendations were adopted through heated debates, amenorrhea and oligoamenorrhea. Practically, there are problems with hypothalamus amenorrhea caused by the anterior lobe of pituitary gland, ovarian problems, uterine amenorrhea, medical, non-medical therapy of treating patients with fertility and amenorrhea. AMH level should be assessed once a year during a 5-year period in mothers who had early menopause or premature ovarian failure in order to detect the subclinical forms of the disease at the early stage to prevent infertility. And here I'd like to say that I wanted to pay special attention to this phenomenon. We had about 89 or 90 patients with POF, premature ovarian failure. Well, in some cases, women may have flushes when they have premature ovarian failure, others do not. In some cases, well, premature ovarian failure can be combined with endometriosis, although AMH is 0.05 or something like that. But I wasn't allowed to do it. And maybe there will be time when Natalia Vladimirovna will allow me to do it so that our women, at least when they turn 18 or 20, could be examined totally in terms of the risk of reproductive system failures, when they don't care about their reproductive system because they have different preferences at this age. But maybe thanks to that, we could identify those patients who would not have any premature ovarian failure, and from early ages, they would know that they should protect the ovarian reserve. Well, clinical recommendations on menopause, and this was done by the department of Professor Chernucha and Svetlana Ureneva, together with Professor Andreeva and others. Well, also folks from Siberia who contributed a lot to this, but everyone was working on that. The Southern District, Victoria Alexandrova, and the Northwestern District, such as Professor Bergenar. Well, but I wouldn't like to enumerate all of them. Everyone made a significant contribution to these recommendations. We had a discussion, and those recommendations contain conservative treatment, well, the menopausal hormonal therapy, also what is meant by replacement menopausal therapy, non-hormonal treatment, and different scales to do the risk assessment, and many other things that should be written into clinical recommendations. Well, clinical recommendations concerning the dysfunction of the adrenal cortex, androgenital syndrome. We did it together with the endocrinology center and the staff of the Kolokov Center who deal with endocrinology issues. I forgot what the name of this person is. Professor Sazonova and the department of Helen Andreeva and many other specialists from the Center of Endocrinology, Professor Melnichenko, Professor Dedov. These are very complex clinical recommendations. Well, medical rehabilitation, prevention, and dispensary monitoring of adult patients when there is a shortage of hydroxylase 21, well, pregnancy in case of this condition, and well, no one has doubts about it. Well, dear friends, I decided to use these recommendations and to read these recommendations today. Well, in terms of congenital adrenal cortex dysfunction. And today we have the 34th Congress, and I'm sure that we should provide the best updated data. And also, I would like to express my gratitude to those who participated in the development of these guidelines. Those who didn't have a chance to develop these guidelines, well, believe me, Well, you will have a chance to do it later. Keep working. Guidelines are what is important for our children, our grandchildren, and we'll be able to achieve success in our endeavors. Thank you very much, dear colleagues. If you would like to say something, you're welcome. I also asked Victoria Krutova to say a few words, maybe for 10 minutes, regarding the work that we're going to do in the future. Order 1130N, what is meant by this order. Once again, I respect you very much, and especially those people who has been working with us on this issue through the Ministry of Health. Will we give Victoria a chance to speak or later? Natalia? Maybe Victoria could talk for 10 minutes. Is 10 minutes enough? Sure. Yes, I'll try to be in a nutshell. Just in a nutshell, then we say goodbye to each other. Thank you so much, Leila. Well, that's our main document, Order 1130N, to provide obstetric and gynecological assistance in Russia. It's a thick document, although it's the third update. We can see that it has a limited time frame. It went into force in 2021 and will be working until January 2027. We are planning to introduce changes into this order. That's why, together with colleagues from the southern region of Russia, we came up with a proposal regarding introducing changes or amendments. The amendments were sent to the Ministry of Health because it took us a lot of time to discuss the document. But when we started using it in practice, we encountered different problems. And after the introduction of changes, after updating the document, it will be easier for us to use this order of the Ministry of Health. Well, here we mention strategy and tactics, but in each region of Russia, there should be another regional order on the basis of our order 1130N, because otherwise it would be difficult to do any activities in a particular region. On May 13th in Krasnodar, there was a meeting with the chief specialists out of 8 regions. 3 regions do not have the regional order. Unfortunately, maternal mortality levels leave much to be desired. Colleagues, by the end of June, we expect the local departments of health will adopt such regional documents. First of all, as for women's clinics, they should be ranked according to their levels. Urgent delivery rooms should also be included here.
And we must approve legal documents, how to improve. Sorry, the sound is gone. The sound is gone. Не знаю, к сожалению, переводчикам перестал поступать звук. We do hope that this will be taken into consideration. Criteria of quality of work have been identified in this document, and the internet clinics can be facilities for the teaching institutions. Well, they should have an open type reception. We realize that in times of the pandemic, if it is over, maybe it will not be over, rather than we'll have some easing restrictions. But now we'll have to live under those new conditions, and the reception, the open type, where we can put in place protective screen. First time of the checkup should necessarily cover 80% of female population. We have bimanual examination, mammogram of both breasts into projections with 2 readings of the X-rays, HPV test, as well as liquid test. We also contacted Ministry of Healthcare so that women in groups 1 and 2 should be recommended to go to the resorts, so that you have prevention of gynecological diseases, first and foremost, gynecological diseases. If Order 857 has identified 5 groups of, depending on the woman's health condition, now we identify only 3. Further management, once the woman has been diagnosed with the disease, is done in line with the guidelines. Medical help to women to identify breast pathology is done by the gynecologist, and each specialist should be trained going to upgrading course in line with the license requirements, anything by 16 hours or more. Further attention is paid to day hospitals. Previous executive order meant that the woman should be staying there anything between 3 to 6 hours. Now it is 3 to 6 hours instead of formerly 4 to 6. So they go in 2 shifts, and all those women who lose the productivity cannot go to work, but at that they do not require round-the-clock observation and care. Executive Order 1130, in-hospital assistance is given in medical organizations who, depending on their bed capacity, are divided into 3 groups. This also happened for the first time. It clearly describes which are group 1, which is group 2, and group 3. Group 3, other than indications, has identified 3A and 3B. 3B are federal medical organizations. There is a typo here. It's 75, but in point of fact, it's 74. Article 74, which identifies the indications for hospital admission, where one can hospitalize the patient when identified it as federal institutions that hold and provide medical care as part of clinical approbation of ways to prevent, diagnose, and treat and rehabilitate, usually the faculty of universities, teaching universities, or fellows and researchers of institutions do clinical approbation, and then which is generally adopted in clinical practice. We have described the procedures. This is where we had to defend our position when we talk to personnel, the number of office positions, number of beds, gynecologists and obstetricians. The previous version had only 1 physician per 10 beds, but nowadays per 12. Nowadays, it doesn't apply to perinatal centers and medical organizations of level 3. This only applies to levels 1 and 2. This is which we could defend because surgeon, this is what it works, 1 office position per 12 beds. And this meant we would either need to cut down the number of staff positions, or we would need to cut down the number of beds. What to do with underage patients with gynecological disease in remote areas? And it clearly says that primary specialist medical care could be provided to underage girls in antenatal clinics, but the decision of government of the constituent entities for up to 14 years, the girl should go to pediatric clinic, but from 15 to 17, she should go to antenatal care clinic. Obstetrician and gynecologist should do it, or pediatrician or somebody else. As to providing to underage patients prophylactic examinations, that was done at 7 and 12. Now it is 6 and 13 years old. And when we do this prophylactic examination at 17 now, when conditions are in place, we need to do cytology of the smear. Well, legal representative has to be present. I'm sure we will be facing some trouble here. A number of pretty serious questions as to by the parents. So we now contacted the Ministry of Healthcare when we suggested that to leave this in place and now put it into the new procedure, because it is particularly relevant when the question is about pregnancy in an underage girl, especially under 15, or when we diagnose some diseases that require an operation, amongst other things. As to providing medical care to underage patients when we need to remove ovaries, fallopian tubes, and uterus. If it is an emergency, we do it in a surgical by pediatric surgeons or surgeons, but this is where we need to be endorsed by the obstetrics and gynecologist doctor. If you cannot consult in person, then we use telemedicine technology or remote counseling and consultations. How do we provide medical care to underage patients? This can be done in the hospital if this medical organization has specialist license for pediatric surgery or general surgery. We deleted pediatric clinics only, which was the wording. As to pregnancy termination, special requirements by the license and the new government by law said that this license is something we still retain. I'm sure all the constituent entities have taken care of this. And the organizations that provide abortions, they have specialist dedicated license to do so. Examination and preparation of patients for medical care in termination of pregnancy is also based upon clinical guidelines, and in case of counter indications, the board will have to consider, given the gestational age and the place where they will be terminating a pregnancy. Dear colleagues, thank you very much. And with your permission, may I congratulate all of us as these professional standards of the obstetrician and gynecologist. I would like to thank Leila Vladimira because she led the efforts when we were drafting it together with our center. This is a document we really worked hard on, but this is the main document as I see it, because this is what we use in residency and will now continue to prepare them on the postgraduate, on our upgrading courses. Thank you for your attention. Thank you so much, Victoria Alexandrovna. Dear colleagues, dear guests, could we have Zoom picture? I think I've said it all. The only thing I never mentioned is that, dear colleagues, we are all aware that COVID so far is very much reality. It never went away from us. We reached a plateau, so do what you can to make sure, though, that our audience are vaccinated. I invited Professor Chervenak on purpose. They no longer have this question about whether to vaccinate or not. Surely we don't have regulation about how to vaccinate pregnant women and so on, but I'm sure that we will be gradually addressing this question, especially for those who have some risk factors. But after, of course, we have talked, I do believe that I'm a person who dislikes vaccinations and I'm dislike being treated, but so many good people left us because of COVID. We don't want to be the reason for this disease. We don't want to see what we are witnessing today in terms of complications after COVID. So yesterday we saw an article that was published on the Journal of Problems of Reproduction. Delivery outcomes in patients with COVID, 891 patients. It will be a good doctoral thesis. They're now studying it. Placenta is tested in all 891 patients. Review article was also published on vaccinating pregnant women. Well, so to say, given that what are the different societies, what is their position on this? And immediately a law has been adopted from 12 to 15 for our adolescent, teenagers, that they will be vaccinated. Also, since a lot of requests were made, whether we provide contraception during COVID, how we treat menopausal, how do we provide hormone therapy, what do you do about obesity, since what comes next to me was Yelena Andreeva. We wrote 3 review articles on this, where we involved all those. So issue number 3, problems of reproduction, is very much on the shelves. Please look it up. I'm sure it will be interesting. So I'm waiting for your comments, and then we'll be wrapping up words. Please begin. Can I start? A very good evening, dear colleagues, and Leila Vladimirovna. Thank you very much for giving me the floor, for making it possible for me to say a few words. I'm so happy that this difficult work is over for us, but it is highly useful, of course, for physicians. Why? These clinical guidelines, they are pretty much simple, laconic, succinct in their formulations. We put little there. Our physicians are not very keen on reading thick tomes. So 1, 2, 3, 4, I believe, especially for young physicians, this is very helpful. All clinical guidelines, this is something that algorithm of care, algorithm of action, so that we shall commit fewer errors. Because we are seeing our patients, I'm telling to my resident doctors, 80% of patients are referred to us because they were not properly investigated and were receiving therapy for the wrong disease. For our physicians to be guided by, not by Western, but by our own protocols, this is surely great. It's great that we adopted Vitrazole, which we fought for so much, because everywhere across the world this drug has been effectively used. We now say different place for metformin. We were looking at a typical hyperplasia of endometrium. Who should it be? Should it be a gynecologist or multidisciplinary boards should be taking this decision, involving all sort of specialists? I believe as of today, they got what they got. We took part in 4 clinical or maybe 5 clinical guidelines elaboration. I believe they're now optimal. They're not overloaded. They're great. So congratulations on this work we have performed. And I'm so happy that we were involved. Thank you. Alina Igorevna, thank you to you. Indeed, you've done, your personal contribution is invaluable. Then ladies, and please take your turn. With your permission, Leila Vladimirovna, then I will take the floor. What I want to say that last year and this year, we had 2 very important years that helped us revise a huge number of guidelines, executive orders, procedures, triage instructions, and you name it. This is a huge bulk of work done by a group of people that Leila Vladimirovna, you led, were it not for your energy, were it not for your activity, were it not for your productivity, because surely I know that all these guidelines were read from A to B to Z, and if we took part in 5, 6, you took part in all the versions, revising all the versions. So whatever is being published today is what we owe to you, a lot of work that you've done. Thank you very much for involving us. We try hard. We may be making some discoveries for ourselves when we are writing these guidelines for one another, maybe. But surely for our physicians, we keep remembering that these guidelines are becoming something they should be guided by for our physicians. And as far as I know, they will become collated by the mandatory insurance so that they will pick up the bill. So it has global importance for the country at large. Thank you very much. So I would like to thank you for this opportunity to take part, to read a lecture today, talk at the evening at the expert council, and I do hope we'll continue our work together. Thank you, dear colleagues. Natalia Vladimirovna, please, would you like to share from far away? Leila Vladimirovna, dear colleagues, I would like to thank first of all for the invitation to talk to you and possibility to take part in this collective piece of work. In such a representative team, it is indeed a great honor, but the work that you have done is huge. It's so important. These guidelines are first and foremost today in our legal space. It is a matter of security and safety, not only safety for the patient, but also security for doctors. And it's great that gynecologists today have 10 guidelines, but the next step is also very important because these guidelines are based upon standards of care. And we would very much want our economists to hear the professionals speak up. And what we suggest in these guidelines, it is something that should be covered by state guarantees. It has to do with our girls, about endocrine problems, about infertility and many other factors. So I'll put it this way, as we're waiting for further measures, because we have done what we did it, the physicians are now fully armed, but the next stage is the economic component. Thank you, dear colleagues, to all of you. And I wish you all to continue working at this Congress and have a productive meeting. Thank you very much. Now, please say a few words. Arrivederci, who would like to say parting words. May I, dear Leila Vladimirovna? I'll be brief. First of all, it's a great honor indeed to be involved, to be part of your team. As Yelena Nikolaevna highlighted, without you, these guidelines would be non-existent. They would have been impossible. And indeed, fantastic amount of work that you did. And I also like to point out, it is surprising, but you found for every amendment, for every change you suggested, you were very, very, very tactful about this. And even if you disagreed, you never flatly rejected it. And it was all based upon evidence-based medicine, which I think is great. Thank you. And listening, why am I asking you these questions? You will be just praising me. It's not really good. Bizhanar, please. Leila Vladimirovna, You have one gentleman among all those who stayed. Well, thank you very much. Are you happy with the guidelines? I'm very happy about them. Yes, and what I want to say that we're very grateful to you. Can you hear me? Can you hear me now? No, we cannot hear you. Then how can you read me? The interpreters can hear me. Please, yes, it's all on. We cannot hear anything, sorry. Sorry, we cannot hear you. The interpreters can hear. Can you hear me? Can you hear me? You cannot hear me. Dear colleagues, thank you very much for all you've done. It's not that we are just a team. We now have solidarity. We all fight for the lives of our patients. Thank you very much. Vitaly Fyodorich don't be upset. He invites me on the 16th to travel to St. Petersburg. I may well travel there. Thank you very much. All the best, dear colleagues. Enjoy your work at the conference. I'm sure you will enjoy it. Thank you. This meeting adjourns and goodbye.